were conferred. So this committee put down everything objectively, and then they selected 9 recognition, and these are the people who had done outstanding work in their particular specialty. So we start with the proceedings. May I request Dr. Talwar sir to kindly come to the dais. Dr. Kar, CEO Mangalagiri and Bhopal, and Dr. Sanjeev Sinha, our professor from AIMS in the Department of Medicine. So I request all the RAE recipients to please help us. We have kept 15 minutes for the presentation, and we request the chairpersons to kindly make sure that each speaker adheres to the time. They have so many things to present because some of them are presenting last 60 years of their academic contribution. So my humble request to all the 3 chairpersons is that please ensure that they adhere to the time. Right, sir? And we will give you a small temple bell. At that you can just put it. And humble request to all the recipients.
Disciplinary impact on evidence-based surgical practice. Sir, we invite you to give your lecture, sir. He has written a lot of books on breast cancer, and I got the chance to read all these books on breast cancer. And so many of lectures I attended. Let's listen to sir for his lecture on this evidence-based surgical practice.
Thank you very much. Good morning to everyone. Professor Behera, Chairperson, ladies and gentlemen. I am grateful to the NAMS for giving me this honor and this chance to have interaction with you all. I'm going to deliver the lecture in memory of Colonel Sangam Lal, who was the professor of surgery in AIIMS, Delhi. He was one of the founders of this NAMS. He was president of Association of Surgeons of India. Because of the time limit and everything, I'm going to speak to you my journey through world of surgery. Surgeons are unique breed of medical professionals at the highest pedestal, hardworking, distinguished, smartly dressed, not scared of politicians or bureaucrats. Their performances are result only, and they are the only medical persons who can draw out a patient from the jaws of. I had my schooling in Tilokchand Jaina School, and here I learned the discipline of hard work, sports, extracurricular activity and everything. Then I went to GR Medical College Gwalior for my graduation, and it was really a cakewalk. Because when I was applying for GR Medical College, out of 4,000 students in inter-science, only 6 got more than 60% mark, not the era of this. And I had my ragging done on the day I had gone to submit my application for admission. I was house surgeon of Professor B.N.B. Rao, another legend in surgery. He advised me that for post-graduation and for better training, I should leave Gwalior, and I came to PGI Chandigarh, joined it on 1st of January 64, much against the wishes of my parents, my teachers, my friends and everyone. But I think it was one of my best decisions. I could complete my MS in surgery within 2 years after passing part 1 and 2. In 1967, I was selected as a registrar in surgery. Subsequently, Professor A.K. Basu of Kolkata nominated me to become the house surgeon, SHO with Sir Rodney Smith in London, but Professor Santosh Singh Anand did not allow me to leave as I was a bonded candidate of Punjab government. In 1970, selected lecturer in surgery. 1971, selected assistant professor in surgery. There in PGI, I learned the qualities of a surgeon. A surgeon must have eyes of an owl, smelling power of a dog, hands of a lady, heart of a lion, and he must be ready to have the donkey's work, stamina of this. And I really got all these things assembled in me. This was the year after my graduation, and I ascended and became what I was in surgery. I saw the Indo-Pak War of 1965 and 71, used to look after war casualties. A large number used to be evacuated to PGI, almost 200 to 250 every day, and they were given treatment. I was a captain in the Territorial Army and had donned the uniform and transferred to Command Hospital, Chandigarh, for the war period. I was selected by Government of India for Foreign Service Deputation and posted in Libya, where I did a lot of work in GIT, neurosurgery, ortho, trauma cases, even performed at cesarean section. And this was because of my training all round in PGI. I was designated as the best ambassador of Hindi because of my work. I feel in academic institutions, faculty positions include patient care, research, teaching and training, administration, organizational activity, and health awareness. And I will come to these one of. One of my major interests, as Professor Carr has said, is surgery of the breast. In this I did breast conservation surgery, breast conservation surgery for locally advanced breast cancer, palliative care for metastatic breast cancer, MRM and breast cancer surgery under local anesthesia, which I don't think anybody is doing, aspiration treatment for breast abscess, medical management of this. The most of the cases we were doing was MRM. This was the commonest procedure. But then I realized, our patient require breast conservation. A thesis was given to MD Psychiatry of PGI, who now has retired as head of the psychiatry department. We published. This is the photograph of one of a young ladies, surgeons. Please don't change yourself. Who had, again, breast conservation surgery. We could give an incision at the junction of the areola and the breast, and you can see the good cosmetic effect. This was an 82-year female professor in Punjab University who was operated for breast cancer on both the sides. She refused to have mastectomy, and she is surviving now with 32 years and 20. This was the breast conservation surgery for the central quadrant tumor, which is not done by this, but we did it because this patient insisted, and now it is almost 15 years and she is fine. This is the breast challenges. Metastatic breast cancer, this is, I think, a curse of our country, and but these patients also require support. Like this 92 years female had a very large tumor, and this patient came to us with a lot of pain. We gave her some, not working. Demonstration set, and we could start laparoscopy 5 years after, and for 5 years till then I was the only person who was doing laparoscopic surgery. I started stapler surgery, mini cholecystectomy through a buttonhole incision. As a matter of fact, I must say, people did not believe that the gallbladder could be removed with a 2.5 centimeter incision. The director of the institute, Professor I.C. Pathak, came to the operation theatre just to see how I was able to do. Use a zipper for closure of abdomen, abbreviated surgery for poor risk patient. Everything for her. As a matter of fact, we were able to save the facial nerve also. I was awarded B.C. Roy Award for teaching and training as an eminent medical teacher. I have written 10 books, published 125 scientific papers, delivered 25 named orations, and I used to attend 20 to 20. These are the various books that I have been. This is the honors. This is from Delhi. In research, I did the non-operative management of hemoperitoneum due to blunt trauma abdomen. This was the pioneering work I started, and for this I got the MCI award of the nation, which is given only to one person in the whole country every year. Coming to MRM, breast conservation surgery under local anesthesia, This is the fibroadenoma or fibrocystic disease, which is usually done by excision, but I have tried this with Saheli, the tablet, and this has worked with me for almost 95% of patients where the fibroadenoma has disappeared. Coming to breast abscess, another common problem, usual practice is incision and drainage, can be managed with simple aspiration. You can see the breast abscess, and there you see I have been able to do it with aspiration or drainage in a few patients. And again, 90% of patients, you can avoid a big incision and dressing for days together, mutilation of the breast also. This is about the tuberculosis of the breast. The organizational and administration activities where I was quite involved in Gwalior Medical College, in PGI, in ASI, I was national president and governing council member for 6 years, and so far nobody from PGI in 70 years has become the president of ASI. I was president of National Indian Association of Surgical Gastroenterology, and presently I am the proud council member and chairman of the academic committee. Since 1967, I have been associated with ASI, but I am more interested in health awareness and health education now. Have published 10 books, 150 articles in popular newspaper, delivering lectures in school, colleges, clubs, associations. Received national award from DST for distinct communication skill because of this thing. I have been interested to fight the cancer and conquer it. These are the books I have published. This is the latest book I have come out of breast cancer. This is my autobiography book. I have been having a lot of hobbies, games, sport, represented university, Gwalior. Also have been interested in dramatics. I have been doing conducting, acting, directing, producing plays and cultural programs in PGI for almost 10 years. I have been interested in flower cultivation and have also in photography. I bow my head with respect to my teachers, trainers, guides, my colleagues, resident friends, my patients who believed in me, my profound to my family. This is my present family, my wife and my 3 princes. Thank you very much, ladies and gentlemen, for your patient hearing. I'm sorry I had to rush through. This would have required a lot of time, but I hope I could give a gist of my activities during the last 60 years in the surgical field.
Thank you so much, Dr. Bose, for all your contribution in the field and your sort of original contributions. Thank you so much. I think there will be no, there are no question and answer, and I think I'll ask now request Dr. Sinha to kindly introduce the next awardee.
So, thank you very much, sir. Good morning to everyone. It's my pleasure to invite Professor Narendra Kumar Mehra. Currently, he is Emeritus Professor ICMR, and he is also working for AGLS Laboratory, Gurgaon. Professor Mehra was Dean Research at All India Institute of Medical Sciences, New Delhi, and he was founder, head, Department of Transplant, Immunology and Immunogenetics, AIMS, New Delhi. Professor Mehra, please.
Thank you very much. At the very outside, I want to thank NAMS for giving this honor. And I'm so glad that I have got this RAE under the name of the big doyen of medicine, Dr. Chuchotani, longest serving director in Chandigarh. And the field of work that I'm going to present to you, out of the various activities that we have been doing, is the field of tropical medicine actually. The big three diseases, the big three infectious diseases for which we don't have the vaccine so far, the mycobacterial tuberculosis and leprosy, malaria and the HIV AIDS. And I want to, we were trying to find an answer to this question: how does the host immunity variation influence communicable disease expression? And the three infectious diseases that I'm going to talk about, I'm going to talk about the leprosy as well, because this is something that we have forgotten now, but we are still seeing new cases of leprosy. It is still very common in India, in Brazil and Indonesia there, although it has been eliminated globally because the incidence has fallen down below 1 per 10,000 there. The second disease I'm going to talk about is the tuberculosis. Tuberculosis, as you know, an estimated global total of 10.7 million cases of TB was seen in 2024, equivalent to 134 per 100,000 population. This was an increase of 4.5% from 2020, and most of these are found in Southeast Asia and within Southeast Asia in India. India's TB incidence in 2022 is 199 per 100,000, down 18% there. So that was a good thing, good sort of news. The third disease I'm going to talk about is HIV/AIDS. So these are the three infections that we have been working on. And there is a multifactorial etiology of infectious diseases. The three sort of players are the viability of the pathogen, the phenotype of the host, and the genetic variability of the host. And when we talk of the genetic variability of the host, the most important one is the human MHC, and because the MHC, which in man is called the HLA, the basic biological function of this particular molecule is to present the foreign antigen to the immune system. The immune system remains redundant if the foreign peptide is not presented to it by the HLA molecule there. And besides this, there are several others, the toll-like receptors, cytokine gene polymorphism, interferons, and our group has been working on all of them. I can't really talk about everything, but I will just focus on some of the things. And my story actually began in the early 70s, in 1971-72 in AIMS at that time, because at that time leprosy was very high in India. Out of the 10 to 12 million cases of leprosy worldwide, 5 to 7 million were in India. And in AIMS we used to always talk about immunology of infectious disease, immunology of leprosy. And we were trying to create this mouse model. I had to therefore do hundreds of thymectomies in the mouse, total body irradiation, bone marrow reconstitution. I became like a mouse doctor actually, doing too many of these. But what happened at that time in 1973 was a landmark year. Two very important developments took place. In 1972, Baruch Benasraf, who ultimately got the Nobel Prize in 1980, discovers what he called the immune response genes. And in 1973, Derek Bruton in UK showed a very strong association of HLA-B27 with ankylosing spondylitis. And that was the first time, because people thought HLA system was getting developed because of its need in organ transplantation. And here was a time, here was this guy showing a very strong association with the disease. So we thought, why not see if there is a similar association seen in leprosy. And that took me to Varda area. Disease was highly prevalent there. Every village, every house had a case. And of course, I'm so very happy to now report that from 1981 to 2025, the incidence has really fallen down significantly. These were my tools at that time. I didn't even have an inverted phase contrast microscope there at that time, but we published our first paper in 1975. This was in the best journal of that time, Tissue Antigens. And that took me to studies on TB, Again, tubercular leprosy, pulmonary TB, with Dr. Pandey. Pandey was really very kind to sort of categorize our cases on the basis of severity of the disease. And Dr. S.K. Sharma, of course, this Surinder Sharma, we published this article in 2002, evaluation of clinical and immunogenetic risk factors for the development of hepatotoxicity during anti-TB treatment there. And we found that certain of the HLA genes were susceptible to that. And of course, the story on leprosy went on. By the time we were also getting more interested in kidney transplant, the bone marrow transplant, but the studies on infections continued from TB, we went on to HIV, there were a lot of papers. And I want to show you this slide. How does HLA diversity determine the disease susceptibility? The hypothesis says that the susceptibility to a disease is determined by the overall binding capability of an HLA molecule with the peptide. And that's the binding molecule over there, the peptide binding groove with pocket 1, 4, 6, 7 and 9. Those are the very important ones. Of course, out of these, the 1 and 4 are very important. What is more important is the number of epitopes bound and the avidity of binding. Unless this avidity of binding is very strong, it cannot, the foreign antigen cannot be shown to the immune system there. And they would be therefore efficient and the inefficient presenters. What we see in autoimmune disease, there is a greater overall self-antigen derived peptide binding presented by the HLA molecule there. And in infectious diseases, it is the other way around, lower overall foreign peptide binding. So unless the peptide binding takes place very well, this antigen as a foreign antigen will not be shown to the immune system. And what we found during our studies that every HLA allele presents a different peptide. And that is why some of us get infected, but then become diseased as well, others not. Now, this slide shows you the alpha-1 and the beta-1 domain of the HLA-DR molecule and the pockets, the 1, 4, 6 and 9. And I will continue to talk about the pocket 1 and 4. This was our landmark study in 1999. Where by the time the sequences, by the time our ability to do sequences of these alleles had become very known, we had shown for a long time that there was a HLA-DR2 association. The DR2 has now been split into various subtypes, but now we could do the sequence analysis. And this was a landmark study, showed that alleles that had a arginine at position 71 or 13 were positively associated, and those that didn't have the arginine. So arginine turned out to be a very important sort of amino acid at position 13, 72, 71 in the pocket 4 of the HLA-DRB1 alleles. Our subsequent studies showed that it is not only the pocket 4, the pocket 1 residues are also very, very important, where there is a valine glycine dimorphism there. This took us to studies both on TB as well as leprosy. You can see that in valine goes on increasing when you move from the control population to TT type of leprosy to the more florid BLLL type. At this point of time, you don't see those BLLL types of individuals. So as the severity of the disease increases, the valine residues keep on increasing. This was also the case in pulmonary TB, where Dr. Pandey was kind enough to categorize our patients into unilateral limited disease, unilateral extensive, bilateral limited, and bilateral extensive there. And this has very clearly shown the peptide binding groove and how these residues in pocket 4 and pocket 1 influence the susceptibility or the severity of the disease there. This was our paper in Nature Genetics in 2007. We had collaboration with the Canadian group, and we had also tried to look into other genes as well, for example, the NRAMP1 and the TTLR there. And we came up with this model of two-stage model of genetic influence on human immunity in leprosy. I don't want to go into details of that, but these are landmark studies. We also did the TLR expression studies, because TLRs are very important genes for the innate immunity. What happens in a healthy individual, the cells with TLR expression are very good. But in TB, due to the MTB infection, there is a suppression of immunity, so therefore the TLR expression goes down, and that leads to the immunity going down and the susceptibility be going up. And we had this book, my book on HLA system biology and medicine, we came up in 2010. That's all these genes that have been described over there. We then went on to do also studies on HIV. HIV, came up as a wonderful disease because they were rapid progressors within 2 to 3 years. LTNPs, the long-term non-progress, and the EUs over there. So we wanted to understand the immunogenetic and the immunoprotective correlates there. And several studies done. Of course, the host genetics, the variation HIV disease is throughout the whole genome there. So we were looking at chemokines, cytokines and receptors, HIV co-receptors, the immune response genes like the HLA and all. And because it turned out that MSC has the greatest genome-wide effect on the control of the viral load. And of course, again, a sort of an invited article where we summarize all of these genes, the HIV entry, co-receptor ligands, post-HIV entry, and other innate immunity genes there. And there's a trinity of HLA-B alleles that were found to be associated with HIV-1 infection. Again, because of lack of time, I will not go into details of that. We worked on chemokines, the CCR5, the ApoBec3H genes. We really looked into almost all kinds of genes over there. So in summary, what I can say is that the communicable diseases even today continue to pose a challenge for the healthcare system. We were trying to find an answer. How does host immunity variation influence communicable disease expression? The answer lies at the intersection of immunogenetics, infectious disease, and population biology, with HLA being the master regulator and most powerful immunogenetic determinant. The same pathogen can cause wildly different outcomes across individuals, from asymptomatic carriers to the severe disease or death, or largely because of the host immunity variations there. The immune variables include, as I showed you, the favorable HLA, the TLR, hypofunction, strong Th1 bias, excessive inflammatory response, and the regulatory T cells being abundant there. So understanding the MSC peptide binding motif could help in developing screening tools to monitor susceptible progression, predicting populations, specific genetic propensity, and finally, vaccine responsiveness in clinical trials. This information could enable clinicians to adapt themselves for the modalities. This is my last slide. I want to really thank all the funding agencies. During my career, I have had a lot of funding, I must say, both within India, the organizations within India, as well as elsewhere around the world. And it's only due to that we could do those studies. So this was just one aspect of our work that we have been doing, infections and host genetics. Thank you very much.
Thank you, sir, and congratulations for Dr. Prannath Jutani recognition of academic excellence. Thank you very much, sir.
I think another very distinguished our professional colleague, Dr. Kar, who is also recipient of the P.N. Jutani recognition for academic excellence. Dr. Kar was, I think, was in AIIMS, then moved on to Maulana Azad Pant Hospital. He is presently the Senior Director Medical Gastroenterology in Max Healthcare, Patparganj. Dr. Kar, please. Okay, Dr. Kar, over to you.
I am thankful to the National Academy of Medical Sciences of giving me this opportunity to deliver this prestigious oration, Dr. P.N. Chitari oration, who has been an academic dawn in the field of internal medicine. And I feel proud to deliver this oration as a sort of a respect for him. I had thought that I would speak on viral hepatitis during pregnancy, because most of my work at the Maulana Azad Medical College, where I had spent almost 30 years of my life as a director professor of medicine, I had worked in this field. So I thought that it is difficult to cover every aspect of viral hepatitis, but I've chosen hepatitis during pregnancy as the main subject, and I would focus other aspects of my contribution. Hepatitis E virus is an enterically transmitted virus is a single RNA virus, initially classified in the calcivirate family, currently classified into separate genus, hepatitis E-like virus. Hepatitis E is an important cause of both sporadic as well as epidemic cases of viral hepatitis in this country. It's important to know that HIV infection doesn't lead to chronicity, but a fraction of such patients progress to acute liver failure. The most important part to note is that high mortality rate of 20 to 30% have been reported for HIV infection during pregnancy, where FHF account for maximum severity in the third trimester of pregnancy. HIV is the most common cause of sporadic AVH, 40% in India. The prevalence of HIV in pregnant women in first trimester is 76%, second trimester is 88.9%, and third trimester is 83.8%. The geographical distribution of hepatitis E virus varies across the world, but most common is in Africa and Asian countries, including India. And most of the outbreaks of hepatitis E is related to consumption of fecally contaminated drinking water. Person-to-person transmission, nosocomial transmission has been reported, and some studies have shown the possibility of post-transmission of hepatitis E. It's important to note that this virus is never transmitted by sharing of utensils, cigarettes, or by kissing. There are three different phases of HIV infection: the prodromal phase, the ectoric phase, and the recovery phase. And these phases almost remain same, whether you're dealing with viral hepatitis A, whether you're dealing with viral hepatitis B, or whether with viral hepatitis E. The viremia has been studied by most of the workers of the HIV viremia, and they have found that it varies between the 45 days to almost, it can vary up to from minimum 39 days to about 111 days in a given patient, as reported by various workers. Acute viral hepatitis, if you look into the publication in the International Journal of Gynecology and Obstetrics, it shows that hepatitis E was the most important cause in 48%, followed by hepatitis B 27%, and other viruses 25%. We at the Lok Nayak Hospital at Delhi, we analyzed our 5 years experience in a total of acute viral hepatitis during pregnancy, 411 patients, and AVH non-pregnant, 357 patients. And you can see that HIV infection was seen in 82.72% of the cases, as against the non-pregnant, which was 43.4%. Similarly, we analyzed our data in ALF patients. We had about 139 acute liver failure patients, pregnant patients, and non-pregnant ALF, and we again showed that the hepatitis E virus was responsible in 73.38% of the cases. HIV in ALF has been also described by other workers from this country. Acharya et al. From India had described it to be 68.4% HIV infection. Nanda et al. From PGI, 62%. So HIV remains a major cause of acute liver failure in India. This is another publication which emphasizes that HIV infection is seen as a major cause of fulminant hepatic failure in pregnancy as well as in AVH. This is another analysis of our data, which again goes to show that HIV infection occurs in all the trimesters of pregnancy, and they are responsible for increasing number of mortality. So now the thing, I am going to this straight away to the viral hepatitis in pregnancy, which has been a subject of continued interest and controversy. Reports from Europe and United States have shown that the course of viral hepatitis in pregnancy to be no way different from non-pregnant women. However, studies carried out in India, Africa, in Iran and Middle East have found the incidence of fulminant hepatitis to be higher in pregnancy. Females constitute more than half of the cases of the worldwide, irrespective of the etiology of ALF, and this has been confirmed by Dr. Khuru and Kamili, that there is a higher prevalence of females in HIV infection than those in non-E group. The prevalence of HIV pregnant women with ALF was 95.8% as against 41.2% in the non-pregnant women. Now the question is that hepatitis A infection has both a high incidence severe course in pregnant women. My interest was to know why does it that the hepatitis A virus behaves in such an abnormal way during pregnancy. The only country where hepatitis A is very prevalent is in Egypt. The anti-HIV antibodies are very high, but severe HIV infection does not happen in Egypt in the AVH cases in pregnant women. Reason for differences in the outcome of HIV in different geographical areas remains unclear, but could be the result of early childhood HIV exposure producing long-time lasting immunity, or it might subsequently modify the response to the exposure to the virus. Alternatively, the HIV genotype which is seen in Egypt may be less virulent. Liver injury due to HIV infection during pregnancy is the consequence of immune system changes. Certain hormonal factors like progesterone, estrogen and human chorionic increase in pregnancy, and animal studies, these have a suppressive effect on the cell-mediated immunity. The genetic and the environmental factors with its occurrence in certain developing countries. We have also seen that in viral hepatitis, when it occurs in pregnancy or in acute liver failure, there could be sometimes co-infections also with hepatitis C. A, E combination, B, E combination, C, E combination are seen. Now, does ALF in pregnancy have a worse prognosis? The prediction is different from different authors. Bhatia et al. Found no difference. Jilani et al. From our center at MAMC find a higher mortality. Khuru from Kashmir said ALF has a good prognosis. We also studied the HIV infection in pregnant women, the HIV viremia in these patients, and found that about 33.67% of the pregnant women have asymptomatic HIV IgG antibody present in their circulation, indicating ongoing HIV viremia. The maternal and fetal outcomes are also affected in HIV infection. 1/3 patients develop fulminant hepatic failure. Maternal mortality may be as high as 25%. The fetal outcome is also poor and may lead to high rate of preterm labor and stillborn. Mother to child transmission may be as high as 33.3% and 50% of the cases. 2/3 of the HIV positive women had preterm deliveries, intrauterine fetal death, preterm deliveries and perinatal mortality are reported to be higher in pregnant women with HIV infection. Obstetrical and fetal complications. Obstetrical complications are seen in HIV infection. There is a high incidence of postpartum hemorrhage, intrauterine fetal death, preterm delivery, spontaneous abortions and death in the hospital. We had studied the CD4 counts and the CD8 counts and found that CD8 counts were lower while CD8 counts were higher, and their ratio CD8 and CD8 in HIV pregnant women was significantly lower when compared to that of HIV negative pregnant FHM controls. The levels of estrogen and progesterone hormones were found to be significantly higher in patients with acute viral hepatitis in pregnancy as well as in patients with ALF as compared to the controls, and we believe that probably the hormone levels of estrogen and progesterones and chorionic hormones have something to play a role in predicting the severity of the course of the infection. We had carried out a study which we have shown that high viral load has something to do in patients with severe acute viral hepatitis and acute liver failure, because the high viral load probably is found to be different in patients with AVH with pregnancy and ALF patients as compared to AVH patients and ALF patients who are non-pregnant. There's a significant difference. And this is true for the genotype 1, which is common in our country. Yeah. We have also found that the exclusion of P65 from the NF-kappa B transactivation complex seems to be a crucial step that may cause dysregulated immunity and severe liver damage leading to death of the patient. Our findings provide a molecular basis for developing a novel therapeutic approach. We had also reported that the high viral load, HEV viral load and dysregulation of the progesterone receptor signaling pathway is associated with a hepatitis C related poor pregnancy outcome. We have also found that there is a significant negative correlation between baby birth weight and estrogen levels in HEV infected pregnant mother. The role of TNF-alpha. We have reported that high serum concentration of TNF-alpha observed in HEV infected AVH and FHF patients shows that pregnancy with HEV influences TNF-alpha secretion, and TNF-alpha may be an important factor in the outcome of pregnancy due to HEV infection. Another important thing which we have been able to show for the first time, that is, we have demonstrated that the HEV replicates in pregnant mothers in the placenta, outside the uterus, in patients with acute viral hepatitis and acute liver failure. And possibly, because of this extrahepatic site of replication, this is responsible for the severity of the disease during pregnancy. We have also reported that there is evidence of vertical transmission of hepatitis C positive infection from mother to the child in the cord blood in the newborns. The public health implication, the special effective tool is needed for outbreak controls of NAMS, floods, endemic hotspots. Consider target vaccination wherever possible. Surveillance and control procedures should include provision of safe drinking water and proper disposal of sanitary waste, determination of source infection and mode of transmission by epidemiologic investigation, and detection of outbreaks and the spread of contaminant. Now, to summarize, hepatitis E has both a single high incidence and severe course in pregnant women. Acute liver failure occurring during second and third trimester of pregnancy has high mortality. HEV infection during pregnancy is vertically transmitted, leading to increased maternal mortality, obstetric complications, poor fetal outcome. The liver injury due to HEV infection in pregnancy is influenced by the immune system changes, hormonal factors, genetic and environmental factors. High viral load and dysregulation of the progesterone receptor signaling pathway associated with hepatitis B related poor pregnancy outcome, and there is an extrahepatic site of replication of the virus which I have already demonstrated, and the viral load is comparatively higher in the FHF group than the AVH, and this speaks of the role of HEV, viral load, hormonal factors and genetic factors in predicting the severity of the course of the disease. At the end, I must acknowledge the ICMR, the Department of Science and Technology, the University Grants Commission, the Maulana Azad Medical College Dean, and the Dr. B.C. Das, who was in the ICMR earlier, and some of my students, some of the other the colleagues in the department who had helped me in generating these data for this particular presentation. Thank you.
Thank you so much, Dr. Kar, for your excellent contribution in this area. I think we will go to the next presentation. I'll request Dr. Kar to.
So next, the very noted clinical pediatrician or the clinical scientist nominated for the NAMS recognition of academic excellence is Dr. Tulsidas took recognition academic excellence. Professor Dr. Madam Shelly Avasti, who has extensive work in the field of infectious diseases including epidemiology, pathogenesis, prevention, control and treatment of infections and translation studies. She is retired from the Professor Head from Pediatrics, King George University, Lucknow. Madam, up to you.
Thank you very much.
Listen to her.
Thank you very much. Eminent members of the jury and distinguished members of the audience. Before I begin my presentation, I pay homage to Dr. T.D. Chugh, who was Emeritus Professor of Clinical Microbiology of NAMS. Also, he served at Rohtak and for more than 25 years in Kuwait. As a result of his endeavors, he has mentored many students, and this award was instituted in 2018. I thank the NAMS for selecting me for this award. I would acknowledge various constituencies, my institution KGMU, sponsors of all the works which I am presenting, my colleague co-investigators, pediatrics department, my PhD scholars, residents, and other constituencies and subjects and families. My work which I am presenting today, a body of work, is in community-acquired pneumonia in children. According to WHO, it is defined as children having cough, difficult breathing, fast breathing with or without fever, and it is called severe pneumonia when it's associated with a danger sign. The etiology is bacterial or viral, and WHO has given 8 specific fast breathing cutoffs above which the diagnosis is made. Diagnosis is primarily clinical, focusing on identifying those who require immediate antibiotic treatment. If you see the magnitude of problem, there are 14 cap deaths per hour. It is high incidence, high mortality condition, and childhood pneumonia, there are approximately 4 million episodes annually. The mortality rate of hospitalized children can be as high as 30%, and the key risk factors are those with increased vulnerability to infection. There has been a decline in cap mortality due to introduction of vaccine, improved nutrition, early disease recognition, increased access to antibiotics, and reduced household pollution. Therefore, ICMR formed treatment guidelines. This is the strategic treatment workflow of ICMR for CAP. I was chairing this committee, and we hope these guidelines are implemented for efficient management of the cases. So my areas in CAP, the work range from 1990s till date, and I have worked in the area of risk identification, burden of disease, risk stratification, also in cases of treatment, prevention, and early recognition. The earliest work I would want to present is effect of cooking fuel on respiratory disease. As we know, a lot of different respiratory cooking fuels are used. It were used, LPG was not commonly used that time, and we found that the use of dung cake increased the odds of respiratory infection, as did the bedroom overcrowding. There was an attempt, therefore, to change policy to improve the type of cooking fuels or modify the oven design if LPG could not be affordable to all the families, and the public impact of this work was immense. The next I would present would be the ISCAP study, 3 days versus 5 days treatment with amoxicillin for non-severe pneumonia in children. Now, I would not repeat the background. In 2000s also, pneumonia caused a lot of deaths. It was treated with antibiotics because etiology was bacterial/viral. But a trial of oral amoxicillin in Bangladeshi children reported 3 days treatment cured 75% of cases, and there was no subsequent relapse in them. Therefore, the study was conducted. It was a randomized, double-blind, placebo-controlled, multicentric trial of 7 referral centers, and I was the PI as well as coordinator. The objective was to compare 3 days versus 5 days treatment with oral amoxicillin. About 2,000 children were randomized in 3 days versus 5 days group, and we found that the cure rate with 3 days was 89.5% versus 89.9% in 5 days. This was equivalence trial, and based on our prior criteria, the two treatments were equivalent. The key finding was that 3 days was implemented, and as a result of implementation of 3 days, there was a reduction in cost of treatment, reduction in emergence of antimicrobial resistance, and WHO changed the IMNCI strategy and recommended 3 days of amoxicillin for non-severe pneumonia. However, in 2015, we undertook a study of revisiting community case management of childhood pneumonia. What were the perceptions of caregivers, grassroots health providers in UP and Bihar? Because the mortality hadn't reduced despite ARI program. And we wanted to see what was the perception of caregivers for treatment. We did a qualitative study, and we found that there was poor recognition of danger signs, that the mothers took the baby first to the RMP, then the family decision was made to take the child to a private clinic, and the public health facilities which had qualified healers were the last to be visited after almost a week delay. Therefore, we said there is a need to increase awareness, and we said that we have to address delay in recognition, delay in care seeking, and delay in qualified care seeking. And we developed posters, we developed videos, and with these posters and videos, we trained the community to assess what would be the impact on qualified care seeking. This was a community pneumonia awareness intervention study, a behavior change modification study, again a randomized trial, 2x2 factorial design, open labeled, where we said that could we address the delay by increasing the awareness, by strengthening the public health facility, and we used our IEC material to train the villagers, to train in the public health centers, and we developed pneumonia treatment kits which had amoxicillin, paracetamol, bronchodilator, and we distributed it so that they would not use irrational medicine. So as a result of our intervention, we found that care seeking improved. Now the parents were coming to public health facility for care seeking, and this was initial inputs which went into the program of the Government of India, the SARS program. Then there was effectiveness of 13-valent pneumococcal vaccine. We know pneumococcus causes primary endpoint pneumonia with or without infiltrations. And when pneumococcal vaccine was introduced, we did a study to see, a case control study to see what was the effectiveness of pneumococcal vaccine in India. RCT could not be done because it would be unethical. We found that vaccine was effective, and with vaccine, not only did we improve the outcome, there was a significant mortality reduction, and this enhanced the national confidence in introduction of pneumococcal vaccine. Not only that, we saw the nasopharyngeal carriage rate of streptococcal pneumonia serotypes in sick and healthy children in northern India. And we found that among cases of pneumonia, there was 8% nasopharyngeal carriage. Among controls, there was a 23% nasopharyngeal carriage of strep pneumonia. But vaccine types, serotypes, were much higher in cases as compared to controls. The adjusted odds being 1.77. There was a low isolation from the cases because prior antibiotic was given to the patients before they came to the hospital. We also did a vaccine serotype, the blue being cases, the red being controls, and you can see the vaccine serotypes are higher in cases. We also found additional serotypes which could potentially be introduced in the vaccine. Having said that, we moved on, and in 2022, we published what is the epidemiology of hypoxic community-acquired pneumonia. We recruited 10,000 subjects, 7,000 almost, from states of UP and Bihar. We found that 35.9% were hypoxic, and there was an increased incidence, increased death. The death was 2.36 times higher in cases of hypoxic children as compared to non-hypoxic children. And therefore we said that what happens to these hypoxic children when they are discharged from the hospital? And we followed up about 1,000 children. It was a retrospective study, and we found that among those who were discharged from the hospital, within 3 months, the mortality was 3.5% as compared to 1.9% in the hospital. The infants, those with congenital heart disease, those with severe malnutrition, those who lived in rural areas and radiological pneumonia had a higher incidence of death. Therefore, what I'm saying now is discharging a child from the hospital is not enough. These children have to be under close follow-up for at least 3 months. Not only that, we validated the PREPARE score which WHO had developed. We identified the risk of death in children hospitalized for pneumonia, and we found that the WHO PREPARE score on external validation was 80% sensitive, 72% specific, with area under the curve 0.82, and therefore countries like India could adopt PREPARE score for risk stratification, and the sickest children could be referred to higher facilities which has intensive care set up in those areas, facilities. Now, based on that, we found that hypoxia is bad. Therefore, prevalence of hypoxic pneumonia, what is the prevalence of hypoxemia in sick children which come for health care in the public health facilities in Uttar Pradesh? We saw this and we published this in 2025. We had recruited children from the health facilities, and we wanted to know how many of them were hypoxemic. We found that the hypoxemia less than 94% oxygen saturation was low, 1.3%. And among these 1.3%, severe hypoxemia was 1/3. But what is of concern to us is that these hypoxemic children, only 1/4 were referred, and among those that were referred, 1/4 adhered to referral. So they preferred to keep their hypoxemic children at home, and there was bad outcome and death. This is of grave concern. So what are the gaps in management of CAP? This is antibiotic overusage because it is viral also. There's lack of diagnostic precision. Can we differentiate viral from bacterial? There's inconsistency in guidelines and non-adherence, and therefore ICMR guidelines should be followed. Unclear management protocols for complication, and vaccine coverage has to be enhanced. And my last slide is on what are the immediate research priorities for CAP. One would be, can we use PCT for the studies needed to see PCT tool for antibiotic de-escalation, rapid molecular diagnostics for to identify pathogens, viral, bacterial, reducing empirical treatment, improving outpatient management, shifting towards waitful watching for mild cases to decrease antibiotic exposure, and adhering to standardized protocols, adhering to simple evidence-based local management algorithms. Thank you very much for your kind of. Thank you.
Thank you very much, ma'am, and congratulations. So, I would like to invite Professor Aman Sharma for General Amir Chand recognition of academic excellence in field of non-communicable diseases. And Professor Sharma is professor at Department of Internal Medicine, PGI Chandigarh. He have expertise in the systemic vasculitis, and he is also program director of Center of Excellence of HIV Care, NART, at PGI Chandigarh. Thank you.
Thank you, Professor Sinha. And at the outset, I would like to thank the Academy for this huge honor, and I feel humbled to be speaking amongst the stalwarts of medicine and research in this country. The subject that I've chosen is to take you through our journey of trying to understand vasculitis in the next 13 or 14 minutes, and what we've learned and what we shared with the world. When we talk about vasculitis, having an ideal or criteria or a criteria which is universally acceptable while making a diagnosis is still a research, is a work in progress. And in one of the initial works, we validated the EMA algorithm, which led to classification of the unclassifiable patients also at PGI, and subsequently we were invited to be a part of the global effort to make new diagnostic and classification criteria of vasculitis. We contributed patients, invitation to review the patient data set was also there, and subsequently the ACR and the EULAR made a draft criteria which was proposed in 2017. We applied these criteria in a real-life cohort of around 187 ANCA vasculitis patients, and as you can see, these criteria were very incongruous, and what we flagged was that despite the fact that we know that there is kidney involvement in ANCA vasculitis, in this score, no score was given for renal involvement. This aberration was corrected in the eventual final criteria published by the American College of Rheumatology, and kidney involvement was in fact included in the final score of the American College of Rheumatology criteria of GPA. We also validated the 7-item criteria for diagnosis of polyarteritis nodosa. What we showed was that while it is very good for making a classification for polyarteritis nodosa, it does pick up many patients with ANCA vasculitis also as polyarteritis nodosa. So taking this template, because vasculitis is not a single disease entity but a group of different disorders, taking this template of Chapel Hill nomenclature system of different vasculitic disorders, I'll share our experience of different subgroups of vasculitis. When we talk of large vessel vasculitis, we know there are two, Takayasu and giant cell arteritis. Whenever people talked about giant cell arteritis, it was always said that giant cell arteritis doesn't really occur in this country. This is a landmark publication from Sohan Singh Hare, who was a Patiala Medical College alumnus and went on to become the global leader in understanding the anatomy of optic nerve, and was a professor of ophthalmology and anatomy at University of Iowa, the last word on giant cell arteritis. He also writes that while he himself and a couple of his siblings suffered from GCA, it was a commonly held notion that GCA doesn't occur in this country. So we published the first entire published experience from India with Professor Amod Gupta's group, and we did show that this does occur in this country. We also made an effort, because it was held that the people with color do not really have giant cell arteritis. The experts from all over the world, including John Stone for Harvard, and also colleagues from Europe and from UK, we put a piece together and published in Lancet that does occur in the people of color. Takayasu arteritis is something which has been our bane. It is a grumbling disease. It is very difficult to assess the disease activity clinically. The only investigation which comes to our rescue is PET CT. We showed that it is very sensitive and specific in assessing or picking up active disease. This is what we published along with our colleagues from the nuclear medicine. Because of difficulty in having any outcome measures, there are not many randomized trials in Takayasu arteritis. So we did many meta-analysis and published which have guided treatment in Takayasu arteritis. Our colleagues from the NIH described a new disease entity called Vexus syndrome, wherein we went from phenotype-driven approach to a genotype-driven approach, and they showed that there is a new disease entity called Vexus syndrome, and while they described relapsing polychondritis, giant cell arteritis, and polyarteritis nodosa as one of the phenotypes, at the same time we had a patient with lupus phenotype, an adult male. With the help of David Beck, who was the first author of the NEJM publication, we showed this was the first patient diagnosed anywhere outside the NIH in India at PGI Chandigarh, an elderly male with a lupus phenotype. Polyarteritis nodosa is a medium vessel vasculitis. We showed that in our cohort there was no difference in either presentations or outcomes with the reference to hepatitis B positivity. This was the first paper which looked at the role of CT angiography, because unlike other vasculitic disorders like ANCA vasculitis, medium vessel vasculitis doesn't really have a biomarker. So the way to, and there is nothing much that you can take as a tissue. So only if you have a neuropathy you can take a tissue and do a nerve biopsy, which is not possible in many of these circumstances. So what you fall back upon is CT angiogram, which shows the vascular changes in the form of microaneurysms as shown here, or end organ changes in the form of renal infarcts or splenic infarcts. This study has established the role of imaging in helping making a diagnosis of medium vessel vasculitis. We've done some pioneering work in a disease which was published for the first time in New England Journal of Medicine called deficiency of ADA2 or DADA2. This is simultaneously published from the NIH and the colleagues from Israel, wherein it was shown that this monogenic disease was because of ADA2 gene mutation. What we found out that the disease which till that time was considered to be disease of childhood was actually occurring well into the adulthood, and in the northern Indian population this was localizing itself to Agarwal Jain community. So patients with recurrent strokes who came with polyarteritis nodosa kind of manifestations, they were all from that community. That was a clinical observation. Immediately when this paper was published in the flagship publication of American College of Rheumatology, Arthritis and Rheumatism, it made a buzz, and the altimetric score was 61. We showed that a disease, as I said, which was the median age was 4, but this is the first publication that we had where we saw patients well into the adulthood. At that time, we had the last patient that we saw was in 40s, and Mandy Umbrello's group from the NIH had shown that once you start an anti-TNFs, the strokes don't recur in these patients. That was an NEJM publication. What we showed was that with treatment, not only strokes don't recur, but the other inflammatory manifestations also improve after exposition to anti-TNF therapy. And what this did was, this created a lot of buzz. I was invited to deliver the inaugural lecture of the DADA2 conference hosted from the NIH. There was COVID, and so it had to be delivered online, and here is the chief of the vascular research at the NIH tweeting about it, and there was also an invitation to deliver the NIH grand rounds also followed after this publication. We expanded this work. This is the largest cohort of 101 patients. 1 in every 7 patients of DADA2 in the world happens to be an Indian. And we also predicted the mortality in these patients. Bowel wall ischemia and CNS involvement and lack of anti-TNF therapy is a predictor of mortality in these patients. Again, this was recognized, and this work of ours was highlighted by the DADA2 Foundation newsletter, and that Indians are seeing more and more patients. And I think I'll take this opportunity to sensitize everybody that this can go to any specialty. They can go to the gastroenterologist, they can go to the neurologist, they can also be seen by the skin specialist, and also they can be seen by the rheumatologist. So we were part of the ADA2 treatment consensus published in JAMA. Coming on to another area of interest, ANCA vasculitis. We know that there are 3 types: GPA, which was known as vaginous granulomatosis, EGPA, which was known as Churg-Strauss, and MPA. Before we started publishing about ANCA vasculitis, whenever the Westerners talked about ANCA vasculitis, they said that unlike Europe, Asians have an MPO positive GPA, which was because the Japanese only published about ANCA vasculitis, and they had a subgroup which was MPO positive ANCA vasculitis and not a GPA positive ANCA vasculitis. But our publications clearly showed that Indian patients are like their European colleagues, and they have PR3 positive ANCA vasculitis. And this is what we published, that it is not different from the West. Indians, at least, not unlike Japanese, have what the Northern Europeans have, a PR3 positive ANCA vasculitis. When we encountered 3 patients in the labor room presenting in the advanced stage of labor with ANCA vasculitis, we saw that there is not much published literature available. So we ourselves did based upon 3 patients in labor presenting for the first time with ANCA vasculitis, one of them having cannonball opacities, which we published in the Lancet. We did a systematic review of all the pregnancies in ANCA vasculitis, our 110 pregnancies, and we showed that pregnancy outcomes are possible in patients with ANCA vasculitis. Since these are TB is a close mimic, we showed that if you have mediastinal adenopathy and pleural effusion, this goes in favor of tuberculosis even if you have lung shadows. And we also continued this work and showed that TB can cause PR3 positivity also, so one has to be very cautious. This was published with our colleagues in pulmonology, and we showed that these were microbiologically proven TB patients who had PR3 positivity in up to 7%. So we need our own guidelines. So this was a data-driven guidelines published in Autoimmunity Reviews, the journal around impact factor, where we took into consideration the economic considerations also, and these are data-driven Indian guidelines for management of ANCA vasculitis. The other thing that we have to encounter when we treat patients is cost. So we showed that biosimilar rituximab, which is very economical as compared to the innovator was as effective in both remission induction and remission maintenance in ANCA vasculitis. So you can very confidently choose economical biosimilar molecule for treatment of a life-threatening disease where the mortality untreated is almost 100%. We also showed that ANCA patients, especially the GPA cohort, had a much lesser kidney involvement. That was the experience of Professor Ashok Kumar from All India Institute also. And those who had ANCA negative status in ANCA vasculitis, they had worse outcomes as compared to the patients who had ANCA positivity. And the renal outcomes were dependent upon the burden classification system. Those with the sclerotic involvement had the worst outcome, and those who had focal had a better outcome in ANCA vasculitis. So this outcome was again defined histopathologically. Our PhD students have shown increased ROR gamma T and decreased FOXP3 expression in patients with ANCA vasculitis. Proteomic studies on MALDI-TOF showed differential expressed proteins in ANCA vasculitis. And also Dr. Mehra would be interested, we have distinct HLA and non-HLA associations in subtypes of ANCA vasculitis, increased expression of BAF in ANCA patients. And also, whenever people talked about Behçet, they said this is disease of the Silk Route. There are many studies from India, but I'm only highlighting one wherein I think Professor Talwar would be interested. We've seen patients with aortic aneurysms which have been tackled with stents. We've had aortic artery aneurysms, aorta aneurysm, femoral artery aneurysm, dorsalis pedis aneurysms in patients of proven Behçet's disease, which were tackled and treated at PGI. We also know that various connective tissue diseases can also be associated with vasculitis. But one landmark work that we did was in patients with relapsing polychondritis. This is a disease of the airways, generally causes red ears and tender nose. But what is sinister is the airway involvement and also aortic root dilatation, which is sadly most of the times picked up when it has already occurred. But one investigation which can pick it up before the patients the life is threatened is by doing a PET scans. This work has made its way up to the uptodate.com, and it is being included in the evaluation of relapsing polychondritis. And the latest edition of Hochberg textbook of rheumatology also cites our work and says that this should be done wherever the facilities are available. So this was again a game chamber work that we did. This is how I will show you that the airway involvement can be picked up on PET. This is a student from PGI itself who had aortitis. There were no symptoms at all, and the aortic root diameter was also normal, which we used to do when my mentor Dr. Bhamri was there. But PET can show you, we can pick up the thickening, we can pick up the uptake of the aortic root, and you can prevent aortic root dilatation in these patients. We've participated in the disease activity measure like the RPDI and RPDAM, and this is the physician's global assessment on the NIH data with our colleagues who published both Vexus and reported the data too. And the diseases don't really read the books. We've also published that the patients do not really qualify to any of those criteria. We had a patient from Bombay with a tumor-like mass in the thigh, isolated granulomatous GI vasculitis, pan with Budd-Chiari syndrome, which can present with any of these specialties. With us, I will wish to conclude that our group has described clinical spectrum, validation of lab criteria, various manifestations. We've shown the world that DADA2 occurs in adults, expanded spectrum of DADA2 and Vexus syndrome, genetics, cytokine and proteomics work in DADA2, and data-driven Indian guidelines. Thank you very much for your patient hearing. And these are the acknowledgements with, of course, my guru highlighted in yellow.
Thank you so much, Aman, for your pioneering and outstanding contribution in the field. Thanks so much again.
Thank you, sir, very much, sir.
Request Dr. Carr to...
Yeah, I am pleased to introduce the next scientist, clinical scientist, Dr. Mohammad Ashraf Ghani, who is currently the Director Professor and prestigious Medical Institute in Jammu and Kashmir, Sher-e-Kashmir Institute of Medical Science, Srinagar. His alumni from NAMS, and we interacted with there in the institute how he pushed the faculties to do the more of community works and go to the next level. He has been nominated for Achanta Lakshmi Prati recognition of academic excellence in the field of maternal and child health, women's health and community nutrition. That's up to you, Sani.
Thank you, Chairperson. Good morning, everybody. It is an humbling experience to present in front of stalwarts and after all the scientists of the country presented their work. I would like to here actually telescope all of my work into few slides here, and just to sensitize that we think that the women health issues and the epidemics of several non-communicable diseases in the country stem from a central driver which I called polycystic ovary syndrome. As we know, epidemiological transitions have happened in the West and infections have been conquered there, but we still have both infections and a barrage of metabolic issues, and there are significant morbidity and mortality accountable to these diseases, and women health probably remains in the center of this whole gamut, and women have hormonal disorders still, nutritional deficiencies, they have infections, and there are reproductive challenges. Not only that, because of the transgenerational impact from women dysmetabolism to the next generations is going to fuel our epidemics. So my journey to endocrinology was way back in 99 when my stalwart endocrinologist judged my paper and declared as best poster, best oral presentation, and that is how I chose endocrinology. And in 2000, I came to endocrinology when Dr. A.C. Amini, motherly figure, gave me two theses on PCOS. I thought, I am endocrinology, why is she making me gynecologist? But that time metformin was first paper on treatment of PCOS came by John Nestler, and I did a journal club, and that is where the process started. But I was thankfully rewarded for that work immediately. So the RCT comparing metformin with an anti-androgen came in JCAM, and this paper was, commentary came in NEJM, and this was also come in textbooks. And second, my paper also got best outgoing DM scholar at AIMS New Delhi, and I got a Young Scientist Award in Japan. And this actually lured me to the concept of PCOS. As you knew, 1935, two gynecologists from UK described that polycystic ovarian morphology as PCOS, but it evolved. Till 1990, there was no paper on PCOS. From 1611, and then papers started coming up. You can see the research papers are even lakhs of citations come every year on this. And in 2011, as an executive editor of our journal, I wrote this editorial that PCOS is probably the metabolic malady and it is the mother of all lifestyle disorders. So it was in a very humbling way I put it, but 15 years down the line, I found Prime Minister's office declared the Swasth Nari and Sashakt Parivar, and which actually supported our claim, which was 15 years. Although we started this the campaign in our institute recently, we did many programs under this, but I would like to tell you a few slides about my experience of a decade of stay in All India Institute of Medical Sciences and 1.5 decade study at SKIMS Srinagar. I tried to raise few questions to myself that about PCOS. How common is the disease? What is it linked to other metabolic disorders? Is there an Indian phenotype? And if so, why it happens so commonly in India and what can be done? So some of the work, we did a systemic analysis. There were small, not so well designed regional studies on PCOS prevalence ranging from 30 to 36% of the girls. But we thought, no, let us actually systematically answer this question. So I approached ICMR, several ICMR, DBT, DST for this problem, but luckily one fine day I had a good luck and Dr. VM Katoch Saab listened to me, he realized the problem, he initiated a brainstorming session and a 3-phase PCOS task force was constituted, and subsequently Somia ma'am, who was then DG, allowed me to take this task force to the logical conclusion. We have 20 centers across the country, very well designed study, 102 investigators, and very proper mechanism, systemic training workshops and other issues were put in place, and even a website was there, and we ended up with results which Dr. Rajiv Bahl Sahab declared. And I will just say in nutshell, you can see across the country there are some hot zones where PCOS is very common, and the paper came in JAMA and we released the data last year, and it shows that by Rotterdam 2003 criteria, which is commonly involved, India has 19.17% PCOS population. And if you see, we estimate that we will have 44 million in this country, and this is far higher than even China and US and other European countries. Since the costs work out, if you can see that it is many times more than our health budget. So that is a burden of the disease, and it gave us a systematic answer, and now the ball is in our court what to do. Second question was, is there a phenotype different to Indians? So there are phenotypes described by Americans and Europeans. There are the methods findings. You have these different criteria for diagnosis. I will not go into detail, but what I would like to say that in India there is variation from region to region, like Delhi and Srinagar, women are different, and there are several phenotypes which we have described, and these phenotypes, we have even partial forms which we described, we call it as a pre-PCOS, and that means an intermediate variety of PCOS is also happening. So why then, why are we bothered that if we have PCOS so common, are we only bothered about reproductive and cosmetic issues? No, we are bothered about these gamut of metabolic abnormalities which are every day added, and they are described. Probably the central driver being insulin resistance, which is common to diabetes, CAD, and so many other diseases. Accordingly, PCOS presents from pediatrics to geriatrics to any department. Only the manifestation is differ. And because of this, we have seen even neonates have higher C-peptide. We have seen that HSCRP is elevated at younger age. We have seen microalbuminuria occurring in normoglycemic girls, and we have seen that glycemia even at adolescent age, 36 to 40% of girls have glucose intolerance. We have also shown that we have fibroscan showing fatty liver in these girls, and they have the markers in ovaries may be absent, ultrasound may not show PCOS, and even the family members, fathers and brothers and mothers of these girls have all metabolic issues. So you have cortisol axis deranged, you have psychiatric comorbidities, and we have also described several other things, but risk factors, genetic, epigenetic, or the environmental remain to be seen. We have actually seen that genetic issues have been examined by several studies, but there is no conclusive data. And now we are looking, despite of having these small studies, we are looking at exploring genetics. We have microbiota we are working at, and we have seen pro-inflammatory markers in these women which are related to our diet. Even vegetarian women have higher inflammatory markers. So there are some immunity, as I was saying, vasculitis. So there are, we have described some papers where autoimmunity has been also showing higher prevalence of PCOS. So it needs to be explored whether it is Graves' disease, thyroiditis, or other autoimmune markers. So we need to see this in future whether autoimmunity has a role. Vitamin D has been seen. Now we have a big biobank out of this task force where we want to see, explore the possibility in future. So management of PCOS has been so long, diet, weight reduction, but India has more of lean PCOS, yoga, other physical activity parameters are there. But the problem is OCP is drug of choice in West, they are prescribing, but what we have seen in Indian PCOS that OCP worsens inflammatory markers and cardiovascular risk, and metformin and anti-androgen combination is better. So we have compared OCPs versus metformin, and this paper is under publication where we found that OCPs are more deleterious in our women than in West. So we have had several papers, and we presented metformin as compared with anti-androgen, and we even showed a combination of a small dose of anti-androgen with metformin are probably the best treatment, first line treatment in PCOS. That means we have to have a new guidelines for Indian population, and we cannot just copy the West as it is done. So we have thiazolidine, Dionis also are quite effective, but only precaution is that if we are giving them and these women conceive, they get something like bone disease, something like osteofibrous dysplasia. So we are seeing the impact of vitamin D is here, but it's very small. There are several other drugs have been tried, but these treatments are not effective. We have Indian women have to have indigenous drugs to be tried for in future studies. We have also out of the task force started a model clinic, multidisciplinary clinic, because these girls, young women have multiple problems beyond reproductive and cosmetic issues. So we have started this clinic in Srinagar, and we want this to be replicated across the country. We have also put some initiative being attached to PCOS. We have started public awareness programs. We have also started the society. We found that knowledge attitude about among clinicians is very less about this disease, and there is need to actually inform our clinicians, paramedics as well as public about the existence of disease and the metabolic ramifications which we get. So we have started a study, started a society, metabolic syndrome, pre-diabetes, PCOS society. The name is big, but it is just to sensitize people that we need to look into metabolic aspects of PCOS. This society, we had yesterday only a meeting in Srinagar, 6th annual meeting. We have started a registry to note down patients beyond government centers, from private clinics also, because the ICMR only allowed us government centers to be included. So we have also out of this task force, we have put several normative parameters of hormones, biochemistry in these reproductive age women, and this will be a basic fundamental parameter to compare in future. There are unfulfilled issues, like we have to rename this condition. It is not a polycystic ovary disease. We have to revise the criteria of diagnosis. We have to look at Indian guidelines, and we have to see what is the pathogenesis using this biobank, especially the transgenerational impact. Because what I believe that this dysmetabolism in a pregnant mother is likely the reason of diabetes epidemic, CAD epidemic, fatty liver epidemic, whatever is happening. And if we are able to take this transgenerational impact away, probably we may reduce the impact of these NCDs on our economy in our country. So I conclude that PCOS is a metabolic disease. It should not be considered as a cosmetic or a reproductive issue. We have to intervene early, especially during pregnancy. We need to do more research, but we need policy making in the government. And I think anybody in this hall, everybody is related to PCOS. It is just not a condition which is only limited to gynecologists or endocrinologists. So in the end, I thank the chairpersons, and I thank a word of gratitude to NAMS for giving me this honor to be here. So I acknowledge my collaborators at SKIMS, at AIMS New Delhi, my mother, my wife, and funding agencies. Thank you so much.
Thank you so much, Dr. Aniki, your extensive years. Next,
I think we go to
there is
the
no
next.
question and answer yet.
This is very prestigious. Again, KLB recognition or academic excellence. And I think we have Dr. Tejinder Singh. He's one of the pioneer in medical education in the country. And I remember the medical council, I think, has the training center that he was heading to train the faculty from the medical colleges. He is now as presently associate with, I think this is Adesh University, Bathinda. He is chairing the Center for Health Professionals Education Center. Dr. Tejinder Singh, thank you.
Thank you, sir. I thank NAMS for providing me this opportunity to be here and share some of my views with this august gathering. Yesterday, when I was traveling from Ludhiana to come to Delhi by Shatabdi Express, after the breakfast was over, there was an announcement on the public address system that a passenger in coach C11, seat number something, has fallen sick. So if there is any doctor on board, can you please come and see this patient? So I offered my services, I went to that coach. There were a lot of anxious faces around. Nobody asked my degree. Nobody asked my attendance or my marks or my medals. But I could sense that there was a silent question all around, and that was, can we trust this doctor? I suppose this is the question at the heart of competency-based medical education. I would be taking a reflective view, and some of the visuals that I present here are AI generated for the sake of better understanding without any data or patient issues. Now, clinical competence, when we talk about it, it sometimes happens to us that it's a recent phenomena. But some 2000 years ago, Charak had given us the attributes of a competent physician. One with knowledge, skills, experience, dexterity and purity of intent. And as we look to the contemporary definition of clinical competence, it appears to me that it's a purely copied Sanskrit into English. There's hardly any difference. You know, the language may have changed, the technology may have changed, but the human expectations have not changed, and they remain the same as they were about 2000 years ago. In the last century or so, our thought process about competence has changed. 1910, when the Flexner report came, it equated competence with knowledge. And from knowledge alone, we have actually moved on to performance, to adaptive performance, to entrustment, and to identity. However, behind all these frameworks lies the same question: how do we create competent physicians to serve the needs of the society? One of the enduring definitions of competence, and please compare it with the definition of Charak that I showed you last little while ago. It says that competence focuses on wise use of communication, knowledge, skills, emotions, and values for the benefit of the society. The key word here is judicious, because medicine cannot be practiced by algorithms alone. It requires a human mind, it requires a thought process. And I hope you have also noticed that in this definition, communication has been given a precedence over knowledge and skills. A learner may perform very well in calm circumstances, but may falter under pressure. The same individual, different contexts. And this context dependence of competence requires that the teaching and assessment for competence must be flexible, relevant, and adapted to the context. So it is not possible to have a standardized one size fits for all when you are teaching the medical students for acquiring competence. Competency-based medical education again has multiple definitions, but the most commonly used one by international CBME collaborators says that it's a approach which designs curriculum, teaching, assessment and program evaluation in the framework of competencies. And what is interesting here is that we are not talking about the time spent, we are not talking about the hours logged, but about the competencies which have been acquired by the student. Several factors have recognized the importance of competence and they have been pushing for competency-based medical education. Society demanded accountability, patients demanded safety, short half-life of medical knowledge required doctors who continue to learn even after getting their degrees, and regulatory bodies wanted the doctors who are competent. So all these keep on pushing the competency-based medical education, and in the coming years we are likely to have more such things. Now what has competency-based medical education done? If we look at the experience of the last 50 years or so, it has given us clarity, and that's a big achievement. It shifted the focus from what we teach to what the learner can do. It allowed us to articulate the outcomes of training, and more importantly, it reminded us that graduation is not attendance. Graduation is readiness to practice. Yet every reform develops distortion. Even good ideas require course correction. Clinical practice is complex, uncertain, relational and dynamic. Yet our systems sometimes fragment it into small measurable units. That may be okay for observation, but it's not important for or insufficient for understanding. Understanding of competence by the student and understanding of the student's level by the teachers. Both have a problem with these multiple fragments. A procedure done correctly is valuable, but deciding when to do, when not to do, how to explain it to the patient or relative, how to respond when things go wrong, this is competence. Now, if we do not differentiate between skill and competency, then we keep on certifying performance without looking at the capability. Competency is about doing, about performance. Professional identity is about values, responsibilities, and belonging to a profession. Please remember that identity shapes behavior long after the examinations and training is over. And we run the risk of producing technicians rather than reflective practitioners if we do not distinguish between skill and competency. And then comes the administrative burden. Those of you who were involved with the new curriculum would remember the time, energy, effort that we spent on creating timetables, multiple iterations, multiple hours spent. Now when documentation grows, in fact learning shrinks. But that is not the real danger. The real danger is that the patient disappears from the scene. So we are more worried about completing forms, sending reports, posting it up on the website, rather than teaching the students how to deal with the patient in a competent way. Assessment deserves a special mention here, because in education, assessment can quickly become the curriculum, and the students would read about what is asked rather than what you want them to read. The real purpose of assessment is not grading the past. The purpose of assessment is predicting the future readiness, making responsible judgment about readiness for tomorrow and readiness to practice. Now, since competency differs from skill, as I discussed a little while ago, the assessment has to be at the level of competency rather than at the level of segregated knowledge and skills. We sometimes collect endless fragments of assessment, but many fragments don't automatically become a whole truth. Rather, it results in wastage of time and giving a wrong direction to the students to plan their learning. we have envisaged 7 roles for the Indian medical graduate. Now, if you look at these roles, then many roles like leader, professional, communicator, there is this scoring. Even if you were to score these roles, tell me how many marks is leadership worth? Or what would be the pass percentage of professionalism? Or how do you combine the results of leadership with professionalism? Now, these are some of the issues which cannot be done by numbers alone. And what is not assessed is not learned. Just take a second to reflect that even after 80 years of having an independence in our country and teaching medical students, not a single institute in the country assesses professionalism. But we want the graduates to be professional. That somehow may not happen actually. Quantitative assessment is anyway reductionist because complex performances cannot be split into binaries. You cannot just have pass fail or you just can't have yes no. It doesn't also provide enough feedback to the students. And when metrics become heavy, then people try to optimize the metrics rather than to learn. This is what is called Goodhart's law and is very well known in management science. It's unfortunately equally applicable in any educational setting. Measure what is easy to measure, ignore what is important but difficult to measure, and then act surprised by failure. This distorted assessment, because of our obsession with objectivity, has a name. It's called McNamara fallacy. And I'm sure you know how the name came into being. In this situation, subjective judgment remains indispensable, especially when grounded in repeated observations, multiple perspectives, and accountable standards. It is invaluable for assessing those aspects of competence which often remain hidden, just like an iceberg which shows only a small part at the top, but much of it remains hidden underwater. And especially for formative and internal assessments, subjective assessment can play a very significantly useful role. I therefore strongly emphasize that assessing for competency is much more than using only MCQs or ASCIIs. Sometimes stories can tell us a lot of things which policy documents and other write-ups do not. And Mahabharata is one such example which can actually give a lot of ideas about what we can do to make most out of competency-based medical education. We heard about Eklavya. He had dedication, he had talent, he had discipline. He knew about Shastra, but he didn't know about Shastra. And skill without knowledge has its limitation. Then there was Duryodhana. He knew Shastra, he knew Shastra, but he lacked ethics. Being capable without being ethical is dangerous. And then there was Arjuna, the perfect blend of Shastra, ethics, professionalism, communication. In fact, that is the kind of doctor we seek to produce and graduate. But when the time to use his competence came, he gave up. He simply gave up. And at that time, Krishna didn't ask him, okay, you don't want to fight, go for another fellowship, come back, then we'll fight. No. What Krishna did was to listen to him, clarify his doubts, and help him move on to the righteous path which he was supposed to be doing. I hope you understand this slok, Atova prapasi swargam, jitvava bhokshase mahim. Tasmat utishta kaunteya yuddhaya krat nishchaya. So rise, son of Kunti, and decide to fight. This has many messages for us. One, that competence is a combination of knowledge, skills, attitudes, ethics, and professionalism. Two, a person may be competent in calm environment, but when stress, pressures come, there is a problem. Three, the context makes a lot of difference. Arjun was trained to fight enemies, not his relatives. And fourth, a mentor can play a very useful role in implementing competency-based education. Thank you very much.
Thank you, Dr. Sanjay Singh, for your sharing the crux of medical education. I think we go to the next awardee.
Good afternoon. So for Dr. Abhay Indrayan, recognition of academic excellence in the field of epidemiology, biostatistics having relevance of health science, I would like to invite Dr. Tinku Thomas. He is professor at Department of Biostatistics at St. John's Medical College, Bangalore. Dr. Tinku, please. And congratulations for recognition.
Thank you, sir. Respected Chair, Dr. Sinha, Professor Behera, esteemed members of NAMS Council, thank you for this opportunity and the recognition for being chosen as for recognition in biostatistics. And I'm deeply honored to be named, given this recognition in the name of Dr. Abhay Indrayan. Today I'm going to speak about the science of linking data and evidence-based practice, which is my area of expertise, which is biostatistics. So statistics and biology has been linked from the very beginning. And if you look at Carl Pearson, who first instituted a department of statistics in a university, he was involved in the study of biology and anthropometry. And if you move on to Dr. R.A. Fisher, who was contemporary of Professor Carl Pearson, and he too was a geneticist. So from very early on, statistics, which is a mathematical science, and biology and statistics have been very much linked. And if we think about Professor P.C. Mahalanobis, who was the eminent statistician from India, and if you think about his work, the statistics by which he is very well known, which is the Mahalanobis distance, was actually developed in order to distinguish anthropometric measurements of Anglo-Indians. So there is a very deep connection between statistics and biology. And what I'm going to speak to you today is about some of our work that we have done at St. John's in the area of biostatistics. So diagnostic testing is very important, and when we develop a new test, what we try to achieve is good accuracy of the test. And we have many indices to define this accuracy, which is sensitivity, specificity, and so on. And we also power it up with calculating the 95% confidence intervals, which tells us how good these estimates are. But at the center of these calculations is what is the gold standard measurement. And many times we don't have such a gold standard measurement and what we can do. And this is a classic example where we did this study among sepsis patients in the ICU. And what is the standard procedure for identifying sepsis, which is a microbiological test, gave us only 20% prevalence, whereas a newer test, which are molecular-based tests, had 50% prevalence. And there was a big difference in the prevalence. And it was very well known that the microbiological tests are not really gold standard. And how would you really evaluate the accuracy of this new molecular test? We applied Bayesian statistical methods where we drew data from earlier knowledge of what exactly would be the prevalence of sepsis in such a situation. And with that information, we could arrive at the estimates of sensitivity and specificity of this new molecular test. and also a corrected prevalence, which was 43%. So this was an application where we used classic Bayesian methods to evaluate new tests. When we use cutoffs, that is when we are using continuous data, this becomes even more challenging in classification of diseases, and what we usually use is a cutoff in that continuous measure, and anemia classification is a very good example for that, where we identify a cutoff for hemoglobin and classify individuals. And we know that the National Family Health Survey reports a very high prevalence of anemia in India, which is about 58%. But the question always remains as to, can the prevalence of anemia be so high? And is there a problem really of the cutoff of anemia? To explore this, we looked at the enhanced data, which is from the US. So these are people who are living in the US. We selected healthy individuals from that population and looked at different classes, that people with different origins. And what we could clearly see that the distribution of hemoglobin in this population was different. That means shifted to the left for the Asians as compared to the whites. We showed that there seems to be a difference in the distribution of hemoglobin even when they are in the same setting. So we wanted to understand this better, and if we actually look at the origins of the cutoffs of hemoglobin, and this is the 1968 report of WHO defining anemia, it is very clearly said that the figures, that is the cutoffs, were arbitrarily chosen, and since they could not define normalcy of the population, that is the population in which they derived this cutoff were perfectly healthy and normal. So these are, the arbitrariness is clear here. And the very recent book that has that WHO has published, which re-examined the cutoff of anemia, there again there is a discussion on which should be the population that should be considered, whether one should consider the 5th percentile or the 2.5th percentile. So whenever statistics and data becomes a part of cutoff and as a background of cutoff, one has to be careful. And this is even more important when the distribution mean itself or the average itself is very close to the cutoff. Very small shifts in the cutoff can bring about great changes in the prevalence. Like in this case, in the earlier study, in the enhanced data, if we try to identify what is the 5th percentile, that happens to be 11.2%. So 11.2 grams per deciliter is the cutoff of anemia. And if that is the case, then the prevalence of anemia in NFHS drops to 36 from a 58. So the message here is that when we are using distributional cutoff and statistics as a basic of classifying individuals as having a disease or not, one has to be very careful where you are applying, what is the distribution, and it is even more important when we use all of these in public health. So it is better, rather than having binary classification, sometimes it might be better to just use a probability approach. So what we are asking is to talk about the probability of being at risk of hemoglobin rather than classifying individuals as being anemic or not. And this can be very simply done if we have a distribution of healthy individuals in whom we know the distribution of hemoglobin, and then we compare it with the population that you want to evaluate. And this method can be applied to any distribution. It needn't be symmetric distribution like in the case of hemoglobin. It can be even a skewed distribution. So we have applied such methods for identifying undernutrition in under 5 children using the WHO standard data. So we should be getting more accustomed to using probability approach where we are talking about risk rather than classifying individuals into binaries. When we think about any disease, we are also interested in identifying what are the risk factors that are associated with the disease, and classic regression models are applied. But what if we don't have the exposure and the outcome in the same data? And this problem exists. So this is an example when we are interested in looking at the problem of anemia again in the population, And if one is interested in seeing how iron intake is associated with anemia, we don't have one single data set in the country which has captured hemoglobin and dietary intake. Of course, right now the ICMR-funded DAPSI study is there, but in earlier days this was not available. And in that case, what we did was to combine two independent surveys, which is the National Family Health Survey and the National Sample Survey, which had diet data, using a method called statistical matching, where we could build a data set which had both anemia and dietary intake. And with this, we could see in which states iron fortification would work as a strategy to combat anemia. Moving on to clinical trials, which is considered as a better method or better research method for ascertaining causal effects. More and more we are coming across non-inferiority studies, superiority studies, and so on. And in this case, what is most challenging is to identify a non-inferiority margin, which we have to define a priori even before we do the study. And considering whether a absolute or a relative difference is important is a matter of great concern and must be debated. Much time should be spent on identifying what these margins would be. And I was fortunate to be involved in this particular trial on calcium supplementation, and we debated a lot on these cutoffs and so on. And moving on from the same data, we had the opportunity to explore the adherence to calcium supplementation as an outcome. And we used time to event analysis, which is otherwise called the survival analysis. And what happens with adherence is that we can have multiple events of non-adherence during the course of the trial. And this was called repeated outcomes or repeated events. And in time to event analysis, this is well defined, but the challenge here was when some of the subjects or when some of the study participants exited the study a little earlier. So we had truncated time points in such individuals. We came up with a method of weighting so that the truncation was taken care of and we would have a correct estimate of the repeated outcomes. This was a PhD work of one of our students. We have also worked on diet optimization. You can see that much of my work has been in relation to nutrition purely by fact that I am in St. John's, and we have a strong nutrition team there. And what we are doing is linear and non-linear programming, which is mathematical programming, to identify the right combination of foods and the right quantities in order to make sure that the population gets the right amount of nutrients in the required amount. And we are using this now in the ICDS supplementary nutrition program, both in the take-home ration and the hot cooked meal, and this has been developed into a tool which the government has used, and we are now trying to implement this in some of the states in the country. I'll conclude with this. All of this have been possible because of the wonderful team that I work with. I should especially mention Professor Anurag Kurpat, with whom I've been working for 2 decades now, and much of my work in nutrition is along with him. Thank you very much.
Thank you, madam. Next, we will listen Dr. Niranjan Khandelwal recognition for academic excellence. I will to introduce Professor Dr. Naveen Kalra. That's a professor, Department of Radiodiagnosis, PGMR, Chandigarh, with an excellent interventional radiologist. And Dr. Naveen, you go ahead.
Thank you, sir. Good afternoon, everybody, and it's an honor to be speaking here in the presence of such stalwarts on this dais and off the dais. And I'm really honored to be receiving the Dr. Niranjan Khandelwal RAI in Interventional Radiology. Dr. Khandelwal, the former head Department of Radiodiagnosis at PGIMR Chandigarh, is a world-renowned neuroradiologists who developed neurointerventions in India and started the first DM program of neurointervention radiology in India, also started the first DM program of intervention radiology in the country. Also feel extremely indebted to my institute, PGI-MER, where I've been working since '98, first as a senior resident and then in a faculty position. Very, very grateful to my guide and mentors, Dr. Veena Chaudhary from Maulana Azad, Dr. Sudha Suri ma'am, and Dr. Khandelwal at PGI-MER, Chandigarh. I'll be speaking on loco-regional treatment in hepatocellular carcinoma, target, treat, and triumph. I think the battery on the here is running low. That's the message I get here. So, and I have the AV team to please help here. So surgery, as we all know, is the treatment of choice for HCC, and unfortunately, majority of these patients are not suitable for surgery due to extensive intrahepatic tumor involvement, extrahepatic disease, and poor liver reserve. We have ablations, the transarterial chemoembolization and transarterial radioembolization, TACE and TARE, as I'll be referring to them from now on, are the common loco-regional therapies in hepatocellular carcinoma. Whenever we think of treating these HCCs, we have fallback on the Barcelona Clinic liver cancer staging system. And if you look here in the very early and early stage disease tumors up to 3 centimeters and up to 3 in number, we have ablations playing a very important role. If you look at the intermediate stage of hepatocellular carcinoma, that is the B1 stage, B2 stage multinodular SCC, with preserved portal flow, with selective vascular excess. Those are the candidates for transarterial chemoembolization. Also, tumors up to 8 centimeters in size are candidates for radioembolization or transarterial radioembolization. So, I have been a member of several task forces of the Indian College of Radiology and Imaging and the Indian Society of Vascular and Interventional Radiology, giving forth guidelines and consensus statements for management of hepatocellular carcinoma. And I've also been member of the Indian National Association for Study of the Liver Task Force on HCC. Acharya sir is here. He has been spearheading it, and we've been giving forth consensus statements on the management of hepatocellular carcinoma. So, INAZL came forward with a modification of the BCLC staging system, which is I think more practical and more user-worthy in our setup. And in this, if we look at the intermediate stage HCC that I talked about, it was the B2 which was mentioned in BCLC, but INAZL also recommends the use of endovascular therapy for the B3 stage, where it is a multi-lobar, multinodular infiltrative type of HCC. Also, the advanced stage of hepatocellular carcinoma has been further divided into C1 and C2 stage in this task for recommendation. And in the C1 stage, which is basically the portal vein invasion by the hepatocellular carcinoma, but there is no extrahepatic spread, comes in the role of endovascular therapy in the form of transarterial radioembolization, while in C2 we do not have this loco-regional therapy coming in. So we recruit all our hepatocellular patients in the interventional radiology clinic, which we started in 2018, the first clinic in a government setup, and we provide all these patients longitudinal care right from their recruitment to their follow-up, meet them twice in a week. So coming now to the specific loco-regional therapies, the ablative therapies, the chemical ablations, is ethanol, thermal ablation, RFA, and microwave, and cryoablation, first time started in our institute in the country, and non-chemical, non-thermal ablation, irreversible electroporation, again started for the first time in India at PGI-MER. So if you look at these images, when we talk about ablative therapies, the concept is localizing and staging a lesion on cross-sectional imaging, CT or MR, then localizing it on the ultrasound, using ultrasound or CT, putting in the needle, and then delivering the energy, whatever we have. If we have RF and microwave, we'll get gaseous shadows within the tumor as we burn it. If we have cryoablation, we'll see the ice ball. So ethanol injection, in this 95% ethanol is injected, leads to protein denaturation and cellular dehydration, causing coagulative necrosis. Also small vessel thrombosis sets in, leading to ischemic tumor necrosis. But the downside is that the local recurrences here are high. RFA, on the other hand, in this high frequency alternating current is passed into the target tissue from the electrode tip, leading to frictional heat after rapid oscillation of ions. The results of RFA are as good as resection, at least for the first and 3 years. With 5 years, there may be lesser overall survival, but it suffers from heat sink effect, meaning that if you are treating a lesion close to a blood vessels, the flowing blood within that blood vessel will take away the heat, and you will not you will have a suboptimal ablation. So this is our patient where we treated. This is, you can see the cirrhotic liver with a HCC. We put in the needle, delivered our energy, and 3 months there is no tumor. 6 months also there is no tumor, as you can see within this red circle. We looked at radio frequency ablation in our unresectable HCC cases. The ablation success rate was 81%. The survival rate was 63% at 1 year. The complication rate was low. We also tried to see whether combining radiofrequency ablation with ethanol, this is some time back, whether we can actually increase the effect of either. But here we found that the survival rates at 6 months were 84% in the RFA alone cohort and 80% in the combination group cohort. So there was no advantage of combining RFA with ethanol in this subgroup. Microwave ablation, here it is the less pronounced heat sink effect, and you can deliver higher temperatures at the target tissue, uses electromagnetic waves. There's a patient here, you can see the black arrows point to the hepatic vein. So if you have a tumor close to vessels, this is again the ultrasound showing the vessel close to the tumor. So you put in your microwave ablation and do your ablation procedure, and 3 months follow-up shows no tumor at the site. We were also the first facility to start cryoablation, and here for liver tumors, and here rapid expansion of the argon gas leads to the Joule-Thomson effect, leads to formation of the ice ball at the tip of the probe. And there is the advantage is there is no collateral damage where we are ablating the tumor, and this works on coagulative necrosis by rapid freeze and thaw, direct cell injury due to crystallization of water molecules, and the interruption of the microcirculation, and induction of apoptosis is also there. So this is a patient, a centrally located tumor as well as in the caudate lobe. So this was a perfect candidate for doing a therapy where there would be less collateral damage. You can see the ultrasound and the CT images showing the ice ball. The arrows point to it in the tumor. Again, the caudate lobe lesion, we see the ice ball present within the tumor as it gets ablated. We published our initial data. This was the first from the country because we started doing it. So we achieved technical success in all our patients. There was complete response in 78% patients, no complications, and no local tumor progression. Our group has also looked at in a meta-analysis where the utility of cryo. We compared it with RFA, microwave, and cryo, and for very early and early stage HCC. And we found there's no significant difference in the overall survival and local recurrence at 1 year and 3 years following ablation of very early and early HCC. Irreversible electroporation started in 2014 at PGI-MAR, and again here I will like to give credit to Professor Yogesh Chawla, who helped us start this facility, and after that we didn't look back. And at that point this was the map. We were the only facility in the entire country to be doing IRE. So this is a technique, a non-thermal technique. We deliver 70-second micropulses, high voltage using parallel probes, creates irreversible pores in the cell membrane. There is apoptotic-induced cell death. The good thing is that the connective tissue framework and vital structures are not damaged, and there is no heat sink effect. But you have to be very accurate in the precision and precise in the placement of your probes within the tumor. Works best for perivascular and peribiliary HCCs and in subcapsular lesions. So this was a study over 3 years. We looked at 21 patients of HCC using IRE based on tumor location. Most of them were subcapsular or perivascular lesions, and some were peribiliary. We found that the median time for local tumor progression was 4 months, the median local tumor progression-free survival was 7 months, and the 6-month progression-free survival was 72%. These are one of the patients where you see the centrally located tumor, a very difficult location to do a thermal ablation. We put in multiple probes and did our ablation, and there is no significant arterial or venous injury. So some capsular leak happened. So again, meta-analysis looking at IRE in the treatment of liver tumors, we found that HCC was associated with a better overall survival at 12 and 36 months compared to IRE treatment for cholangiocarcinoma and metastasis. Now, moving now to the endovascular therapies, which would be catheter-based approaches, the bland embolization, conventional TACE, drug-eluting beads, and the transarterial radioembolization, wherein we first reach the vessel supplying the tumor and then selectively embolize. For transarterial chemoembolization, we use iodized oil with doxorubicin, but we won't use it when there is portal vein malignant thrombosis and where there is impaired hepatic function, the childhood 8 or greater. This is a study where we've looked at the outcomes of conventional TACE with tumor histology and biochemical parameters, and we found that there is statistically significant correlation between histological grade and the 3 months outcome. Now, TARE, the last modality where we give beta radiation by the endovascular route. This is a non-embolic therapy, and this is a patient with a large tumor in the left lobe of liver. So we went in endovascularly, found the selective vessel using the microcatheter, delivered our Y90 therapy, and we were able to downstage this tumor, and the patient could undergo liver transplantation. Our experience with transarterial radioembolization, we found median overall survival of 15 months, the median local progression-free survival of 4 months, and the overall response rate, which includes complete response and partial response, to be 58%. So these are the advanced stage HCC patients. In our facility, we are using for these endovascular treatment a combination of hybrid angio-CT, which means in the same table, patient will undergo fluoroscopy evaluation, a DSA, as well as a CT on rails. And the advantage is it provides a large field of view. There is faster acquisition without breath holding. We get less susceptible to motion artifact, and you can get images of diagnostic quality with rapid multiplanar and 3D reconstruction images. This is one of the patients. You can see that there is a very subtle lesion seen on the CT and MR, but when we do our catheter angiography with the cone beam, with the angio-CT, we can see very, very exquisite details of the vascularity of the tumor, and this helped us to do the endovascular therapy very easily. So we've also looked at patients using angio-CT and using this endovascular treatment, and found that angio-CT actually yielded 87 new observations in this patient cohort, and 16% of them were either probably HCC or definitely HCC on follow-up CEMR at 6 months. We've also looked at the response assessment of hepatocellular carcinoma to loco-regional therapy using MR elastography technique, and we found that the tumor stiffness was significantly lower in the treated versus the untreated tumors. This is one of the patients where you can see the tumor in the left lobe of liver. Pre-procedure MRE, the elastography value was nearing 7 kilopascals. We treated with transarterial chemoembolization, and post-procedure, these are the images, and the MRE was reduced to near about 6.2 kilopascals, which was significant. So to conclude, loco-regional therapy for HCC plays an integral part in its management. Targeted treatment with ablations and endovascular therapies are required for different stages of HCC. A combination of various therapies may be used in different stages of HCC at different times. The outcome evaluation post-treatment is also evolving. In 2015, published this editorial, Loco-Regional Treatment for HCC. The best is yet to come. And in this decade, we added IRE and cryo. I'm sure this statement still stays there, and we are going to have more modalities coming in the future. And I'd like to acknowledge and thank my family at home and the IR team at PGI-MER Chandigarh. And also, we have a strong bond with the hepatology department. We work in collaboration, presently headed by Dr. Ajay Duseja, carrying on what we had the the legacy with Dr. Chawla and Dr. Dhiman. So we work strongly, we work in collaboration, and that's how we are able to give our results. Thank you very much.
Thank you very much, Professor Kalra, and congratulations for recognition. So I would like to invite for next recognition, Dr. R.V. Razam, recognition of academic excellence in the field of community health, communicable diseases, leprosy, and sexually transmitted diseases. So I would like to invite Dr. Sonu Goyal. He is professor in department at the School of Public Health, PGI, Chandigarh. Thank you.
So respected chairs, thank you for the generous introduction. So in public health, impact is not measured by the institution we build, but by the lives we touch. So a very good afternoon to all the esteemed members and fellows of National Academy of Medical Sciences and distinguished colleagues. As a young public health researcher, so it's my privilege to deliver a talk on my journey as a community physician. The profound philosophy has long guided the field of community medicine and is deeply reflected in the vision of Dr. R.V. Ranjam, who emphasized that the patients must be treated with compassion, dignity, with a strong focus on prevention and rehabilitation. His approach underscored the importance of moving beyond the episodic care to more holistic, human-centered model of health. It is with this philosophy that my journey began to take shape, not just academically, but through a real-world engagement. For me, it was community. My journey in community health has been a series of isolated experiences, but a continuous and evolving progression shaped across diverse institutions and roles. It began with my founding education in Kendra Vidyalaya, being my father in Air Force, where the commitment, discipline formed the core part of my early development. Thereafter, building on this foundation, I began my MBBS training at Indira Gandhi Medical College, Shimla, which marked the crucial step in shaping my understanding of medicine. During this phase, I was introduced to clinical environments where I utilized the essential skills in patient care, basic clinical assessment, and teamwork. Through postings and practical exposure, I learned the importance of effective communication, team building, and various other aspects of empathy in patient care. During my MBBS, I developed interest in community health, pursued my MD in community medicine, during which my perspective have actually evolved from individual patient care to a comprehensive population-based approach. This phase was instrumental in developing the core competencies which are expected from a community physician, that is, an epidemiologist, a program planner, a critical thinker, and the evidence-based decision maker. Thereafter, my training has actually developed my skills in leadership, team building, coordination, and problem-solving skills, especially in the resource-limited settings. I worked primarily on the social determinants of health, as I understood that it is not the individual which we need to take care. We need to take care of the social determinants of health if we want to improve the community. This evolving perspective was further deepened with my training of senior residency in PGI Chandigarh. Here, my engagement with underserved community during my senior residency transformed my theoretical knowledge, which I have gained during my junior residency, to various outreach activity which I performed during my tenure of senior residency at PGI Chandigarh. And I was also fortunate to have other administrative roles in PGI Chandigarh besides it. Thereafter, I was posted in UNICEF in northeastern states of our country, where a young public health researcher rarely venture into Manipur or other states. It was, I'm talking of way back in 2005. So there I understood that it's not only the individual or a comprehensive patient care which is important, but the systems and the governance plays an important role in shaping the future of public health. I joined Rajendra Prasad Government Medical College. Thereafter, I joined Rajendra Prasad Government Medical College, Tanda, Himachal Pradesh, where I incorporated all those practical experiences which I gained from senior residency and UNICEF to the teaching, because I always believe that we can improve the teaching only when we can have some practical examples from the field. So I tried to have those community medicine, which is normally considered as a relatively dry subject, into something which is more practical, which is more, which shapes, which actually is more example oriented. So thereafter, after that, currently I am working in PGI as a professor, and my work now spans across the three things, which is capacity building, research and service delivery, each contributing to strengthening the health systems and improving the community outcomes. I understood that teaching, service delivery and training are not isolated pillars. They are all integrated, they are all interconnected, and only when we think of all these three pillars as interconnected pillars, then only we can improve the community health. My contribution in teaching and curriculum development span multiple programs, which is like Masters of Public Health, Bachelor of Public Health, MD Community Medicine, and the doctoral program. As rightly stated, that teaching is not just merely a transfer of knowledge, but it should foster a thought of critical thinking, and it should be interesting, made with practical examples. I try to use the examples from my the previous work which I was there in improving the curriculum of community medicine in our PGI Chandigarh. Thereafter, contributing to institutional teaching within the department, it was time to expand the horizon. And that's what something interesting happened. I always have a belief that the doctors are very well trained in their clinical disciplines. But when it comes to team building, when it comes to communication, when it comes to emotional empathy, we are not trained into that. So I try to inculcate, I try to improve upon those skills during my master those skills, and try to have that through a program which I termed as an International Public Health Management Development Program. I always thought that what if anything which is new, it can be failed, but failure can always be a case study. It's not always success which becomes a case study. Even so, that's why people was telling that why you are conducting a leadership program being in a medical discipline. So I thought that let us take a challenge, and I conducted that program, and this is just a small journey of the program.
The developing nations are still struggling with infectious diseases. NCD burden continue to rise. All of these disturbing numbers are on rise due to the suboptimal functioning of health systems. Leadership training among healthcare workers helps them to work efficiently in finite resource settings. Call for the first course in 2016 received a great response, even though it was self-sponsored by the participants themselves. 100+ nominations were received, and we selected 36 participants from 15 states of India. One of the alumni of the first course was selected as a director of cultural relations in Peru. He went there and convinced the ambassador of India in Peru to conduct a similar course in Peru, but it had to be conducted in Spanish. And with the call, the program got an international platform in 2017. Consequently, a flagship program of the Ministry of External Affairs, and international technical economic cooperation was set up. These are the few glimpses of IPHMDP courses over the years.
With our programs expanding reach, spanning over 96 countries in less than 9 years of inception.
Program is unique, it builds capacity, it makes you a better leader. So I want you to be involved with it, speak to your government also to talk or partner with the Indian government so that you can acquire the knowledge we have gained in a short period of time.
The methodology that you are using, I find it very practical and very easy to follow and very fun as well. We don't feel like we are really in a training, like it's a combination of learning, interacting with other participants.
IPHMDP building while the developing.
So this is the phase which I was talking about, started in 2016, and over a period of time, now we have multiple courses under the overall domain of Ministry of External Affairs, which PGI is conducting, and PGI is the only institution in Southeast Asia which has been conducting these leadership program for last 10 years. Thereafter, another innovation occurred with the state of Odisha. The community health officer forms the backbone of any public health now. So we try to develop a model again for community health officers, which is a very interesting model which has been developed, and we are training these community health officers again through this gamified approach, and it is very cost effective program which has been still running with the government of Odisha, and now Ministry of Health and Family Welfare intends to take this program forward for other states. So I always say that all these things is not possible alone. It is only with the collaboration and with the knowledge partners, and we involved NHRC, National Academy of Medical Sciences, and AIMS, and many other institutions in taking all these things forward. And these are the capacity building initiative which is currently running. Thereafter, the service delivery is another component which I must say, and we started with the supportive supervision with one block in Ambala district as a part of our field service program, and I am happy to share that that block has been consistently scoring the first block in the entire state of Haryana when it comes to various indicators. So this is the journey in advancing community health. I would like to take a glimpse of this small video again for community health. These are all my old pictures of senior residency when I was there. I worked with Sapera Basti, which is a very underprivileged community in Narayangarh district, which streamlining of immunization clinic there. So these are many activities which we have been conducted for community health, and I always believed in inverted triangle approach, where when you are in a resident, then you have to explore all the areas, but when you become a faculty, then you need to concise your areas and you need to work on specific areas. And thereafter, these are some of the work which has been done, and these are some of the achievements based upon my work at community health. And I always acknowledge with bottom of my heart my mentors who have shaped my journey of community health, and which actually led to where I am here. So thank you audience for listening to this talk. Thank you.
Thank you so much, Professor Sonu, for your interesting journey innovation, contribution in the field. And I think we come to the end of this session on presentation by eminent medical and biomedical scientists who have been recognized for their academic achievements and excellence in the field. I congratulate all of them, and let us give a big hand to all of them. And I think they all stuck to time. And I think, Dr. Kapil, you don't have to say anything on that issue. We finished the session before time. Thank you. Thank you.
Thank you very much, sir. We are most grateful to you and Dr. Sanjeev, sir, for helping us and facilitating this session. It was a long session, I must say. May I request Dr. Acharya to felicitate our chairperson. Please come, sir. इधर से आ जाओ सर. May I request all the delegates, participants, RAE recipients to join for the lunch. It's just in the just adjacent to the main building. Conference hall के पास में जो hall है उसमें lunch है. Please join us. Good afternoon. We start the proceedings of the afternoon session, and we have three most eminent scientists of the country. They will be making a state-of-art presentation. This session would be chaired by Lieutenant General P.P. Verma and Dr. Mahesh Verma. Dr. Sanjay Agarwal would join online due to his sudden commitment which has come up. So I request Dr. P.P. Verma and Dr. Mahesh Verma to take over, please. Thank you.
Good afternoon, ladies and gentlemen. I think this is one of the very important sessions, and as the Secretary, Dr. Kapil, has mentioned, we have got very eminent people to talk on special issues. Well, the first speaker is Professor A.B. Day. May I request Professor Day to come on the dais? And he's discussing on geriatric population. We all know that today India has got probably the youngest population in the world. Our average median age of an Indian is something like 29.5 or 29.8 years, around 30 years. Whereas other people in the other countries in the world, they have got growing aged population, but possibly in another 25 years or so, in 2050, we'll be matching the international population, and we will also be getting much older. I think today, possibly over 60, we have got 10% of population, and by 2050, we are going to have over 20% of the geriatric population. Professor Day, please. Maybe request Professor Day to come. He's talking online. No, I think he was very much here. He is there, he comes. Please come, sir. Professor Day has been the chairman, Department of Geriatric Medicine, and founder of the department at AIMS, New Delhi. Presently, of course, he is in Artemis as chairman, Department of Geriatric Medicine, and he has had special training at UK, and subsequently he has been advisor to government and in various specialties for geriatric medicine. He was a founder, president of the Indian Academy of Geriatrics, and has played a key role in shaping the MD DNB curriculum for National Medical Commission. I think he is going to talk about major health issue among older population and how to manage them. Professor Day, sir.
Just give us for the timeline.
I'll only request that since we have got 2 hours for 3 speakers, so kindly stick to 30 minutes, please.
Yeah. I'm extremely thankful to the National Academy of Medical Sciences and the President NAMS, Professor Behera, who is a year senior to me in SC Medical College, Cuttack, for 2 things. That giving a lecture to geriatric medicine in National Academy is a big thing for me, and also thinking me good enough to speak, because the speakers following me are very eminent people. So I'm extremely thankful to Dr. Behera and also to Dr. Umesh Kapil. At this point of time, the life expectancy of birth in India is about 73 years, and 13% of population are aged 60 years or more. And because we had the last census in 2011, the projection is that about 18 crore Indians are 60 plus. But I do presume that majority of people sitting here are either 60 plus or going to touch the proverbial 60 years limit. They will understand that things are not age easy or age kind of pleasant, age increases. But hold on, in next 20 years time, 25 years time, about a fifth of the population in India will be 60 years or more. And at that point of time, the number of children below the age of 14 years will be less than the older person or the persons above the age of 60 years. So that will be the cutoff year is 2050, where the graph will cross each other and the younger population will start going down and older population, which is anyway increasing, will further go up. This has got major challenges for the health system, because now also you see those who are in clinical practice can appreciate that the number of older patients in your practice are increasing day by day, and they create all sorts of challenges in clinical practice and management and finances and everything. But health in old age is not a random phenomena, and we age the way we work or we are destined to by our genetic inheritance. Where we live in the lifetime, living 4 decades in polluted Delhi, I can't expect to have a healthy life. Our health behavior, my Guruji and me had a lot of smoking done together, so now we understand that lungs are, Guruji is Professor Acharya. So we now understand that lungs have become weak, and also whether we are controlling our diabetes, hypertension, getting injected with vaccines that are essential for preventing pneumonia and influenza and diseases like that, and our access to healthcare, which is very important. Those who have access to health insurance are somehow protected, but not 100% protected, because most of the private insurances have their limit, and the CGHS, ECHS, they have got the limit, or they do not allow everything to be done with their funding, probably except Employees Health Scheme of AIMS, where virtually everything is taken care of. Other insurance schemes are not that liberal. But having some insurance is better than having none. So with all this complexity of all these colored cubes that you see, our health is decided. Sometime in 1997, after a lot of deliberation, Journal of American Geriatric Society made a consensus definition of aging. It's a very simple definition. When from fitness to unfitness comes in, you are aged. So all of us who were very fit 10, 15, 20 years back, and now feel not that so fit, that means we are aged. As long as you are fit, you are not aged. And our chances of survival is threatened every day with infectious agents, stress, physical dangers, etc. However, WHO doesn't believe in such a morbid definition of aging. So it thought healthy aging is a continuous process of optimizing opportunities to maintain and improve physical and mental health, independence, quality of life throughout the life course. And all those who have got exposure to WHO language, they always try to make look things better. But what I understand from this, whatever disease you may have, whatever disability you may have, there is still light at the end of the tunnel. So if one is independent and you have got good quality of life under the circumstances, probably you are living a healthy life. Healthy life is a developmental goal, so that's why United Nations and WHO have declared 2021 to 2030 as the decade of healthy aging, and all the governments in all over the world have agreed to this policy, and there are a few parameters that is none of our concern in this meeting. But that looks at health, long-term care, environment, etc., etc. So what is good health in old age? Let's understand biological decline, metabolic effects of life process, impact of exposure to internal and external environmental hazards are a part of life. So some decline is a part of healthy aging and is inevitable. And my Guruji, Dr. Kalyan Bakchi used to say, whatever you may do, whatever healthy life activity you may do, at the end of the day, illness will come. I now agree with that at the end of the day, some illness or other creep into your system and try to make you miserable. Identification of the deficit and prevention of at each level can lead to good health in old age. WHO always talks about preventive health, etc., etc. So whatever you may do, at least you should have access to healthcare, some treatment, diagnosis, etc., or admission to hospital at the time of requirement, access to a physician. Probably all that we can aspire to in an aging population. So these are the diseases of late life, diseases and disabilities of late life. All of you are aware of this. Acute, chronic health problems in the very old, when one gets into 80s and 90s and 100s. At this point of time, I am treating 3 centenarians, 100 plus. So obviously, all these things go on happening, some issues or the other. But what makes a difference to your life are the disabilities. The vision which declines either first by cataract, next by macular degeneration, difficulty in chewing. Our dentist colleagues will say if you maintain a good gum, your teeth will be all right, but I somehow do not agree with that. दांत तो ऐसे ही हो जाता है. Hearing deficit is a part of life. Locomotion and cognition, again, they are affected. But people don't come to me with all these definitions. They know that Dr. Saab ko pata chali jayega. What they come are challenges of cardiovascular health, cognitive decline, bone health, and the list is quite long. And as I myself go through the process of aging, I also feel many of the issues, whoever wrote this, wherever I copied from, are actually practically this happens. To all those who are in their 70s, 80s and 90s, they all suffer from this. I usually used to think if one escapes MI, probably life is good. But now I see heart failure is a major issue. So in Artemis Hospital, the patients we admit, they may not have any symptom. As we investigate and do this NT-pro, BNP, all of them have majority of them have heart failure. So one of my faculty who did his thesis under me, it was also surprising. In his thesis, I gave him cardiovascular health in 75 plus. He told about 80% have diastolic dysfunction, about 20% have diastolic heart failure. I never knew that. I signed the thesis, but never knew such a creepy thing was written inside it. So obviously, if one is a bit breathless and difficulty in walking, completing the same round of walk in the morning walk, please do understand, it's not depression. Your heart and your muscles are giving a warning. But my lecture is not a depressive lecture. I have some better things to talk about. So what affects the quality of life in old age these are the things: physical frailty, poor muscles, memory, etc., etc. And how we measure them, what matters to a geriatrician or a doctor who looks after older people is basic activities of daily living. There are 6 of them. Intermediate activities of daily living, 8 of them, and advanced activities of daily living, 3 of them. So if one is good at 6 and 8, 14, nice and fine. If one is bad at 6, then probably person is bedbound. And if he would be living in Western Europe or in America, he would be in a long-term care. But in India, all these patients who are deficient in basic activities of daily living are at home, taken care by their children or grandchildren or their daughter-in-law and son-in-law, etc. So in the practice of geriatric medicine, an older person in clinical practice is extremely complex. So what marks our practice is extreme complexity, multimorbidity. This is a term which became popular when COVID came in, and then you understood that there is a disease called entity called multimorbidity. That's a part of our clinical practice. On an average, in one of my earlier publications, every individual above 60 years of age who came to AIMS had 2.5 illnesses. Some degree of sensory deficit, hearing, vision, your taste buds, some deficit is there. Cognitive impairment is profound in our practice. Possibility of affective disorder, anxiety and depression are also there. There will be multiple disabilities, I have known them, I have noted them, and uncertain socio-economic support system. The joint family, etc., are good in Ekta Kapoor serial, but actually, frankly speaking, in real life, the joint family में कुछ नहीं होता है. So, who takes care of the old man or woman is a major challenge in the family. And now, as I look at patients discussing, somehow we in geriatric medicine do a lot of talking part of it. We don't look at time कि कितना time बर्बाद हो गया. Unless one does that, it's very difficult to understand what sort of things will work out. In the first look, they may appear very caring and everything. I have decided after 30 years in geriatric medicine, the man who is appearing most caring is suffering from a guilt complex that he has not taken good care. The one who fights with me or our doctors is probably a guilty man who is trying to show off that, okay, he is now concerned about his parents. Older persons are extremely heterogeneous. Some age-related functional decline is a part of life. Pathological decline masquerades as aging process. Clinical reasoning is affected by atypical presentation, multiplicity of diagnosis, and late presentation in health system. These are all the things that we do every day, and somehow it's not that difficult actually. Once you start look at older person in a different perspective. So what we do is something called, what is supposed to be done is a comprehensive geriatric assessment. It's a long definition started by an American lady, a British lady, Marjorie Warren in 1930s in Britain. After that, lot of changes have been done, but somehow majority of this comprehensive geriatric assessment look at physical health, functional health, psychological health, socio-economic environment, etc. But doctors hate it doing it. CGI is time consuming, doctors don't hate it, not suitable for large populations like ours. So there is a need for quick and effective tool. So who has the time? A CGI, standard CGI takes about 10 to 12 minutes. In a OPD, in any Indian OPD in primary or secondary care, probably in 10 minutes one will nip out 5 patients. Kiske paas time hai? Now also, even doing geriatric medicine, I also feel it's not possible to give so much of time to one patient doing CGA. So we started looking at different aspects of health and old age. There is a concept called intrinsic capacity, which is a combination of all physical and mental capacity of an individual, and functional ability, which is a combination and interaction of intrinsic capacity with the environment. If the environment is friendly and your intrinsic capacity is intact, then you are living a very good life. If there is any impact, any defect in any of the two, there is disability, quality of life goes down. This is a new concept about 10 years. So many of you who have, I think most of you do not know this concept. This is only a 10-year-old concept. We are trying to put it into clinical practice. So there is a need of healthcare to shift from detecting diseases one point in time and treating in fragmented way to look at function through intrinsic capacity and functional ability pathway. So these are the domains of intrinsic capacity: cognition, mobility, vitality, which includes nutrition, blood pressure, cardiovascular health, respiratory health; sensory, that is how good are the eyes and hearing; and psychological state, whether depression and anxiety are there or not. So these 5 things impact intrinsic capacity in different ways. We have not yet been able to globally develop a equation in which you can put value to each of them and make a score. We have been trying. So some of our publications in that way, in that direction are there, but it's an ongoing process. So this is the way intrinsic capacity is assessed. This is a WHO screening tool of ICOPE. See it for a minute because it's very difficult to read out because my vision is not that great. But cognitive decline, mobility, malnutrition, visual impairment, hearing deficit, depressive domain, etc. all are looked at. And after that, we look at step 1, we screen, and step 2, we do a detailed investigation. So we have tried to look at mobility deficit, malnutrition, visual impairment, hearing loss, cognitive decline, and depressive symptoms. From that, we try to do a further investigation if something is positive. So here, in this model, you only target the defects via the screening and not use a scale for everything, every scale in each patient. So where is the clinical utility of this? So we did some work on this. We tried to create a clinical construct of intrinsic capacity. So what it means are functional ability is equal to intrinsic capacity plus environment. And intrinsic capacity is all physical and mental ability. So we can develop a IC score or not and see how it is affecting functionality, mortality and hospitalization. So this is one of our paper which was published in 2022. We could do a 6-month follow-up only because the COVID came in and the project has to be stopped. So this shows that it's very difficult to project mortality in 6 months' time, but most of people who had defect in clinical intrinsic capacity, they got hospitalized repeatedly. So within that was a short period, short duration follow-up, but this is a longer duration follow-up of wave 1 and wave 2 LACI-DAT study, which has just been accepted for publication yesterday, and which is the intrinsic capacity and survival are related to each other. Those who have got lesser intrinsic capacity are likely to die earlier or risk of death is higher. The follow-up period was about 3.5 years. The gap between LACI-DAT 1 and 2 and the deaths were detected by various methods of community health, and we could detect that the intrinsic capacity is good in detecting or predicting mortality even in long term of 3.5 years or so. 3 years is a big time in geriatric medicine. 1 साल बच गया तो बहुत बात है. So what are the challenges that are evolving in geriatric medicine at this point of time? That is excessive aging and frailty, sarcopenia, cognitive decline. I heard of the term frailty when I was in 30 years back in Newcastle, and they had a frail elderly clinic. I thought probably this is an English word. At that point of time, definitions had not come. Actually, that was used as an English word at that point of time. Those who looked kamjor, marial, frail kah diya, and there's a clinic for them. My supervisor used to look at syncope, loss of consciousness and orthostatic hypotension in all these patients. So she had a clinic like that. I did not like that clinic at all. First, the English language in a different scale. North England English is a bit different from the usual English we speak. So somehow that was not a great thing to work with. But over a period of time, that probably became one of our major area of work. So frailty is a clinically recognized state of increased vulnerability and reduced physiological reserve in older adults, making them susceptible to rapid health decline from minor stressors. It involves a loss of muscle mass, strength, endurance, leading to higher risk of disability, fall and mortality. They are the people who get repeatedly hospitalized. Each hospitalization is a difficult strategy for the doctor treating. So these are the frail patients. So these are the components of frailty, physical and functional decline. It should be distinguished from the aging process as such. The assessment is done by two major paths, the American Frailty Phenotype, Linda Pride 2001, and Canadian Rockwood again in 2001 by accumulation of deficit. So Canada and USA, they fight each other. So frailty, Linda Pride and Rockwood fought with each other. So others thought, okay, in दोनों को मिला लेते हैं. So a lot more scales have been created by combining both the strategies of phenotypic defect, that is the defect detected during clinical examination, and accumulation of deficit, that we count what are the diseases one has and then see if there is more than 25% is positive, then the diagnosis is frailty and the chance of survival is very bad if there are 50% of disease conditions are there. Our frail patients have reversible course. When we started looking at, we thought no, it's not. Frailty means it's a one-way traffic, but now with new drugs, treatment, etc., frailty can be reversed. The second component is sarcopenia. Sarcopenia is age-related progressive loss of skeletal muscle mass, strength and function starting at the end of 40, accelerating after 50, 60. Symptoms include weakness, low walking speed and fall. So aging naturally aging leads to natural loss of muscles. As you see, most of the tennis players retire after the age of 30 years, and most of the athletes after the age of 30 years are very difficult to maintain. It's a reflection of physical inactivity, neuromuscular decline, several hormonal changes, especially testosterone and growth hormone deficits lead to muscle mass reduction. But more importantly, in our population, we found not taking enough protein may be the number one cause of sarcopenia in Indian population. That's why also we don't get gold medals in Olympic. Cognitive decline is a gradual reduction in mental functions such as memory, reasoning, processing speed, ranging from normal age-related changes to serious neurodegenerative diseases like dementia. So the cognitive decline includes memory loss, reduced mental sharpness, navigation issues of not feeling familiar in familiar places, getting lost in familiar places, language difficulty, impaired judgment and behavioral changes. The behavioral changes part is extremely important in patients of Alzheimer's disease and other dementia, because that's what makes caregiving difficult. So, is it a normal aging process or a pathological state? Please do remember the pathology of brain in Alzheimer's disease patient have excess of neurofibrillary tangles and loss of brain mass and deposition of amyloid and tau protein. In normal brain also, we have all these changes. But what makes these changes excessive to affect the brain, get dysfunctional and lose its capacity, is the question that most of the scientists ask and trying to work on them. So from normal aging to dementia, some people think that it's a one-way traffic. Others feel that no, it is not that way. One may not develop MCI to go to dementia in the beginning itself. So new terms by DSM-5 is MCI is mild neurocognitive disorder and dementia is called as major neurocognitive disorder. So new terms, and so that's the way we look at it. So the new challenges in care of older persons, how aggressive and diagnostic approach should be. Transitioning from a government hospital of AIMS to a private hospital of Artemis, this is an everyday challenge for me to how aggressive one should be. Unless I am aggressive, the hospital doesn't get revenue. But is that aggression liked by the family members? But now I feel every family wants सब कुछ करिए, do everything, investigate, PET scan करा लीजिए, do everything. जो पढ़ के आया गूगल में सब करा लीजिए. So as a clinician, it becomes very difficult for a doctor to decide how aggressive one would be to get into a diagnosis. The vaccination strategy have been evolving, and some people say this is probably the only anti-aging intervention which prevents age-related morbidity and hospitalization, especially respiratory disease, respiratory infection-related disease and disability. Let's understand urinary tract infection and respiratory tract infection, lower respiratory tract infection are the terminal events in large majority of people who are in their 80s, 90s and 100s. Eligibility and preparedness for surgery and intervention. We have worked on this in the setting of cancer, and we have developed a scale to say that how one decides whether a patient should be getting aggressive cancer treatment or not. Probably my colleagues in National Center of Aging will work on the other surgical issues. Hip fracture management is a big business in Europe. If there is a hip fracture, it has to be operated fixed in 36 hours time. If not, the consultant and the registrar will be blacklisted by the hospital that they have failed to get a hip replacement done. Hip fracture treated in 36 hours time. When in our trauma center, in a collaboration between trauma center and geriatric medicine, we nearly achieved that. Within 36 hours, our residents will make the patient fit and they will be operated by Rajesh Malhotra and his team. But after COVID, most of the things got unsettled. I don't know whether NC has been able to do that or not. Possibly they are looking at that possibility that in 24 hours time try to make the patient as fit as possible. and make the anesthetist agree to operate, get the patient operated in 36 hours time. Management of cancer in late life, as I told, is a major issue. But now I feel that one should be aggressive. I saw 2 patients in Artemis Hospital who has been treated by Priya Tiwari, our own MD student and DM student, lung cancer with metastasis. She treated them aggressively. They are now living in 3 years after the diagnosis with treatment. Now, of course, the recurrence have come in and they are now back with us. Whereas, some of my known people treated by our own AIMS, IRCH, they did not survive even 1 year. So, I think one has to be very aggressive. 2 minutes hai abhi. The new treatment for Alzheimer's disease, I will say a few minutes on that. Earlier we thought Alzheimer's disease is very difficult to diagnose and treat. Now things have changed. There is a biomarker approved by FDA available in India which can make a diagnosis that whether the person has got Alzheimer's disease or not. It's a ratio of beta amyloid, A to beta amyloid versus to p tau 207. This is done by many of the labs. So if that is positive, that means the person has Alzheimer's disease. So if it is positive and the patient has very advanced dementia, nothing much can be done. But it is an early dementia, mild cognitive disorder with clinical dementia rating scale 0.5 or less. Treatment can be given. This drug was launched in India, monoclonal antibody was launched in India last week, donanemab by Eli Lilly, and the other drug will be there by Eisai will be there in by end month end. So again, this is a very difficult area. NIMHANS is working on this to make a protocol as to we should be using them. They are very costly drugs and also very dangerous because they may cause fatal CNS bleeding in patients who have not been properly picked up. Long-term care as a necessity in the health system have not been never looked at. Now it has become imperative that health system also looks at long-term care, not only changing diaper and putting vials tube feeding, but looking at acute events that occur in a person who is in his 80s, 90s, 100, had a major neurocognitive disorder or dementia or something, and they make frequent trips to hospital and then it becomes a major crisis for the family. So these are the way forward. Look at functional capacity as a measure, practice guidelines for most of the things are required. Age-friendly environment, provision for long-term care. We are looking at intrinsic capacity and functional ability as the major tool for assessment of old age health. So there are some good news, as I told, dementia treatment has come up, frailty treatment has come up with new drugs, growth hormone agonist, ghrelin agonist named anamorelin, and some other androgen receptor modulator. They have also come up, probably will be good for sarcopenia and frailty. So things are happening, so I am not hopeless that probably in few years time there will be many more drugs and mechanism will be available. But the magic portion for ameliorating the ravaging effects of aging is far away. Till that time, enjoy your old age, because it is good to be alive and old and all sick and frail and sarcopenic rather than dying in young age. Thank you for
Thank you, Professor Day, for your excellent disposition of the topic. And just small query, 2 queries. I hope the question is permitted. What is healthy aging? Most of us sitting here are in the group of senior people. What is healthy aging? You are just 3 lessons for them. And secondly, our Indian protein intake is very low. ICMR data shows possibly we take 0.7 or 0.8 gram per kg body weight vis-a-vis Westerners who are taking over 1 gram. Is the frailty more common in India, sarcopenia is more common in Indian scenario vis-a-vis Westerner?
First question, healthy aging. Some time back there was some assignment given to some of us by Dr. Umesh Kapil to make some addition of Pota cabin here, and the in charge of that was, sir was the in charge. 8:30 winter morning he was measuring the plants, so that is healthy aging. So So I came from Green Park Extension, he came from a distant place, so we must have got out of home at about 7:30 or so. And in that winter morning, he was measuring 7 foot idhar, 6 foot idhar. So aging, healthy aging age, if you are able to do whatever you feel like doing, what you are enjoying doing, despite all your illnesses, disabilities, that is healthy aging. That's what WHO says. It cannot be that you are 70 or 80 and will not have illness. That's not possible. Illness will come, as my Guru Kalyan Bakshi told, illness will come. You do whatever you may do. Illness will come, so let's accept it and do whatever is possible. And about the protein intake, I was discussing this with Center for Brain Research Director Dr. Hari. He told this is a typical South Indian diet in which there is only rice and dahi and rasam and sambar and there is no protein. So, Indian diet as such, because our kind of hatred for meat and things like that, though we love taking it outside the home, घर में नहीं पकाना है, तो as a result, our diet is deficient. The prices of pulses are very high and people think, oh, the Bengalis think pulses or dal is required only to make the rice a bit softer. Otherwise, it's, as a dish or as a food, its value is not known. But now we have understood that protein deficiency, on which we have never, in our undergraduate days, we never talked about protein deficiency in adults. It was only talked about kwashiorkor and marasmus in children. They are carbohydrate deficient, protein deficient. But similar thing happens in older people also. And in one of the animal experiment, one of the last PhD student did with me was a protein deficient diet to rats, and they all became older rats. Like they all, the characteristics of old man or woman was seen in them, and with protein and exercise they all recovered. So protein deficiency is very common in India. That's the greatest indicator that we don't win any gold medal in the Olympics, because the protein is not there for athletes to eat. Muscles तो है ही नहीं.
ठीक है. I know there are some questions, but sir, can we do it quickly? Dr. Bose, Professor Bose, quickly, sir, because we are running.
Professor Dev, you have covered everything, but I wanted you to tell us what is the role of family in the healthy patient, for the welfare of a elderly patient. Role of family.
अरे ये तो सर PhD का thesis है sir.
I will answer in all the centenarians that I treated were supported only by their family. That's why they survived to 100 years. So I always tell them, it's not, they tell that आपने बचा रखा है, मैं कहा हमने नहीं बचा रखा है. It is the children who have taken care of their father and mother, they have reached 100. So family is essential for living to 100. So to end, our chairpersons are getting restless. The Atharva, the Yajurved statements are live to 100 years with eye, ear and oral cavity and brain intact. So Jivayam Saradaha Satam. So 100 years with everything intact, but for that a family is required.
Yeah, that is for a healthy and a long living. I think the most important parameter is he said environment. That environment is family. So thank you, sir. Wonderful lecture. I wanted to, in fact, read out the carry home messages, but maybe if there is a time, we will do it in the end. But the next speaker, I'm very excited. We have Dr. Y.K. Gupta, who's been a giant in pharmacology. And he's going to talk about another challenge. Besides getting all of us getting old, geriatric is AMR, which is a major health challenge today and also a kind of a silent pandemic. What they say that misuse today and have no cure for tomorrow. And this is the biggest threat to the modern medicine. And from hospitals to homes, everybody is, struggling to fight this battle. So Professor Gupta, you all know him. He's been the boss at AIMS and president of AIMS Kalyani, and he's been instrumental in setting up a lot of things at AIMS, including the clinical pharmacology and pharmacovigilance and neuropharmacology laboratory, which was like a trendsetter in the country. Over to you, Professor Gupta, Y.K. Gupta. Thank you.
Thank you very much, Chairman, and the galaxy of academicians here. After having a talk on old age, which I think everybody will have to go, I'm talking on another issue which everybody is going through. And the country is going through, the entire world is going through, and it has become challenge not only global, but it is a major challenge in India. WHO has termed antimicrobial resistance as a major health threat. In India, we are the major contributor on antimicrobial resistance. Even Prime Minister had to speak in Mann Ki Baat about antimicrobial resistance. And I will say, and I happen to be the principal advisor in WHO affiliated organization which is called as a GARD-P, Global Antibiotic Research and Development Partnership in Southeast Asia. And I would just like you to remember, you remember this fellow? I think this is a general knowledge question which is the preliminary round question in KBC. जो अमिताभ बच्चन पूछता है, Alexander Fleming कौन था? He was the person who discovered penicillin. और जब पेनिसिलिन डिस्कवर हुई तो उसने कहा, लोगों ने कहा कि ना अब हमने दुनिया जीत ली, सारा इन्फेक्शन जीत लिए. एंड इट वाज सच एन इंपॉर्टेंट एंटीबायोटिक कि जिनको पेनिसिलिन दी गई उनकी यूरिन कलेक्ट करी जाती थी टू एक्सट्रैक्ट बैक द पेनिसिलिन सो दैट इट कैन बी गिवन टू अदर्स. दैट वाज द प्रेशियस मटेरियल इट वाज. एंड दिस फेलो गॉट द नोबेल प्राइज इन 1945 और उस टाइम उसने कहा था, जो कोट किया मैंने यहां पे भी, 30 नोबेल प्राइज लेते में, आई वुड लाइक टू साउंड वन मोर नोट ऑफ वार्निंग. रिमेंबर दिस, इट इज नॉट डिफिकल्ट टू मेक माइक्रोब रेजिस्टेंट टू पेनिसिलिन बिकॉज उस समय उसने पेट्री डिश में माइक्रोब रेजिस्टेंट बना लिए थे. by exposing them to concentration not sufficient to kill them. This statement is now vetted in 2025 publication also. Now 1945, same publication, similar publication in 2025. I will tell you later. And the same thing has occasionally happened in the body. Now this was at that time, we ignored this warning. We were so overwhelmed with penicillin, and you know the penicillin की story बड़ी सारी है, Alexander Fleming, then उसके बाद में और कई, and उसी के थोड़े दिन के बाद another Nobel Prize to a person, Waxman, ये भी KBC के second round में आता है, not Alexander Fleming. He got the Nobel Prize for discovery of streptomycin, and that was considered to be the ultimate victory on tuberculosis. और tuberculosis आज major problem है, drug resistant tuberculosis. Now because we did not pay attention to that. Now ये just देखिए, ये जो हमने दिखाया यहाँ पे antimicrobial resistance, if you just see on this side a warning on Oxford, a silent pandemic, कोई WHO वाला कहता है, कोई कुछ कहता है, कोई हमारी मन की बात में कहता है, and ultimately everybody is putting that the next generation epidemic, which we call till date silent pandemic. So silent word अब delete हो गया. Now this is pandemic. Now preparedness for pandemic is now a major emphasis on this. ये चीज जो हम आपको दिखा रहे हैं, there is a race, continuous race between the antibiotic development and the development of the resistant organism. Who is the winner? Now you see the penicillin was discovered, if I can use this pointer, this is working. Penicillin was discovered and then resistant. Then tetracycline was discovered, colistin, methicillin, and you can see हर चीज का resistant develop होता चला गया. And today, now what you call as a pain resistant organism. जब pain resistant organism हो जाएगा, तो अगर infection हुआ तो आदमी का भगवान ही भला कर सकता है, वो भी नहीं कर सकता, because he doesn't have any antibiotic. Then you say उसको तो मरना ही था. the total mortality of antibiotic resistant organisms is much more, which I will put it here. Now this is, you can see, race which is happening between the development of new antibiotic, all channels, all pathways of antibiotic resistance, antibiotic development is almost exhausted. Now strategy is to look for different innovative receptors. Can we find out? We are trying to find out what can be the mechanism by which you can spare antibiotic use and what antibiotics can be preserved if you have. So that is what, and this is, you can say, antibiotic resistant के बाद superbugs. Or India में Delhi superbug became famous and Delhi became infamous. But there was a lot of controversy कि superbug सिर्फ दिल्ली में ही है या superbug कहीं और पे भी है. तो दिल्ली में होगा तो कनाडा भी जाएगा, कनाडा में होगा तो दिल्ली में भी आएगा. So message is, this is a trans-boundary problem. Who will win? As on date, clear direction of winning is the superbug is winning. And therefore you have to have a different alternative innovative strategy to come over to this. This is just, you see, this is a summary which I prepared for 3-4 publication of antimicrobial resistance, and this says that out of 40 million people, this is a study, who were given antibiotic for respiratory issues, 27 million were given for those who got antibiotic which was unnecessary, and only 17 million, 13 million got the antibiotic which was necessary. This is global situation. Unfortunately, हमारी country में ऐसा कोई data नहीं है, लेकिन हमको नहीं लगता कि हमारी country में इससे better data होगा. इससे और खराब होगा. हम कहना नहीं चाह रहे, but I understand that you will understand it. Now for that कि अच्छा है, खराब है या यही है, what we need to do is, and India is one of the country hit hardest by AMR. This is the WHO said, couple of papers have said, but hardest, कितना hard, ये हमारे पास study नहीं है. 17% of the world population lives in India, 17%, but 30% of the global AMR are in India, Bangladesh, Bhutan, Nepal and Pakistan. ये तो छोटे छोटे, इन सबको मिला दो तब भी इसके 1/3 होते हैं. Now you can see, imagine what is the magnitude of the problem of AMR, and I will ask you कि आप भी ध्यान में रखिए कि आपके कितने नज़दीकी लोग, कितने पेशेंट रेजिस्टेंट ऑर्गेनिज्म से मर गए. Then you will find at least एक तो होगा ऐसा. Now this is in India, limited studies on antibiotic prescription analysis, and that is very alarming. जो limited study है, आपने कहा ना hard, बहुत limited study, but that results are alarming. So what is important? A need for prescription audit in all hospitals is important. Across the discipline and across rural and urban. ICMR ने study करी, restriction was, limitation was, ये सिर्फ tertiary care hospital के थोड़े से hospital में हुई. That data cannot be penalized, cannot be the pan-India reflection. So that is what important thing. Initiative किसने लिया? IIT के एक engineer ने with direct support and a startup, Vaidya RX, digital platform for prescription analytics. So this program is going on India in different platform and getting all the information कि कितने prescription हमारे antibiotics में हैं, कितने rational हैं, कितने irrational हैं, and that data can make the policy for the hospital, for the country at the later stage. This is a global killer. Now you can see cancer 10, this is million, and 2021 का जो census है उसके बाद में नहीं आया. Heart disease, stroke and AMR is just 4, and you can 4.7 billion deaths were association it with AMR, of which established causal relationship 1.4 million. इतने बड़ी प्रॉब्लम है, हम यहाँ तक तो बहुत ध्यान दिया हमने, लेकिन AMR में अब इतना ध्यान आ गया कि प्राइम मिनिस्टर को बोलना पड़ गया कि AMR is a problem which everybody has to solve together. This you can see. ये अगर आप देखें कि ये 2025-50 में प्रोजेक्टेड है, यहाँ से इतना बढ़ रहा है. हमारा कैंसर की रिस्ट्रिक्शन यहाँ पे 8.10, ये सारी की ग्रोथ जो प्रिडिक्टेड नॉट बाय AI बट बिफोर AI, दिस वाज द प्रिडिक्टेड, एंड अल्टीमेटली इन 2050 प्रिपेयर्डनेस जब तक अगर हमारे पास AMR की नहीं होगी तो हमारी मैक्सिमम डेथ्स होंगी AMR पे, एंटी माइक्रोबियल रेजिस्टेंस. नाउ this is something which is I will like you to do a brainstorming, antibiotic concentration and resistance. हम जो अभी बात करते हैं, जो डोज हमारी होती है एंटी माइक्रोबियल रेजिस्टेंस के पहले हम बात करते हैं कि माइक्रोबियल कंसंट्रेशन और व्हाट वी से MIC. नाउ इफ यू सी, ये जो कंसंट्रेशन है ये MIC से कम है, राइट? और इस MIC कंसंट्रेशन से कम होगा तो क्या होता है, ये जो बैक्टीरिया है ये बैक्टीरिया नॉर्मल है, वाइल्ड टाइप, और यहां पे आपने देखा जो रेड है ये हमारा नॉर्मल बैक्टीरिया, तो वहां पे कम हुआ, ये है. इससे न नॉर्मल बैक्टीरिया मरा, न म्यूटेंट बैक्टीरिया लाल वाला वो मरा. लेकिन जब ये कंसंट्रेशन मिनिमल MIC पे पहुंचा, जिसके बेसिस पे हमारी डोज आजकल कैलकुलेट होती है, तो क्या होता है उससे, नाउ यू कैन सी all the sensitive bacteria are killed, but the mutant bacteria are still there. Now if this is happening, then mutant bacteria will propagate, and what will happen if you increase the concentration to much more than this, then this mutant bacteria will also be killed. Message here is, are we giving the right dose, or there is a possibility of increasing the dose, which I call it as, and couple of also people have raised this, should we give the concentration which is maximum tolerated dose, जो 500 milligram 250 milligram dose कहते हैं, that may be insufficient. So why not you go to 1 gram, why don't you go to 2 gram, why don't you go to a dose which is tolerable but it is much beyond that. And this is now couple of clinical trial have started, so maybe after 5 years or after this theory is established, the dose of antibiotics will be calibrated. So this is something which is innovative thing which everybody, and you can see Pseudomonas aeruginosa, E. coli जिसका impact, ये MCS minimum inhibitory concentration 0.25, लेकिन जो minimum dose जिसको कि mutation dose है, mutation prevention concentration is 8. Here you can see E. coli. Imipenem, carbapenem resistance is a major problem. Now if you can increase the dose to 0.5, that means double the dose of meropenem, perhaps जो हम आज resistance दिख रहा है वो शायद resistance नहीं हो. Therefore the entire definition of resistance will change, and this requires a collaborative approach between microbiologist and pharmacologist and clinical epidemiologist. That's something very important. I would say WHO has given a list of priority pathogen, and इसमें उन्होंने बताया कि critical level जैसे Acinetobacter, Pseudomonas and Enterobacteriaceae, इनकी वजह से deaths बहुत होती हैं, and उन्होंने कहा कि high priority and medium priority. So what we are more keen in handling this critical, and India में भी जो One Health है उसने भी correct clinical priority बनाई जिसमें Enterobacteriaceae and then high priority and then medium priority. Why I am telling you this? हमने जो नेशनल हेल्थ पॉलिसी में नेशनल लिस्ट ऑफ एसेंशियल मेडिसिन बनाई, आई चेयर दैट कमेटी, वी मेड एसेंशियल कैटेगरी ऑफ लिस्ट बेस्ड ऑन दिस. कॉम्प्लेक्सिटी AMR में बहुत है, आई एम नॉट गोइंग इनटू द डिटेल. कॉम्प्लेक्सिटी इज अंडर रिकॉग्नाइज्ड डायग्नोसिस. हमारे यहाँ हिंदुस्तान में डायग्नोसिस पे ओनली 23% पैसा खर्च होता है as compared to outside where it is 70% plus. And how many of the patient get antibiotics after getting culture sensitivity? और culture sensitivity करके भी आता है और उसके बाद कितने लोग उसके basis पे alter करते हैं, that is again an important issue. And how many people believe on the results of the culture sensitivity? That is another third issue which has been done in a survey and found to be dismal. So what is important is the lack of access of diagnostics also. Molecular diagnostic is now increasing, but molecular diagnostic accessibility, affordability is important. Now here also inappropriate prescription, I am not going to detail because everybody knows that you can buy anything from the market in India, and if you are familiar, the most important highest consumed drug was azithromycin and oxythromycin and clarithromycin in COVID, for COVID. Now this is what's happening, and this is not prescribed, and even prescribed sometimes. Challenge in the healthcare system, antibiotic use apart from human. That's why we have created in India the large number of plant get antibiotics, जिससे कि उसका growth बढ़ जाए. I do not know myth, and also in animal. In animal, the antibiotic use in India is not only less, but it is highly unregulated. पता ही नहीं किसको कितना है और क्या दे रहे हैं किसको, and all this goes into this. This is to give you an idea that correct treatment with, this is in sepsis, correct treatment within 1 hour of initial hypotension in sepsis will have the 80% survival if you are able to give it. And for each hour delay in the treatment, survival declines by 7.6%. If your treatment, correct treatment, delays by few hours, then you can imagine what is the risk. I have deleted those graphs which indicate that. But the net is, faster the diagnosis, faster the correct treatment is started, the much better is in the critical care. A correct diagnosis has a 3/4 of the remedy. That is something which is very important, which we lack sometimes. And in India, antibiotics, majority of the antibiotics are given empirical. So what we have started as a challenge in the multi-institutional project, that you develop antibiogram of your hospital, of your region, and then your empirical treatment will also be an evidence-based empirical treatment, and that is what important thing is. Now here you can see fit for purpose diagnostic. We call it a fit for purpose. क्या होना चाहिए? Importance of correct diagnosis. Fit for the purpose diagnostic. You cannot say that हम rural area में भी molecular diagnostic immediately कर देंगे, but you have to see with what is the limitation, what is the accuracy, and what is the sensitivity of ABC diagnostic procedures. Making accurate diagnosis, ideal characteristic of point of care test. The Department of Biotechnology, Department of Science and Technology, and ICMR is funding liberally on the chip-based diagnostic for different disease, and also to the extent that the expiration which you say exhale can diagnosis, can have a prescription, can have a potential diagnosis of couple of infections, and that project is running in IIT Delhi, and I chair that ethics committee. And turn around time, TAT, those who are microbiologists. अगर हमारे रिपोर्ट ही 24 घंटे के बाद 48 घंटे के बाद आएगी कल्चर सेंसिटिविटी, I can't delay the treatment to start. And that's why the TAT is become major important. Also important is TAT. TAT and TAT. Starting appropriate antibiotic therapy, and these are the two major challenge, TAT and TAT, how to start antibiotic appropriate. Barriers of diagnosis is availability diagnostic, molecular diagnostic है नहीं. Accessibility उसकी होनी चाहिए, particularly rural areas में, and that's why the government of India is liberally funding it. Acceptance of that is important. हमने बना तो दिया, oh, sorry. And guidance and training. ये जो हमारे molecular diagnostic है, इसका interpretation हमारे clinical आदमी को आना चाहिए, because that is something very important thing. What we are doing, how to respond this crisis. I am not going too much in detail. Now the DBT has created One Health Consortium. I chair that committee, and this was for 3 years, this recently completed. One Health means environment, animal, water, aquatic and human. And if you have combined this, then you can find out कि ये कहाँ पे क्या loopholes हैं. And one of the important thing is AMR. And here 31 crore rupees for 3 years. 29 institutions are involved in that. ICMR institution, environmental institution, agriculture institution, and wildlife also, and couple of AIMS are also part of that. Now you can see on 28th December, Prime Minister had to come out on making this as a major threat. जब Prime Minister को जब समझ में आ गया, तब हमारे देश में पैसे की झड़ी लग गई on AMR. Now so much of funding is available on AMR, and I will urge you to suggest your postgraduates that this is one of the very low-hanging fruit for getting funding. He shifted, what he said, read this, he shifted AMR from laboratory and policy documents to public consciousness. उसने कहा प्रधानमंत्री कह रहे हैं कि लैब वेब की तो छोड़ो, वो आप करते रहो, पॉलिसी वालिसी आप बनाते रहो, लेकिन इंपॉर्टेंट है जब तक आप सारे स्टेक होल्डर्स को नहीं लेके आओगे साथ में तो AMR की प्रॉब्लम नहीं सुलझेगी. दैट इज समथिंग वेरी इंपॉर्टेंट थिंग. From political commitment to implementation, so India currently emphasizes on convergence of robust evidence. हमारे पास एविडेंस ही नहीं है कि हमारे कितने प्रिस्क्रिप्शन में एंटीबायोटिक राइट, कितने रॉन्ग, कितने आईसीयू में प्रिस्क्रिप्शन, कौन सी कितनी डोज, क्या डोज हमारी, एंड सो यू हैव टू क्रिएट एन एविडेंस एंड दिस एविडेंस हैज टू कम फ्रॉम डिफरेंट हॉस्पिटल्स एंड दैट विल बी रोबस्ट एविडेंस. स्ट्रॉन्ग पॉलिसी आर्किटेक्चर हमारे पास होना चाहिए. One point is WHO की मीटिंग में this was debated that we are coming with 3-4 antibiotics new. Should we introduce this antibiotic in countries like India, Nepal, Pakistan, where there is no evidence of stewardship? तो अगर हम नया खिलौना, इलेक्ट्रॉनिक खिलौना बंदर के हाथ में दे देंगे तो क्या होगा? तोड़ देगा वो. तो सेम टाइम अगर हम इस एंटीबायोटिक को अनएजुकेटेड, सो कॉल्ड एजुकेटेड फिजिशियन को दे देंगे तो एवरी पर्सन विल स्टार्ट गिविंग दीज एंटीबायोटिक्स टू एवरी पर्सन एंड दिस विल हैपन सेम थिंग विच हैपन टू पेनिसिलिन और स्ट्रेप्टोमाइसिन. दिस विल आल्सो गो वेस्ट. दिस इज वन रीजन व्हाई इंडस्ट्री इज नॉट पुटिंग मनी इनटू एंटीबायोटिक रिसर्च एंड डेवलपमेंट बिकॉज द लाइफ इज अनप्रेडिक्टेबल बिकॉज ऑफ इनएप्रोप्रिएट प्रिस्क्रिप्शन बाय द फिजिशियन. सो दैट इज समथिंग वेरी इंपॉर्टेंट. इनोवेटिव अप्रोचेस जो हमने शुरू करी हैं अभी कुछ कंट्री ने, ए न्यू एंटीबायोटिक डिस्कवरी एंड डेवलपमेंट, मैपिंग द इंडियन लेबोरेटरीज. अब हम लोग क्या कर रहे हैं थ्रू गार्ड-पी, जितने भी इंडिया में लोग काम कर रहे हैं, एमएससी, एमडी, पीएचडी, जो एंटीबायोटिक पे काम कर रहे हैं उनको मैप करो एंड देन ट्राई टू फाइंड आउट व्हाट इज आइदर मी टू रिसर्च, किसमें पोटेंशियल है, जिस मॉलिक्यूल में, जिस कंपाउंड में पोटेंशियल है, connect with industry and take it further. That is what is linking laboratory and pharmaceutical industries, mobilizing and motivating funding. That is what we are doing. This is antibiotic innovation milestone India. लोग कहते हैं हिंदुस्तान में डेवलप नहीं. वोकॉट ने डेवलप करी एम्बेथाबैक्टम. This is a new antibiotic which has been developed by Orchid and India developed ये दो एंटीबायोटिक. तो हमारे in India 4 new antibiotics have been developed. But now putting that antibiotic in market is now being a study debate कि कैसे हम पॉलिसी बनाएं कि ये हम टर्शरी केयर में ले जाएं या प्राइमरी केयर हॉस्पिटल में ले जाएं या हेड ऑफ डिपार्टमेंट के प्रिस्क्रिप्शन के बाद ले जाएं या किसी को भी दे दें, इज स्टिल ए प्रॉब्लम. एडवांसिंग एंटीबायोटिक इनोवेशन, गार्ड-पी वेयर आई एम एडवाइजर, Bugwug, a startup company which is very successful, which has made 12 molecules, 2 molecules are now in phase 3. And also several partners, neonatal sepsis he study, and then ICMR has several active sites as well. Now this is something is important. इतनी महंगी नई एंटीबायोटिक आएगी, particularly ज़ोलिफ्लुडासिन और जो नए एंटीबायोटिक 2-3 आ रहे हैं, 20,000, 30,000 प्लस एम्प्यूल जो बाहर से भी इंपोर्ट करके लाएंगे, 70,000 to 1 lakh rupees per tablet, per capsule. Now if you are going such an expensive thing and if it goes waste, then it is a tragedy. So what we are suggesting, what we are working on, a pool procurement policy. Collect the requirement from all the potential hospitals and develop a pool procurement कि हमको 1 lakh capsule चाहिए and then it will be much cheaper. And this pool procurement for defense, for CGHS, for railways has already been finalized. But this pool procurement is also AIIMS, all AIIMS will be part of that. Linked with stewardship. तब तक उस एंटीबायोटिक को उस अस्पताल में मत ले जाओ जब तक कि वहाँ के डॉक्टरों को देना और इसको मॉनिटर करना नहीं आ जाए. That means you train them, educate them simultaneously before this is, and that's why stewardship, and this is what Niti Aayog suggests, that you convert all AIIMS, 22 AIIMS into one platform so that the stewardship program is strengthened. Policy to restricted access of reserve and new antibiotics. Innovative regulatory approaches. तो प्रॉब्लम आती है कि अगर नया एंटीबायोटिक बाहर आ गया 4 साल से, हमारे कंट्री में ट्रिपल दाम पे एक्सपोर्ट इंपोर्ट कर रहे हैं, लेकिन हमारा रेगुलेटरी सिस्टम अभी ऐसा है कि हमारी कंट्री में आने में उसको 5 साल और लगेंगे because of the. So what is required is innovative thinking, pressure from the peers, and then change the regulatory system so that a new, safe, effective antibiotic which can save the lives should be brought to the country much faster. And innovative regulatory, so we are working on innovative regulatory approaches. We had a consultation with CDSCO, but बड़ा मुश्किल होता है एक किसी सिस्टम को चेंज करना, but that is what is important thing. Enabling quality supply and access, which is very important. And this is what you can see with Orchid Pharma, with Origin, with the and transparent pricing strategy. National Pharma Pricing Authority is one which regulates the price. So many industries have said that हम इस country में इसलिए नहीं लेके आएंगे कि हमारा price control हो जाएगा. So our idea is that they should not be deprived of profit, but they must not be allowed to do profiteering. एक balance होना चाहिए, and that is what the new policy has to be done there. Now this is what we worked and what we published couple of papers on innovative access in India and globe, and a couple of strategy policies, policy documents we published in different publications, and they have become the background or zero ground discussion paper for the government of India as well. Innovative approaches for leftover and expired medicine. ये जो हमारे घर में है, 4 दिन की दवाई खाई, 2 दिन की दवाई बच गई है, 15 दिन की खरीद के लाए, उसके बाद क्या होता है? अस्पतालों में जो लेफ्ट ओवर मेडिसिन है, पर्टिकुलरली एंटीबायोटिक्स, लेफ्ट ओवर मेडिसिन का तो डिफरेंट इशू है. लेफ्ट ओवर एंटीबायोटिक्स जो बाद में कूड़े में फेंक दी, समुद्र में मिली, पानी में मिली और नाले में मिली और आपके घर के बगीचे में मिली, और उसके बाद में आपके पौधे में आ गई, पौधे से आपके पेट में गई और रेजिस्टेंट हो गया, बिकॉज यू सीन द लो कंसंट्रेशन, इनएडिक्वेट कंसंट्रेशन इज कंट्रीब्यूटिंग टू रेजिस्टेंस एज वेल. We had a meeting with Additional Secretary Health. He said कि project funding करो. Just 3-4 more slides. And school college awareness program, digital reminder apps have been developed, and smart medicine return kiosk. And at few AIMS we have started कि डिब्बा रख दो जो left over मिले आप उसमें डालो, and then it will be disposed of appropriately. So CHRI path, Government of India and CARD-P has started project on that. This is one of the brainstorming which we did with 3-4 organizations, and also my academy was involved in that. And here we discussed the strategies how the expired medicine have to be disposed of. Innovation for diagnostics, AI-powered rapid diagnostics. AIMS and IIT are working on that. Point of care diagnostics, smartphone linked diagnostic kits, affordable molecular diagnostics, and sensors for infection. Sustainable pricing, and sustainable pricing is important. Limiting cost, fostering appropriate use is important, and that's why creating awareness is important. And this is what JP Nadda ji and has released a antibiotic AMR policy 2, which is called as. Finally, I would say this is what you say antimicrobial resistance is a, whose responsibility is this? Is the doctor, patient, public, dispensary और pharmacist जो जिसको मन में आया दे देता है, और the regulator जो कि कहता है कि हम कहाँ तक इसको पकड़ेंगे, या कोई और. I think this is all stakeholders, including you all, including everybody who is listening is this. So that is something which is important, and I think this is not the problem of one, this is problem of all of us, whether you are young, whether you are age of, what is it, 90? So what is 98? 94. Here is the senior most person sitting here. I think he must have visited maximum, must have seen maximum AMR cases, but still as strong as anybody can. So thank you very much.
Thank you very much, Professor Gupta. I think you have frightened us, and which is the reality. As you rightly said, 2/3 of the antibiotics are prescribed when they are not required. And whatever our private practitioners or whatever doctors, inadvertent prescribing is the main cause for resistance. And you mentioned finding a solution is not very easy. Let's have questions from audience, one or two.
I will just add one thing here. This is the elite group of the medical profession. You are the key opinion leaders, and each key opinion leaders can have an atomic reaction. You can spread that how we can save the antibiotics which we are going to develop.
Yeah. Two questions, General Velu, and one more. Take mic, please.
Many stakeholders you have given here, but over-the-counter medicine, the availability, accessibility, like a pharmacist is prescribing medicine on his own. So somebody comes with a common cold or a diarrhea, half the prescriptions are given for those diarrheal and respiratory illnesses which are viral. So can't we take any steps to make the regulator implement a more stricter control on dispensing from the pharmacies, which is being done by the ICMR, but they have shown this is rampant.
I would say there are three
rampant. Dr. Gupta, any common person have a diarrhea, he takes a O2.
He takes?
O2. O2 known to everybody.
He is saying ofloxacin, yeah.
Ofloxacin and ornidazole. So imidazoles and fluoroquinolones. Broad spectrum, resistant to everything for viral damage. So you see, you don't have a control on simple intake of O2, ciprofloxacin, ampicillin, amoxicillin, clindamycin, clarithromycin. People take off and on.
I will just say two words here.
Last one.
One is a regulation, other is a bad practice. In India, we have different schedules. I don't think that many of us know those schedules. One is the prescription drug, H. Then came H1 schedule, that means only drugs can be prescribed by a competent doctor keeping 2 copies of the prescription, and antibiotic is one of that. How many you know that antibiotic prescribe करने के बाद उसकी कॉपी रखनी होती है फार्मासिस्ट को? कोई रखता ही नहीं है, ना आप देखते. नंबर 3, H1 प्रिस्क्रिप्शन एनालिसिस के बाद में भी अब हमने सोचा कि H2 बनाएं पर्टिकुलरली फॉर रिजर्व एंटीबायोटिक्स. उसके बाद भी हमने कहा कि अब जो नया रेगुलेशन आया कि हर एंटीबायोटिक में एक नया स्ट्रिप होगा, सो दैट वंस देयर इज ए ब्लू स्ट्रिप ऑन एंटीबायोटिक्स द प्रिस्क्रिप्शन विल बी केयरफुल. बट हाउ मेनी ऑफ यू नो दैट दिस इज अवेयरनेस?
Thank you, Professor Gupta. Yeah, you can ask.
Wondering the
Chris, small question. Yeah.
Time constant. I am Lohia from Jaipur, and as usual, always a pleasure listening to Professor Y.K. Gupta. Compliments for covering every aspect related to antimicrobial resistance. Very important topic. I feel the last slide which you have presented, where everybody is responsible. Whether it is doctor prescribing, whether it is a patient taking it, is a pharma industry manufacturing this, everything. What is needed is on today, and the Prime Minister has also pointed out, is the awareness, because what we generally feel is that even drug regulatory agencies, which they identify a particular antibiotic, they say if it is not effective, it may be faulty production. So we have to be conscious that it is because of perfect resistance it is not effective, or it is because of the faulty production it is not effective. So awareness is very important for all people, doctor, pharma industry, people who are taking it, who are prescribing, everybody.
Thank you very much, sir. Thank you very much. Thank you very much, Professor Gupta.
I think one last
okay.
I think the most culprits are the private practitioners and the doctors in the hospital. It is a blunderbuss therapy. You give everything together, something is going to hit. And for private practitioner, imipenem is sold to a patient, or the person who is prescribing gets commission. And that is one of the reasons for prescription of these drugs.
There's no doubt, inadvertent prescribing. Thank you, Professor Gupta, for a wonderful talk. You have made many friends. The last speaker is, again, another doyen in the field of gastroenterology and hepatology. I request Professor Acharya to come here. Professor Acharya has been professor and head of gastroenterology at AIIMS, New Delhi, and subsequently, presently, he is executive director gastroenterologist at Fortis Hospital, Okhla, and also he spends half the time as Pro Vice Chancellor, KEET University, Bhubaneswar. He is, there's no doubt, he is one of the doyens in the field of gastroenterology, possibly most often sought for second, third or fourth advice. If you remember, Professor Acharya, almost 20 years back, when I had a GI upset, I think from army they took me to you, and I became certainly all right.
I remember.
He has tremendous amount of research work, over 300 publications, and significant contributions in the field of viral hepatitis, liver failure, and hepatic encephalopathy. Today he is going to talk on how to keep your liver healthy.
Thank you, sir. It's a pleasure to see you again. And well, thank you, Professor beHon'ble Behera and my dear friend, Professor Umesh Kabir, for inviting me. And I can see my seniors and teachers, Professor Behera, Dr. KKT, we used to call Professor KK Talwar, KKT, and other people, Dr. Gupta. And thank you very much. I could meet all my friends, Professor Dey, whom you heard. We'll shift the gear. We heard from Professor Gupta how doctors, bad behavior of doctors, or abnormal behavior of doctors, causing antimicrobial resistance and creating problem. Now, I have been asked to speak to you about intervention to maintain a healthy liver. And this is essentially a behavioral problem of us, which creates a bad liver. So, Dr. Gupta pointed out, correct yourself, behave yourself while you are treating, right? And my talk is to tell you how to behave yourself to keep yourself healthy. Now, behaving and maintaining yourself is the most difficult thing, because you are a human being and you are full of weaknesses. Keeping that in mind, and keeping in mind how our own behavior is destroying us, right? In fact, World Health Organization 2 days back, on 19th April, declared World Liver Day. And the World Liver Day, the slogan or theme was solid behavior and strong liver. Search World Liver Day. You will find the slogan, solid behavior and strong liver. What do you mean by that, actually? Why liver so important? You will all agree, you are all physicians, doctors, liver does the most function. Professor Talwar will not mind. I have a slogan to emphasize about liver. So I call heart a pump. It maintains your cardiac output. It is important. It provides nutrition, oxygen, but it is essentially a pump. But it is an interesting pump. It doesn't require recharging. It continuously works. I call lungs a membrane. It maintains your partial pressure of oxygen. That is important. Oxygenation is important. I call kidney a filter. It maintains the GFR and removes your toxin, particularly very bad toxin through urine. But if you see liver does 500 different things, right? It detoxifies everything. Metabolites, it synthesizes multiple functions. Now, if you see, most important thing I have focused here, metabolic function. Whatever you eat, whatever, carbohydrate, protein, fat, butter chicken masala, Professor Mehra loves it, right? Whiskey, right? Everything will be processed by the pancreas, will be absorbed by the intestine, and through splanchnic circulation will go reach liver. It cannot reach your heart or anywhere or lungs. It has to reach liver. The first step. And there all the processing will start, both carbohydrate, fat and protein. think how much it must be working, how much enzymes are necessary, how much enzymes it has to synthesize. They can, if you know your major protein, which is oncogenic protein, which maintains the blood vascularity, albumin, major synthesis is liver. All your clotting factors, right, is liver. All your fat, which is necessary, synthesized by liver, right. Bile acid, which is necessary, synthesized. So it will process your food, simultaneously will synthesize. It will detoxify everything. Professor Gupta will say all biotransformation step 1 and step 2, all the drug metabolism or all the toxin metabolism, including your ammonia disposal, including Professor Mehra's favorite drinks, alcohol metabolism, all in the liver. Right. No, that's true. It is detoxifying agent, all drugs, right? But another most important thing, it is a very important component of immune function. So I told anything you eat, it has to go to the liver. This is the environment. We get infected by ingestion, inhalation, and touch. 3 ways. But if you see ingestion, the barrier between system and environment is the liver. And that's why if you have a lot of gut bacteria, you don't get it in your blood. So if you see portal vein endotoxins and hepatic vein endotoxin, there is 100-fold difference. So there are resident macrophages which has phagocytic function which takes it. Second, it is also a very important component of opsonic protein. Opsonic proteins are very essentially for phagocytosis. It's a glue which binds the bacteria and engulfs it. Many complements. So you have to do so many functions, unlike any other organ. And hence, evolutionary, it has a huge reserve. And that is the problem which I want to bring your attention to. You cut liver, liver regenerates. The best regenerative organ in the body. Best regenerative medicine is the best model. And that's why you transplant, live-related liver transplant. And the problem is, there is always a flip side of the coin. Problem is huge regeneration, very good for us. One liver cell can function 10 times its capacity. So how do you know about liver disease? It will never manifest. It's silent. Unless 80% of your hepatocytes are lost, you will never know. They are silently progressing. Hence you can comfortably drink, comfortably eat, comfortably sleep, get obese, have fat deposited in the liver and conk up the liver slowly over a period of time, causing insulin resistance, metabolic syndrome, diabetes mellitus, hypertension, coronary artery disease, arteriosclerotic disease, and whole gamut. And by now, if you see, 2 million people die because of behavioral disorder in the world. We lose 200,000 in this country in a year. And second, about 1.5 billion people, 150 crore people in the world are suffering from chronic liver disease because of this. And we don't know the cost, but if you see the cost in the United States in 2016, way back, was somewhere about $3,000 to $250 million, which use in Indian currency. And I've just listed down many of this. I'll just briefly discuss how do they do good. We take alcohol, we become obese, metabolic dysfunction associated steatotic liver disease, which is a new term, which increases all cardiometabolic risk factor, are very prevalent in 30 to 40% global population. And diabetes is the result. Diabetes per se can cause cirrhosis. I will show you the data. Now we have combination. मोटू आदमी दारू पी के स्नैक पी के एंजॉय करता है. All the combination, fuel, fire together. There are various drugs, of course, hepatotoxics, all complementary medicine, And other problems I will discuss. There are two things I have not listed here. Hepatitis is we have controlled it, so I have kept it last. Lack of sleep, insomnia. I'll show you some data. And stress, mental stress, worry, itself cause liver problems and fatty liver disease. So these are human behavior. Their causes, and if you see, that's all preventable. Everything is preventable. I always say you can remove hepatology as a discipline. You can stop it. Just if you correct these habits in human being. If for an inch of abdominal girth, Government of India puts an income tax of 1,000 rupees per month and provide inspection for every individual and he has to pay 1,000 rupees extra, you will find metabolic syndrome will decrease. And that's the important. First thing is alcohol. Now 43% globally, I have listed down, just read through it. Right, about 400 million people, about 7% of people take regular alcohol. 2019 we lost 2.6 million, not only because of liver disease, accident, other diseases, suicide, depression. But risk of liver disease increased by 260 times if you are taking alcohol. Even a drop of alcohol is bad, I will show you. And 35% of those who takes infrequent alcohol can develop liver disease with metabolic syndrome. Cardiovascular attack problems increase by 3.2 and cancer can increase. It is a carcinogenic. Now, it should be stamped as carcinogenic. Now, when I was a young resident in gastroenterology, 70 to 80% of cirrhotics were because of Hep B or Hep C. Now, 60 to 70% are because of alcohol. And 40% are obesity. They are crossing alcoholic liver disease gradually. Potentiation obviously is there. So what is the safe limit? Everybody asks me what is safe limit. A healthy stomach, it is usually World Health Organization earlier used to define 2 standard drinks, approximately 20 grams per day for males and 10 for females, is safe. I don't think it is safe. I will show you. If you have mild fat, you will progress to liver disease even with this drink. If you have fibrosis and you know liver disease is silent, you are rapidly going to cirrhosis. And if you are cirrhosis, your liver failure is imminent. You need a transplant. So that is why I have done this stop. Now, we now define alcoholic liver disease if you are taking more than 60 grams of alcohol per day, at least 5 days a week in a man, and about 40 grams in women. Women are not actually designed to take alcohol because alcohol is metabolized by an enzyme called alcoholic dehydrogenase, and that enzyme is present in man's stomach, not in female stomach. Female has alcoholic dehydrogenase only in liver, right? So we have it in liver, but that's why in female lesser amount of alcohol will cause liver damage. But if you are little fat and you don't take more alcohol, the safe limit is 30 grams for men and 20 grams for females. If you take little more than that, but not alcoholism, you get something called metabolic dysfunction associated liver disease with alcoholic both. We call it MET-ALD. MET-ALD is as dangerous as alcoholic liver disease. And Indians are thin from outside, but fat from inside. We do not have subcutaneous fat. So any additional calorie which gets converted into fat goes to your organs or belly, right? So remember, if you are even thin, we have increased visceral fat. And small drinks, I take a small, thoda sa leta hu, yaar party mein lete hain. But that will cause you problems, sir. That doesn't mean I am not taking it, sir. Right? But it is a fact. Now, I don't want to go to discuss how it is causing liver disease, alcohol and fat. Now, I have written here in the low level of alcohol consumption is safe for our health. Now, World Health Organization has classified as a carcinogenic now. It causes increased esophageal cancer, prostate cancer, bladder cancer, stomach cancer, pancreatic cancer. If you have diabetes and small amount of alcohol, you are very prone to develop pancreatic cancer. And there is a demand, there should be a stamp, just like cigarette packets. Smoking kills. Similarly, alcohol bottles should have such stamps. Alcohol killed. Sir, you are chairing CDS CO, all chairmen do that. Alcohol kills. Now, second thing, this is human habit, right? Lifestyle. What is this lifestyle? Now, how many people in this audience has a waist circumference more than 0.9? They have all increased visceral fat. We are not designed to have waist circumferences more than 0.9 centimeter. And for Indians, that is obese. That is your obesity. You have a BMI more than 23, waist circumference is more than 0.9 for male and 0.8 for female, or waist and height ratio less than 0.5 is ideal. If it is more than 0.5, it is also obesity. Now, see the magnitude. Now, 351 million people has abdominal obesity in India. And I have childhood obesity is a big problem. And it is rising. That's another problem in India. School children are getting obese. And you are hearing, young age sir is seeing young age people coming with heart attacks, AMI, right? STEMI, practically frank STEMI you are seeing. So, what happened? Forget Charles Darwin's evolution theory. Yeah, we have evolved in jungle. Now, we all know this. When we evolved in jungle, we didn't have 4 times meals, sir. We didn't have breakfast, lunch, afternoon snack and dinner. We used to walk 10 kilometers to search our meals, which are in niche area. So what happened, sir? There was a fed state and there was a non-fed state. But for the both state, you need fuel. In the fed state, it is glucose which is fuel which burns in TCA cycle and produces energy. At non-fed stage, you don't have glucose. So during fed state, your gene recognized that you have to become a human, you have to do something. So it stored 10 to 12% of your food as fat. For that you have to create fat cell. So body gene created adipocyte below the skin. But Asians, we do not have adipocyte below the skin. That's the problem. And what happened? We didn't have these 2 fed state. We continuously ate 4 times. So we didn't have non-fed state. Non-fed state is very important for human survival and human aging as well as health and prevention of cancer. If you see, in 2016, a Japanese scientist got a Nobel Prize for a concept called autophagy, omushi. What it saw, it started from a baker story. It is interesting, that's why I will tell. A baker used to feed his yeast for fermentation in a petri dish, and the feeding is nitrogen. At the weekend he went home and didn't feed it. Came back on Monday under microscope, he found the healthy cells are eating away unhealthy cells. And the concept of autophagy, that when you are having a fasting state long enough, right, there will be some cells will degenerate. But healthy cell will not allow it, and they will destroy it. The destruction in human being has been studied by lysosomal destruction, or healthy cell eating a dead cell, because defective genes can mutate and proliferate unchecked, which is cancer. So autophagy is a major way how to prevent cancer. Obesity therefore increases the risk of cancer. And this is the concept on which a Nobel Prize was given. But we destroyed this habit of non-fed and fed state, and we added dietary excess, refined sugar. See the last figure. That's what we do today. Food with high glycemic index, sedentary habits, all we know, prolonged sitting we know all cause smoking, and add too nice drink. And I told about sleep. Professor Aparajit Ballabh during his speech probably didn't emphasize. Will you agree sleep is important? And do you think lack of sleep causes a lot of metabolic dysfunction in the body? And do you think sleep is less and less as you age old and old? That's another big problem. Mental health, stress itself. Stress hormones are cortisols. Cortisol causes insulin resistance, causes hyperglycemia. Of course, we don't know about how much Delhi pollution is added to your problems. And we have genetic risks. As Asians, I told, we have certain genetic risks to develop all this, and particularly we do not have subcutaneous adipose tissue. And keeping this in mind, think how much strong our liver can be. If you do just ultrasound in this group, you will find at least 30% have fat. And little here and there. So that's what I was trying to say. Even non-fat stage, the fuel is fat burning, producing ketones through acetyl coenzyme. I don't want to go to the biochemistry. Ketones is very important. While ketones is producing, many genes are upregulated, which are responsible for autophagy, anti-inflammation and anti-aging. That's why intermittent fasting becomes so popular, or alternative fasting becomes so popular, which was known but was practiced later on, providing a lot of benefits. But when you extra fat, it's not very benign. Fat is an endocrine organ. Fat produces a lot of cytokines. It produces adipokines, leptin. Leptin is a satiety hormone. Right? It increases leptin, you are never satisfied with the amount of food. So you consume more and more food. Right? Once you become a fat, you try to consume more food. And it also produces adipokines in white macrophages. M1 macrophages, which are inflammatory macrophages, produce cytokine. It spills over to the system, and you have an inflammatory state if you are obese. Circulating in your endothelium, endothelial dysfunction, increased lipids, endothelial dysfunction, arteriovascular disease, atherosclerotic disease, strokes and heart attack. If you see, steatotic liver disease prevalence is about now 38% of the Asian population, including India. That's what I want to see. But whereas alcoholic liver disease is less, because alcoholic enzymes are polymorphic. There are two important enzymes, alcoholic dehydrogenase, acetaldehyde dehydrogenase. Alcohol converted to by alcoholic dehydrogenase to acetaldehyde dehydrogenase. Acetaldehyde dehydrogenase get converted to acetyl coenzyme, goes to TCA cycle to become carbon dioxide and water. These two enzymes are polymorphic. They are not same functionally. If rapidly acetaldehyde is converted from alcohol, it is toxic to the liver. But slowly converted acetaldehyde to carbon dioxide, that is acetaldehyde accumulates. But acetaldehyde is rapidly converted to carbon dioxide and water, you will not get liver damage. That's why 25% of alcoholic gets liver damage. But with little obesity, that is more. That's why it has become dangerous. So that's what I explained. This lifestyle changes results all these problems and results in multiple diseases, not liver disease. All form of diseases are responsible for it. Now, simple, how do you know it? Your chest will not expand. You will not have a gaseous exchange because a lot of resistance. So previously you used to run 3 stairs. Now you cannot walk 1 stair. Heart is okay, but it is obesity which is causing this restriction. You have a double chin, you can see some of you, a kind of double chin. And abdominal waist fat. If you just stand, I cannot see your nail just like this, you have obesity. That is a simple test. And you feel lethargic. And there are many ways to know. I don't want to go to these details. And cardiometabolic risk factors are very well known to all of you. BMI, waist hip ratio, blood pressure, impaired fasting glucose, triglycerides, or lower HDL. They are all known. Even one is an important cardiometabolic risk factor. But important what is today, slight dyspepsia, you have ultrasound. And ultrasound picks up liver. Very easy to pick up. If you see in the first diagram, I have put kidney and this is liver. See the echogenicity, except same. But if you see in this, see the echogenicity difference between these two. So you compare kidney with the liver, you know it is a fatty liver. You have fat in the liver, you have a metabolic disbalance. You are having visceral obesity. It is not nice. And it can cause various diseases. This is the world statistics. I don't want to give. I just told it can be multisystemic disease. Second is diabetes. This is a study from India, published this year, this month, from all over the country. 9,000 people. And they didn't know that they have liver disease. They were silent. They were treating their diabetes. And you see, 1 in 4 had significant liver fibrosis. 1 in 10 has advanced liver fibrosis without their knowledge. So it's very dangerous. Even those with less fat in the liver had also advanced fibrosis. So diabetes per se is a risk factor for liver fibrosis by insulin resistance, and there are metabolic pathways. So I told alcohol, obesity and lifestyle, and presence of diabetes. Half of the people in our country probably are diabetics amongst the urban population, but they are never screened. Easy to screen and easy to prevent, reverse it. Mental health. We know about hypothalamic pituitary adrenal axis. Increased cortisol causes insulin resistance. Insulin resistant, more insulin production, insulin causes more lipogenesis, and the whole cycle goes on. You have seen Cushing syndrome, you have abdominal obesity. We have abdominal obesity. We have this problem of stress related hypercortisolemia. This is the feedback which is gone in presence of hyperinsulinemia. And cortisol causes increased insulin secretion. Insulin secretion causes more fat, and cortisol antagonizes insulin in the substrate level and cause hyperglycemia, which becomes again fat. This cycle continues. Sleep. Actually, adolescents should sleep at least 8 to 10 hours. Adults should not sleep less than 7 hours. This is a large study, multiple study based on which American Association of Sleep Medicine has defined. I found a study from China, 17 cross-sectional population meta-analysis, 1 in 6 don't sleep. And multiple studies and survey has that if you have sleep deprivation, it increases hunger, snacking, right? Increased binge food, saturated fats. And in the next day morning you are feeling lethargic. You don't do physical activity. So if you have less sleep, it increases something called ghrelin, a hormone from stomach which increases hunger by working on medullary thalamic arcuate nucleus, which is a center for satiety. It decreases leptin, so satiety is never there. So increased food itself is a stress, so there increased cortisol. And stress induces catecholamines, which cause glycogenolysis, increased glucose, increased heart rate, vasoconstriction. So it itself is a problem. And if you see weight gain by hours, less than 6 hours, you gain about 2.5 pounds. 6 hours, you gain 1.6 pound. 7 hours plus, you don't gain any weight. So how do you protect? I just told about the problems. You can easily go through. Time is up, weight loss, if you are obese. If you lose 10%, your hepatic fibrosis vanishes. So, good diet. You know what diet? predominantly vegetarian diet and protein, which should come from fish and lean meat and some cereals. Exercise, both aerobic and resistant exercise are equally effective. But you must do that. It should be habit. And this is a study I found, I told about stress level. You see, if you do exercise, after 1 year of exercise, people estimated cortisol level, cumulative cortisol level in this hair. Those who have regularly exercised, the cortisol level is down. So your hypercortisolemia due to sedentary habit is gone. And that's very important part of exercise. It has been shown to increase neuroplasticity. At later age also you will be bright. It is not that there will be dementia or degeneration. You have good autonomic nervous system control. There should not be any sympathetic overdrive because of stress and sleep. And you have excellent hypothalamic pituitary axis control. Gut microbiota is another thing which has been involved in fatty liver disease. And it changes in 5 days diet. If you take 5 days vegetarian diet, your gut microbiota improves to a healthy gut microbiota. Take 5 days red meat, you have very bad gut microbiota. I can discuss about that, but no time. Hepatitis, we have vaccination, we have various ways to prevent. That's a separate topic altogether. But that vaccination I always say, you should. And various hepatotoxic drugs and alternative complementary medicines which contains alkaloids and heavy metal which are hepatotoxic. You have to be very careful for that. So, friends, this is a caption I always give. Say, love your liver. If you love your liver, you will protect your heart, you will protect your kidney, you will protect your brain, you will protect your bones, you have mobility. It is center. So to do that, no sweets, no processed food, no fruit juice fructose directly get converted to fat, less carbohydrate, more protein, lean proteins, exercise, nil alcohol, sleep well, and have a mental health problems which I emphasize, and take all preventable vaccine for liver disease. Thank you. Thank you very much.
Thank you very much, Professor Acharya. Though you said no alcohol, 2 drinks a day, 2 drinks a day is good, or Saturday 6 drinks?
2 drinks.
Velu was sitting with me. Where is Velu?
Yeah, he's around, sir.
Yeah, he was telling when Professor Dev was speaking about old age depression, and he told, look, Dr. Acharya, if I have my evening 2 drinks, right, I want to drink, I know I don't have depression. The day I stop it, that day I don't have depression.
Stop.
That's
1
what
minute. Just.
he told me. Sir is asking me the same thing.
So thank you, sir. Thank you. Lovely. It's a wake-up call for many of us.
Yeah.
You know, the best part is that firstly he scared us, and in the end he gave us some positive answers that do this, and then, you know, be away from liver malfunction.
Thank you, Chairperson, sir. We request all the speakers to come to the dais. Dr. कहाँ गए?
Dr. Day.
Dr. Day.
He has to come to speak.
YK Gupta. YK वहाँ पे होगा यार.
So why you are kept me sitting alone?
What we do, we first request Dr. Acharya to felicitate our chairperson. Yeah. जाओ भाई. Dr. Verma, please felicitate Dr. Acharya. YK, ऊपर राजा. चलो. मैं जाऊं? हाँ हाँ आप जा सकते हो. गोल्ड का है, भारी है थोड़ा सा. लगता है. हाँ. AB Day.
Dr. Day. Dr. Days.
We'll hand it over sometime. Dr. Kar, please come. We'll felicitate you. Thank you, sir.
All the best. Thank you.
Thank you, sir. Thank you. So there would be a break for 5 minutes. We'll just adjust the tray, and please excuse us. Thank you. पे और फिर फोटो वोटो के टाइम मिल जाएगा हमारे
ले आइए
तो
सर,
very
4
good.
बज गए हैं।
नमस्ते।
Good evening, ladies and gentlemen. Please put your hands together. The chief guest for today's event has arrived. Please welcome the Honorable Chief Guest, Dr. P.K. Mishra, Principal Secretary to the Honorable Prime Minister of India. Please be seated. Good evening, everyone. A very warm welcome to all of you to this prestigious occasion, the 66th Foundation Day of National Academy of Medical Sciences. The chief guest has arrived. I request please put your hands together. May I request the Honorable Chief Guest, Dr. P.K. Mishra, to grace the stage. I request Dr. Digambar Behera, President NAMS, to please come on the stage. Lieutenant General Dr. Velu Nair, PVSM, AVSM, VSM, retired President-elect NAMS, to please come on the stage. Lieutenant General P.P. Verma, AVSM, SM, VSM, retired Treasurer NAMS, to please be on the stage. And Dr. Umesh Kapil, Secretary NAMS, is also on the stage. A very warm welcome to this prestigious occasion of 66th National Foundation Day of National Academy of Medical Sciences. Today we gather not just to celebrate a milestone, but to honor a legacy of excellence, dedication, and service to the nation in the field of medical sciences. It is indeed a moment of pride to be in presence of eminent dignitaries, distinguished scientists, and respected members of medical fraternity. आज का ये स्थापना दिवस सिर्फ वर्षगांठ नहीं है, बल्कि समर्पण, सेवा और चिकित्सा के क्षेत्र में उत्कृष्टता की एक प्रेरणादायक यात्रा का उत्सव है. आप सभी की एक अचीवमेंट का उत्सव है. Today's event is graced by the Honorable Chief Guest, Dr. P.K. Mishra, who is Principal Secretary to the Honorable Prime Minister of India. Please welcome him. Put your hands together for his gracious welcome. I request everyone to rise for Vande Mataram. Thank you everyone. Please be seated. किसी भी अच्छे काम की शुरुआत ईश्वर के नाम से होनी चाहिए और आज एक विशेष दिन है, स्थापना दिवस की वर्षगांठ है. To invoke divine blessings and mark the auspicious beginning, may I request our honorable chief guest and the dignitaries on the dais to proceed for lighting of the lamp ceremony.
Sa sa ni sa ni pa pa li ma ma pa ma pa ma ma ni da
Thank you so much. The light we have kindled today symbolizes knowledge, wisdom, and hope. Institutions are built with time, but they are strengthened by the people who lead them. And today, we are privileged to be in the presence of such guiding forces. Honor and gratitude form the essence of Indian tradition. May I now request the President NAMS, Dr. Digambar Behera, to present a token of respect to the Honorable Chief Guest, Dr. P.K. Mishra, please. Please put your hands together, ladies and gentlemen.
अच्छा रहेगा सर आप सामने अच्छा लगेगा वो कितना
I request Dr. Velu Nair, Lieutenant General, PVSM, AVSM, VSM, retired President-elect NAMS, to felicitate the President NAMS, Dr. Digambar Behera.
Sorry. Sir, thank you.
Please put your hands together, ladies and gentlemen. Each one of you present here has put in a lot of efforts to build this academy, and the Foundation Day is a great event. So this one is for you. Please give a huge round of applause for each one of you. I would request for the felicitation of Dr. Lieutenant General, Dr. Velu Nair. Madhuri ji. Please put your hands together. आज बहुत ही विशेष अवसर है, इसलिए तालियों की कमी नहीं होनी चाहिए. तालियां बजती रहें, प्लीज. Felicitation for Lieutenant General Dr. P.P. Verma, AVSM, SM, VSM, retired Treasurer, NAMS. Dr. Umesh Kapil, Secretary, National Academy of Medical Sciences. Please put your hands together, ladies and gentlemen. Today is a great day. It is the celebration of your efforts. आज का दिन सिर्फ उत्सव मनाने का दिन नहीं है, बल्कि उन सभी प्रयासों को सलाम करने का दिन भी है जो आप सब ने हर दिन किए हैं, हर दिन अनगिनत जिंदगियों को बेहतर बनाने के लिए. To welcome our honorable guests, I request Lieutenant General Dr. Velu Nair, PVSM, AVSM, VSM, retired President, elect National Academy of Medical Sciences, to please welcome our honorable guest.
Thank you. Our honorable chief guest, Dr. P.K. Mishra, respected President Dr. Digambar Behera, Secretary Dr. Umesh Kapil, our past presidents, I see Dr. S.K. Sareen and Dr. Churamani here, distinguished fellows of the Academy, honored awardees, respected colleagues, ladies and gentlemen. A very good evening to one and all, and I would like to tell you that with immense pride and privilege that I welcome you all to this 66th Foundation Day of the National Academy of Medical Sciences. An institution that has over the decades become a pillar of academic excellence and a guiding force in shaping the landscape of healthcare in our country. We are deeply honored by the presence of our chief guest, Dr. P.K. Mishra, who is the Principal Secretary to the Prime Minister of India, whose visionary leadership and unwavering commitment to national development continues to inspire the complete biomedical committee, both the medical fraternity and the scientists alike. And sir, your presence has greatly enriched this occasion this evening. If you see Dr. Mishra's career profile, I can go on for a long time, but to briefly put it, he has put together, great research, published them, helped in policy formulation and project and program management relating to agriculture. Disaster management has been a key portfolio, and of course, handling issues in the power sector, infrastructure, financing, and the regulatory issues. He did his MA Economics with an outstanding, performance at the Delhi School of Economics, and went on to complete his MA in Developmental Economics in the University of Sussex. He didn't leave it there. He went on to earn a PhD in Economics and Developmental Studies from the same very university in Sussex. In 2019, he was conferred the prestigious United Nations Sasakawa Award, which is the most prestigious international award for disaster management. His international experience includes research and academic work in the Institute of Developmental Studies in the UK, negotiation execution of ADP and World Bank projects, and being a member of the ICRI-SAT, which stands for International Crop Research Institute for Semi-Arid Topics, and he has been an expert and resource person in multiple international fora. As a part of the PMO since 2014, he is credited with transformative changes in actually, in the field of human resource management and effective monitoring of developmental initiatives. His key role in the Government of India's effective response to the unprecedented COVID-19 challenges is extremely well documented. I'm very thankful to you, sir, for that. As a chairman of the coordination committee of the India G20 presidency, which was such a huge success and a global, success for everybody to see, he played a very key role in this whole, coordination, preparedness, and all the, infrastructures which had to be put together. And as Secretary of Government of India in the Ministry of Agriculture from 2006 to 8, he actively involved in certain path-breaking national initiatives such as the National Agricultural Developmental Program and the National Food Security Mission, which is such an important agency. He's extremely well published. The first book I want to say is The Kutch Earthquake, Recollections, Lessons and Insights, 2005. Then there's another one on agricultural risk, insurance and income, published from the UK in 1996. And then he's edited a book on agricultural insurance for the Asian Productivity Organization from Tokyo. And likewise, another book on recalibration and changing paradigms. 5 chapters have been contributed by him. So he is so well published and acknowledged internationally that we are very, very fortunate to have you, sir. You've really enriched this evening by your presence, sir. And today, I would like to say is a great evening for this NAMS Academy, because one of the initiatives is recognition of academics of excellence. And this not only celebrates merit, but also sets benchmarks for aspiring professionals across the country. And NAMS, has the ability to bring together diverse domains of medical science under one very umbrella. And I would say today we have a plethora of distinguished scientists and acknowledge the exemplary achievements. We celebrate not just the individual excellence, but the enduring legacy of an institution that continues to influence the future of healthcare in India. Once again, I extend my warmest welcome to all our esteemed awardees, dignitaries, and participants. Your presence adds great value to this celebration. Jai Hind.
Thank you, sir. We are here to celebrate the prestigious moment of 66th Foundation Day of National Academy of Medical Sciences. It is the premier academy of medical and biomedical scientists in the country, an organization of acclaimed physicians, academicians, and researchers in the medical sciences field. Fellows of NAMS are among the most distinguished medical professionals in the country. It has members from Ministry of Health and Family Welfare and all dignified people who have been working 24/7 for years together to put things right in place for the development of the country and to help and support people. NAMS has built many task forces in collaboration with Ministry of Health and Family Welfare. Great institutions carries a legacy, but what keeps it alive is its vision for tomorrow. What is the vision of NAMS? We need more highlights on this. कहा जाता है कि एक सपने से शुरू हुआ जो सफ़र आज वो एक मिसाल बन चुका है। दशकों की तपस्या सिर्फ इस संस्थान ने की है और ये प्रेरणा का एक नाम बन चुका है। हर ईंट पर समर्पण की कहानी है, हर दीवार में विश्वास बसा है। ये सिर्फ एक संस्था नहीं, पीढ़ियों के सपनों के सुनहरा निशान बन चुका है। Tell us more about the achievements, vision, and the future plans of this academy. I would request the President NAMS, Dr. Digambar Behera, who is Padma Awardee and Director Pulmonary Medicine, Fortis Healthcare. He has been the President of Indian Society for Study of Lung Cancer, President Indian College of Asthma, Allergy and Clinical Immunology, and has been honored with several awards. To please give us more information and throw more light about the vision, history, and the future plans of National Academy of Medical Sciences. Dr. Behera.
A very good evening to everybody and a happy Foundation Day to all of you. Honorable Chief Guest, Dr. P.K. Mishra ji, Principal Private Secretary to the Prime Minister of India, Honorable Union Minister of Health and Family Welfare, Sri J.P. Nadda ji, in absentia, General Nair, President-elect NAMS, General Barma, the Treasurer NAMS, Honorable Council Members, Dr. Umesh Kapil, the Secretary of NAMS, the past Presidents, I could see Professor Talwar, Professor Sareen, Professor Saroj Chudamani, then Emeritus Professors, Fellows, Members, and the recognition of Academic Excellence Award winners, ladies and gentlemen. A warm welcome to this 66th Annual Foundation Day celebration function of the National Academy of Medical Sciences. The Academy was established on the 21st April 1961 as an autonomous organization under the Ministry of Health and Family Welfare. It was inaugurated at New Delhi on the 19th of December 1961 by the first Prime Minister of India, Pandit Jawaharlal Nehru. And NAMS is the only medical academy in the country. The vision of NAMS is to act as a resource group and a think tank for policymakers in all current and future spheres of health, including medical education, research, and innovation for cost-effective healthcare to help the humanity. The Academy fosters and utilizes the academic excellence of health professionals in the country as its resources to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Academy is governed by a council which has 23 members elected by the fellows of the Academy. The Academy confers the fellowship and memberships to eminent medical and biomedical scientists who are selected through a rigorous process of selection. The success rate is below 20%. It was entrusted with conducting the National Board of Examination earlier. The Academy Fellows have been the recipient of highest civilian awards of the country such as the Bharat Ratna, Dr. B.C. Rai Award, and Dr. APJ Abdul Kalam. In addition, amongst the NAMS fellows, 10 are Padma Vibhushans, 32 are Padma Bhushans, and 96 are Padma Shri awardees. The Academy is like a banyan tree, meaning thereby an umbrella organization. Unlike many professional societies of the country, it is unique in the sense that it is an organization of all specialties and who is who in the field of biomedical sciences as part of this great organization. Excellence is the only criterion to be part of this great and unique organization. Some of the major activities which has already been highlighted, I'll just name few of them. That is about the NAMS fellows and members. I have already told you every year the Academy organizes an annual conference in which the scrolls of NAMS fellowships, memberships and associate fellowships are bestowed. Eminent medical professionals, presidents of national professional organizations and other national academicians participate in that conference. Plenary sessions are also held on various current and important national issues. As on February 2026, the NAMS has 1172 fellows, that is FMS, 12 international fellows, that is MMS, 61 associate members, 11,500 members by the Diplomat of National Board of Examinations, that we call them as MNAMS, and 52 emeritus professors. We have a cadre of NAMS emeritus professors. We have got 52 at this time. Then we conduct leadership development workshops. The initiative of this leadership development program is to impart leadership skills for directors, deans, and head of the departments and senior faculty members in various AIMS and medical colleges, institutions of national importance. The resource persons are the eminent medical leaders and administrators. Then we have got various state conveners, NAMS cells, and policy documents for national policymakers are made regularly. The task force of eminent medical professionals from the government and private organizations, as well as the representatives from Ministry of Health and Family Welfare, is made to prepare policy documents. The aim is to provide support to policy-making bodies of the Government of India for consideration in framing policies on important national health issues. The 20 task forces have so far completed their work, and 18 of these reports have been published in the NAMS journal. As advised by the Niti Aayog during NAMSCon 2025 that was held at PGI Chandigarh, we have constituted 3 more task forces on One Health, family medicine and pollution and health. Then the Academy has been recognized by the Government of India as a nodal agency for promoting continuing medical education for medical and allied health professionals. Every year, financial assistance is provided to institutions from all over the country for CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. Disseminated workshops on important topics like organ transplant and artificial intelligence and health is being carried out on a regional basis to cover all the medical colleges and institutions of the country. We have completed so far 2, one at the AIMS Bhopal and the other one as AIMS Bhubaneswar, and 4 more to go. I think another important highlight of the NAMS activities is the NAMS AIMS PGI Navigate Medico CME program. This program of NAMS, in collaboration with the All India Institute of Medical Sciences and the PGI Chandigarh, is for the postgraduate medical students. This is conducted online on every first and third Friday of every month between 3 to 5 p.m. Till date, 91 sessions have been conducted. The video recordings are available on the NAMS website and the YouTube. Then important international experts give regular lectures. Then I think another important activity is the recognition of academic excellence. I think the awardees are going to be honored by our Honorable Chief Guest soon during this program. Then we also recognize women in medicine. NAMS has been honoring eminent medical and biomedical women scientists named as the eminent women in medicine in India to recognize their academic achievements and contributions. Then we also run and partnership, we are partner in the online certificate course on artificial intelligence in health for health professionals. Then International Institute of Information Technology, Hyderabad, that is IIIT, that is, and the NAMS, we jointly launched a certificate course, and till date, 394 participants, mainly health professionals, they have completed the course in 3 batches, and currently the 4th batch is undergoing training. Then we have got the ICMR and the NAMS, National Biostatistics Helpline, for PG medical students to get statistical help, that is the online and around the clock. This facility is available free of cost. Then we network with medical colleges and institutions of the country, and then we conduct the NAMS National Quiz. I think the quiz masters will also be honored today. Then we also distribute NAMS research fellowships to encourage medical research for the PG medical students and young faculty members, particularly from areas like northeastern states, Jharkhand, Chhattisgarh, Andaman and Nicobar, Daman and Diu, Jammu and Kashmir and Ladakh. So we give one-time financial assistance to these students and the other faculty members to carry out their thesis-related work and other research activities. Then the Medical Scientist Exchange Program is another area in which NAMS also contributes. Then the NAMS publication, the official journal of NAMS is the Annals of the National Academy of Medical Sciences. Thus has been serving the biomedical research fraternity of India since its inception 60 years ago. I think the most recent achievement of the Annals is that the bi-monthly journal, we have achieved one of the important milestones when the Annals was selected for the M-Base along with inclusion in the M-Care and M-Biology databases. So this selection makes this annal getting officially recognized by the National Medical Commission. This achievement makes a significant step towards enhancing global visibility and the scientific impact of high-quality medical research emerging from India. And we must give credit to our Editor-in-Chief, Dr. Anil Jain, for this. So thank you, Dr. Jain. Then the Academy has developed its future vision documents under the chairmanship of Dr. V.M. Katoj, the former Director General of ICMR. The key focus of future activities of the Academy should be on generation and dissemination of medical knowledge throughout the country through different mechanisms. Need is to lay down procedures to identify contemporary topics, define mechanisms for deliberation, prepare documents, and a timely dissemination through publications, as well as special meetings, seminars, symposia, and CMEs, plus the usual CME strategies followed by NAMS. So these strategies will include strengthening of the important and key activities already undertaken, then identification of certain other key issues in the field of medicine, preparing policy documents after identifying experts in each field, making regional disseminated workshop, as I have already pointed out, already done in 2 at the AIMS Bhopal and Bhubaneswar. on artificial intelligence and organ transplantation. Then the NAMS should regularly interact with other national and international scientific academic bodies, signing MOUs with other scientific bodies like ICMR, DBT, DST, medical universities, various AIMS and CSIR, etc. It should also strengthen its infrastructure and manpower in line of its increased activities. Fund generation through Government of India and CSIR means should be explored. Our office space needs rebuilding and expansion, for which we will need the support of the Government of India. Sir, the strength of the National Academy is its huge and talented manpower in the field of biomedical sciences. The expertise, years of wisdom, administrative acumen in the line of health administration, medical research, and healthcare delivery is enormous. This resource is available always to the government and to the people of India. Only you need to ask for it, and I assure you, sir, the entire invaluable human resources will be available to you. The Academy will like to dwell on issues of medical education, research, and healthcare delivery improvements in the country. There are certain issues that need special attention. It will be a constructive suggestion and in line of what the policymakers and government wants. It will only strengthen the hands of the government to achieve these goals. The vision of Vikasit Bharat aims to transform India into a developed nation by 2047 with a focus to improve the healthcare system in India that is undergoing a significant transformation under the leadership of Honorable Prime Minister Sri Narendra Modi ji, with a people-first approach to making quality healthcare accessible and affordable to all citizens. Key initiatives like Ayushman Bharat is the world's largest health assurance program, targeting the bottom 40% of the population, covering approximately 12.37 crore families. The others, like Pradhan Mantri Ayushman Bharat Health Infrastructure, National Health Mission, Digital Health Backbone, etc., and the pharmaceutical affordability, etc., are unique health programs and schemes in the world today that is being seen in this country. So these initiatives aim to bridge gaps between primary, secondary, and tertiary care, ensuring equitable access to healthcare services without financial hardship. The National Health Mission also promotes community participation and engagement in healthcare decision making and service delivery. The NAMS has been and will be privileged to be a party to this endeavor by the Honorable Prime Minister and will contribute towards the nation-building efforts. With these words, I thank you, sir, again for gracing this occasion and thank the Honorable Union Minister of Health, Sri Nadda ji, for sending his well wishes. At the end, I am thankful to all of you, ladies and gentlemen, the members of the Council, the staff of the National Academy, all fellows and members, the past presidents, for their guidance throughout the years, and other guests for gracing this occasion. Jai Hind.
Thank you, sir, for sharing the inspiring journey and vision of the Academy. Behind every recognition lies a story of efforts, patience, and resilience. And today, we celebrate not only the achievements, but its journey also. And now, ladies and gentlemen, we come to the most significant segment of today's program. May I request the dignitaries on the dais to proceed for release, recognition of Compendium of Academic Excellence. Please put your hands together, ladies and gentlemen. It is the recognition of efforts, resilience, patience. that each one of you has put for this National Academy of Medical Sciences. Please put your hands together. A huge round of applause for the efforts of each one of you. And now is the time for release of NAMS annals. Please put your hands together. Great moment for everyone, ladies and gentlemen. And now I would request Dr. O.P. Kharbanda to come on the stage because it is the time to honor the RAE award recipients. Dr. Kharbanda, please.
Good afternoon. I'll be announcing the names of the persons who have been conferred with the RAE, recognizing academic excellence. So please come from this side, receive the award, and then you can go from that side. So to start with, we have Colonel Sangam Lal recognition of academic excellence, and this goes to Dr. Shashanka Mohan Bose from PGI Chandigarh. Congratulations, sir. आप आ गया सर, आप आ गया आप आ गया नहीं सर, आप आ गए चलो सर, आप आ गया। Dr. Pran Nath Chutani recognition of academic excellence goes to Dr. N.K. Mishra and also Dr. Kar. Ramashish Kar, please. Please come forward. Congratulations, sir. Thank you, sir. And Dr. Premashish Kar. Thank you, sir. Dr. Tulsidas Sukh recognition of academic excellence goes to Dr. Shaili Avasthi. नहीं हो गया बोलता चलेगा okay. I will also request Dr. Aman Sharma to please come forward. Dr. Aman Sharma, please. Congratulations. Dr. Ghani from Srinagar, please. Dr. Tejinder Singh. Dr. Tinku Thomas. Dr. Tejinder Singh. आ गए चले गए लेकिन
हमने तो दिया नहीं मेरे पास
चले गए डॉक्टर क्या प्लीज डॉक्टर टिंकू थॉमस आइए डॉक्टर नवीन कालरा प्लीज एंड डॉक्टर सोनू गोयल Dr. Naveen Kalra. Yes, yeah, please go ahead. Fast. Oh, thank you. आप बोल दोगे चीफ गेस्ट. Dr. Sonu Goyal. मैं बोल देता हूँ. Thank you बोल देता हूँ. Thank you sir. आप बोलो. नहीं मुझे नहीं Thank you, sir. Thank you.
Please be here only. I think we will have to hear. And now is the time for the honors of the past President of National Academy of Medical Sciences. NAMS आज एक बड़े मुकाम पर पहुंचा है और दशकों की मेहनत की जो ये पहचान है ये यूं ही नहीं मिली है. इसके पीछे उन लोगों की खून पसीना मेहनत है, इसलिए ये उनकी विरासत है जिन्होंने सपनों को हकीकत में बदला है. NAMS के पास प्रेसिडेंट्स यहाँ पर उपस्थित हैं एंड आई वुड रिक्वेस्ट द ऑनरेबल चीफ गेस्ट टू ऑनर द पास्ट प्रेसिडेंट ऑफ नेशनल अकेडमी ऑफ मेडिकल साइंसेज. फर्स्टली डॉक्टर के तलवार. प्लीज पुट योर हैंड्स टुगेदर फॉर डॉक्टर के तलवार, लेडीज एंड जेंटलमैन. प्लीज. It's a great moment for all of us. तालियां बजती रहें, ladies and gentlemen. It's a great moment, great honor to have all the past presidents here. Dr. Saroj Churamani Gopal, please come on the stage. Of course, yeah. Ma'am, please. Thank you. And the next person who I am calling is the most versatile personality in the medical fraternity, a gentle human being and a great doctor. Dr. Shiv Kumar Sareen, please come on the stage. Please put your hands together for Dr. Sareen, ladies and gentlemen. Thank you all the past presidents for your immense contribution to the achievements of National Academy of Medical Sciences. And now we would like to honor the quiz team. I would request the chief guest to honor the quiz team. First of all, Dr. Preeti, please come on the stage. Dr. Jaswant, Dr. Nikhil Mehta, please come on the stage to receive the honors. Please. Please. Please put your hands together for the quiz team who is being honored. Thank you so much, the chief guest and all the dignitaries. Please take your seats. And now we would be playing a special message from the Honorable Union Minister, Ministry of Health and Family Welfare, Shri J.P. Nadda ji, who has congratulated the entire team, National Academy of Medical Sciences, on this prestigious occasion.
Friends from the medical and scientific community, Namaskar. It gives me immense pleasure to be the part of the 66th Foundation Day ceremony of the National Academy of Medical Sciences. I wanted to join the celebration personally, but due to the other pressing engagements, I could not attend the event physically. The National Academy of Medical Sciences continues to provide a platform for recognizing eminent clinicians and scientists as its fellows or members. Fellows of this academy are amongst the most distinguished medical professionals of the country who have helped to develop high standards of patient care and medical training in various specialties over the years. I am happy to learn that the National Academy of Medical Sciences encourages and sponsors nationwide medical education programs, symposia and workshops in basic sciences and applied clinical disciplines. These efforts play a crucial role in fostering continuous learning and the capacity building within the medical community. As the Academy celebrates its 66th Foundation Day, I extend my best wishes to fellows and members and wish the occasion a grand success. Thank you.
Thank you for his appearance and his efforts to give this special message on this special occasion. When experience meets responsibility at the highest level, what emerges is perspective that guides a nation. जहां फैसले देश की दिशा तय करते हैं, वहां उनकी सोच एक प्रकाश बनकर उभरती है. आज हम उसी उजाले का स्वागत करना चाहेंगे. May I humbly invite our Honorable Chief Guest, Dr. P.K. Mishra, Principal Secretary to the Honorable Prime Minister of India, to guide us and enrich us with his pearls of wisdom. Please put your hands together for the Honorable Chief Guest.
Dr. Digambar Behera, President, National Academy of Medical Sciences, Lieutenant General Dr. Velu Nair, Dr. Umesh Kapil, Dr. P.P. Verma, fellows of the National Academy of Medical Sciences, eminent doctors, researchers, academicians, esteemed guests, ladies and gentlemen. I am delighted to be present here today on this occasion of the 66th Foundation Day of the National Academy of Medical Sciences. I extend my warm greetings and congratulations to all the members past and present of this esteemed institution for their invaluable contribution to advancing medical education, research, and healthcare in India. On this occasion, I extend my heartfelt congratulations to the scientists, doctors being honored today. Your contributions are a source of inspiration and pride for the entire nation. You represent the highest standards of excellence and dedication in the field of medical sciences. I also congratulate the quiz team for their contribution to the NAMS academic activities. Past presidents of the Academy had played a significant role in shaping the future of the Academy. I thank them for building up an institution which is playing an important role in India's health sector. For over 6 decades, the National Academy of Medical Sciences has stood as a beacon of excellence, bringing together the finest minds in medical and health sciences, fostering academic rigor, and contributing meaningfully to the national health priorities. This occasion is not only a celebration of the Academy's distinguished legacy, but also an opportunity to reflect on the evolving role of medical institutions in shaping the future of healthcare in our country. Friends, in the last decade, India has witnessed a transformative phase in its healthcare journey, guided by a commitment to accessibility, affordability, and equity. Government of India has undertaken several landmark initiatives that are shaping the healthcare landscape. One of the most significant achievements has been the successful implementation of Ayushman Bharat, Pradhan Mantri Jan Arogya Yojana. This flagship program provides health insurance coverage of about up to ₹5 lakhs per family per year for secondary and tertiary care hospitalization. It now covers approximately 60 crore beneficiaries, representing the bottom 40% of India's population. Complementing this is the creation of over 1.8 lakh Ayushman Arogya Mandirs, which have shifted the focus from curative to preventive and primary health care, ensuring last-mile delivery even in remote areas. I am pleased to note that over 44 crore Ayushman Bharat cards have already been issued across the country, reflecting the scale and inclusiveness of this initiative. This has not only improved access to health care, but has also reduced out-of-pocket expenditure of millions of families. Complementing this is the Ayushman Bharat Digital Mission, which is laying the foundation of a robust digital health ecosystem. The creation of ABHA, Ayushman Bharat Health Account cards, serving as unique health IDs, has covered over 88 crore individuals, enabling seamless access to health records and improving continuity of health care. Of course, the digital health mission is yet to go a long way because there are health card digital data available, but many cases, a lot of gaps are there, like registration of, say, doctors, registration of various health facilities, and so on. A major achievement in the last decade under the leadership of Prime Minister Sri Narendra Modi is strengthening of India's healthcare infrastructure and human resources. During this period, the number of AIIMS-like institutions has expanded significantly, and medical colleges have nearly doubled, resulting in a substantial increase in MBBS and postgraduate seats. Because this is one area where the number of seats in the country had some limitations earlier. That's why our students go abroad and even to countries which are not so well known for the quality of education. That's because they can't get admission in some of the colleges. Of course, that it's not merely increasing the seats, but we need to have quality of education, quality of faculty, equipment, and so on. But all these we are trying our best to address. This expansion has been supported by reforms such as replacement of the Medical Council of India with the National Medical Commission, aimed at improving transparency and quality in medical education. India's response to the COVID-19 pandemic stands out as a defining chapter in its health sector achievements. Under the leadership of the Prime Minister, India not only built rapid domestic capacity for testing, treatment, and vaccine development, but also executed the world's largest vaccination drive. The development and rollout of indigenous vaccines, coupled with the use of CoWIN digital platform, demonstrated India's technological and logistical capabilities. Through the Vaccine Maitri initiative, India supplied vaccines to over 100 countries, reinforcing the role as pharmacy of the world and a responsible global partner in times of crisis. Because the digital platform like CoWIN, for example, which enabled us to monitor real-time the number of testing, number of cases, number of people vaccinated, and so on, probably was unique globally. And this is a very important element of our digital public infrastructure, including payment system, UPI, and so many other things, which is acclaimed globally. Preventive health care and public health campaigns have also received unprecedented emphasis. Flagship initiatives such as Swachh Bharat Mission have significantly improved sanitation coverage, reducing disease burden linked to poor hygiene. Programs like Poshan Abhiyan, Fit India Movement, and nationwide promotion of yoga have sought to create a culture of wellness. Prime Minister has repeatedly underscored the importance of holistic healthcare approach, combining modern medicine with traditional systems to ensure treatment of illness along with promotion of overall well-being. Together, these efforts reflect a paradigm shift from illness-centric to wellness-centric, from illness-centric to wellness-centric healthcare in India. India has also made commendable progress in several key public health areas. In the field of tuberculosis elimination, the country has intensified its efforts with a multi-pronged strategy involving early detection, improved treatment adherence, and community engagement. India's commitment to TB Mukt Bharat, ahead of the global expectation through Jan Bhagidari and effective action, is a testament to its leadership in public health. In cancer care, significant strides have been made through the expansion of treatment facilities, early screening programs, and integration of cancer care into primary health system. Similarly, progress in reproductive, maternal, newborn, and child health programs has led to measurable improvements in maternal and infant health indicators, focused intervention, better institutional delivery rates, and enhanced nutrition programs have contributed to these outcomes. These achievements reflect a holistic approach combining policy, technology, and human resources to address both communicable and non-communicable diseases. In this context, I would like to say that when we talk about health, it is not merely hospitals, but the effort of at the policy level is to improve wellness, whether it is Swachhata Abhijan or such preventive health and other things. Because health is a very important element, because our economic growth and to become a Viksit Bharat depends on health. In fact, I remember many years ago when I was doing research in UK, that time lot of studies had come out, particularly in the context of economic growth, those days of East Asian countries, China, Korea, Malaysia, Japan and all. And many of those econometric studies showed that it was the human development, health and education, not only investment, capital, labor, that made a difference. And among these two things, health and education dominated the impact on economic growth. So that's why health is extremely important, health on a very holistic perspective. At the heart of our achievements in the health sector, of course, we have to go a long way. One cannot say that everything has been done. At the heart of this achievement lies the dedication and commitment of our medical professionals. Doctors, nurses, researchers, and healthcare workers have been the backbone of our healthcare system, services, and compassion and professionalism. As during the COVID time also, we saw how dedicated healthcare professionals, even the Prime Minister, appealed to the whole country before we started very stringent measures to inspire all the healthcare professionals. Institutions such as the National Academy of Medical Sciences play a critical role in supporting this ecosystem. As a premier body, NAMS has unique responsibility of guiding medical education, promoting research excellence, and acting as a bridge between academia and policy. It plays an important role in keeping the medical fraternity up to date on latest development through continuous medical education programs across the country. In the context of the government's vision for a Viksit Bharat 2047, the role of such institutions become even more crucial. Since its inception, as it was elaborated by Dr. Behera and others, the Academy has played a pivotal role in fostering excellence in medical sciences by promoting high standards in medical education, encouraging cutting-edge research and facilitating dialogue among experts. NAMS has contributed significantly to strengthening the foundation of our healthcare system. The conferment of fellowship and membership by the Academy is widely regarded as a mark of distinction, recognizing outstanding contributions in various fields of medicine. Beyond recognition, the Academy has served as a vital platform for knowledge exchange, bridging the gap between research and practice and between academia and policy. In today's rapidly evolving medical landscape, such platforms are more important than ever. Friends, As we look ahead, one of the most important areas of focus must be medical education. The nature of healthcare is changing rapidly. Advances in technology and the growing importance of interdisciplinary approaches and the increasing complexity of diseases demand a rethinking of how we train our healthcare professionals. We must ensure that medical education is competency-based, focusing not just on knowledge but also on skills and ethics. Focusing not just on knowledge but skills and ethics. Secondly, interdisciplinary, integrating fields such as data science, genomics, and public health. Thirdly, it should be accessible and inclusive, ensuring equitable opportunity across regions. Aligned with national health priorities, particularly primary health care and preventive medicine. Institutions like NAMS have a crucial role to play in guiding these reforms, setting standards, and fostering innovation in pedagogy. We are living in an era where technology is reshaping every aspect of healthcare, from diagnosis and treatment to monitoring and management. Healthcare is on the cusp of a transformative shift driven by futuristic technologies that promise to make healthcare more predictive, personalized, and preventive. Advances in artificial intelligence are enabling early disease detection and precision medicine tailored to an individual's genetic profile. The integration of robotics and automation in enhancing surgical precision and reducing recovery times, and digital twins, virtual replicas of patients are emerging as powerful tools to stimulate treatment before actual intervention. Additionally, technologies such as augmented and virtual reality for medical training and therapy and blockchain for secure health data management are expected to redefine the healthcare landscape, making it more resilient, accessible, and patient-centric. The rapid adoption of modern technologies presents both significant opportunities and complex challenges for India's health fraternity. The new technologies provide a lot of opportunity, artificial intelligence, so on. Not only in healthcare, but we see in education, we see in administration. But there are very many challenges also. How to validate whether it is right, how to validate the error is not there, how to validate that it is the right conclusion, and how to see that there is some human element is also there. These are big challenges, not only in the medical sciences, but also other disciplines as well. In this context, I would like to say that technology must be seen as an enabler, not a substitute for human judgment and empathy. The challenge lies in integrating technology in a manner that enhances care without compromising the doctor-patient relationship. Friends, one of the fundamental principles of healthcare is equity. Every citizen, regardless of socio-economic status or geographic location, must have access to quality health care. Though it is very easy to say, but of course there are issues and challenges in practice. This requires a strong primary healthcare system, adequate human resources, and effective referral mechanisms. It also calls for innovative approaches such as community-based care, mobile health units, telemedicine, and public-private partnership. We must also pay special attention to vulnerable populations, including the elderly, women, children, and those living in remote areas. Friends, as we advance in science and technology, the importance of ethics become even more pronounced in every field, in administration, in other areas, as in medical professions. Medical professionals are entrusted with immense responsibility, upholding ethical standards, maintaining patient confidentiality, and ensuring informed consent are fundamental to this profession. Institutions like NAMS have a critical role in reinforcing these values through guidelines, training, and leadership. Now finally, as we look ahead, I would like to place before this August gathering a set of expectations from the National Academy of Medical Sciences, keeping in view the evolving needs of healthcare sector. First, there is a pressing need for a comprehensive human resource gap analysis in the health sector. Given the changing demographic and epidemiological profile of the country, it is essential to assess both current and future requirements of doctors, specialists, and allied health professionals. NAMS, with its expertise, is well positioned to undertake such an exercise dispassionately. Second, we are at a pivotal moment where artificial intelligence is transforming healthcare delivery, medical education, and research. NAMS should take a leadership role in critically evaluating and integrating AI into clinical and academic settings. This must be done with strong emphasis on patient safety, clinical standards, ethical norms, and professional accountability. In this context, the Academy may also consider developing structured courses and research programs on AI in healthcare, adopting an ethical, legal, and multidisciplinary approach. Third, NAMS must play a key role in leadership development and capacity building. The healthcare system requires not only skilled professionals, but also visionary leaders who can guide institutions, shape policy, and drive innovation. We need good leaders, not only at the higher level. We need good leaders who can effectively manage medical institutions at all levels, sub-district, district, state, and national. As we find, even in large and prestigious hospitals at national and state capitals. Of course, in smaller places it can be much worse. The day-to-day management, cleanliness, and ease of access of patients leave much to be desired. Even very large, very well-known hospitals, they may be having the best of experts, best of doctors, but the access of common man, that I think if somebody comes, how long it takes to have access. These are issues which possibly we need to give more attention. Even with the best of equipment and expertise, the patient cannot get the intended benefits if the system does not function seamlessly. Fourth, the Academy should strive to ensure that knowledge and expertise reach the last mile. The benefits of medical advancement must not remain confined to urban centers or elite institutions, but should extend to the poorest and the most vulnerable section of society. Finally, there is a need for a comprehensive roadmap for improving medical education and research quality. This includes promoting best practices in clinical care, strengthening academic standards, and leveraging India's strength to position the country as a global hub for medical tourism, thereby contributing to economic growth. Because India has a lot of potentials to be a hub for medical tourism, which can also add to our economic growth, employment, and other areas. And to conclude, as we embrace technological advancements, we must remain anchored in the core values of medical profession, ethics, empathy, and service. Technology should enhance, not replace, the human elements in healthcare. The doctor-patient relationship must remain central to all the innovations. At the same time, we must continue to strengthen our public health system, promote preventive health care, and ensure equitable access to quality services. As the National Academy of Medical Sciences celebrates the 66th Foundation Day, it stands at an important juncture, rich in legacy, yet full of opportunities for the future. Government of India remains committed to strengthening the healthcare system and working in close partnership with institutions such as the NAMS. Together we can build a healthcare system that is inclusive, resilient, and future-ready. I am confident that the Academy will continue to play a transformative role in shaping India's medical landscape through knowledge, leadership, and innovation. Let us reaffirm our collective commitment to building a healthier India and realizing the vision of Viksit Bharat 2047. Thank you. All the best.
Thank you so much, sir, for this enlightening and inspiring address. And as sir rightly said, our healthcare system has shifted, geared up and shifted to the next level, where all the think tanks, researchers, scientists, IT professionals, and now the IT AI experts are also working for the betterment of people. Talk about Arogya Mandir, setting it at the grassroots levels in the entire country. Tuberculosis, TB Mukt Bharat Abhiyan, Poshan Abhiyan, Matra Janani Shishu Suraksha Abhiyan, and lot more. The latest HPV vaccination drive, each one of these abhiyans are actually empowering the health. And now the best part is that now not only we are working for the treatment and cure of diseases, but also on preventive health. And on behalf of National Academy of Medical Sciences, may I now request Lieutenant General Dr. P.P. Verma, AVSM, SMVSM, to express words of gratitude.
Good evening, ladies and gentlemen. It's a pleasure to propose the vote of thanks on this auspicious day, that is the 66th Foundation Day of the Academy of Medical Academy of Medical Sciences, the think tank of Medical Fraternity of India. I'm grateful to Dr. P.K. Mishra, Principal Secretary to the Prime Minister of India, a brilliant academician and a researcher, for giving the words of wisdom in this forum. He highlighted all the key issues which the government is doing for India, whether it is Ayushman Bharat, whether it is vaccination for all, and he also told what is expected out of the academy. He laid down 4 or 5 points like leadership building, artificial intelligence, comprehensive healthcare, knowledge and expertise to reach each and every corner, and maintaining a good doctor-patient relationship. I think I can assure you, sir, that academy is already on this lines, whether it's artificial intelligence, whether it is reaching the knowledge to each and every corner through CMEs, and we also are conducting the leadership quality roles and leadership courses here. I think your words of wisdom have been very encouraging, and we have all gained from that. Thank you so much for sparing your time and coming here, sir. I also thank the President, Dr. Behera, President-elect, General Velu Nair, Secretary, Dr. Kapil, who have been laying the roadmap for all these activities for the National Academy, and they have been working day and night, and I congratulate them that they have done tremendous for this Academy, and all the activities what are expected, they have envisaged it before, and they are already acting in this line. I'm thankful to the Council of National Academy and very senior people who are sitting here, Professor Bose, Professor Sareen, we see Professor Talwar, Professor Professor Mehra, and all these dignitaries who are gracing the occasion, and their always inputs, their knowledge and their wisdom always comes handy. Dr. Churamani also, they always comes handy to us. I thank the administrative staff of National Academy, the auditorium staff, the audiovisual staff, and of course, Kiran Bhardwaj, the MC also, who has made this today's function fruitful and healthy. I think as the vision is, as the desire of the chief guest is, the Academy is going to act on whatever the milestones he has set for us, and I'm sure with this leadership around, we will achieve the game successfully. Thank you very much, and Jai Bharat. And I think we all stand for national anthem.
Please play the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे.
Thank you everyone. Today's moments are tomorrow's memories. I would request the Honorable Chief Guest for a photograph so that we can have memories with you, sir. Thank you so much. Thank you.
पूछ लेते हैं. कपिल सर, ये दे देना.